All right, we're going to go ahead and get started, and we're starting with Jenny Weir, our CEO, who is unfortunately not well, and so she is doing her talk from home, but we're really glad that she's able to join us remotely. So we'll start with that.
Thanks, Kristen. Can you hear me okay?
Yes.
Okay, fabulous. And I am so sorry, you all, that I am not there in person. I have a bad case of bronchitis right now, which is not pneumonia on the optimistic side, but it is keeping me home for the sake of public health and for my own health. And really just wanted to welcome you all to our annual Obstetrical Care Outcomes Assessment Program meeting. As Kristen said, I'm Jenny Weir. I serve as the CEO of our Foundation for Healthcare Quality, which is home of the COAP. We've been part of our Washington state health ecosystem since the late 80s, and our mission here really is to catalyze this system-wide improvement by letting those who give, get, and pay for care lead the way within a framework driven by meaningful clinical data, consensus building, evidence-informed best practice, and promising practice. In addition to OB-COAP, we convene communities of clinicians dedicated to quality improvement derived from chart-abstracted clinical data for cardiac care, for general surgery, and for spine surgery, as well as our community birth data registry, the Public-Private BRIE Collaborative, the Washington Patient Safety Coalition, and Smooth Transitions. Obstetrical COAP is really a keystone quality improvement program in Washington state and now in Oklahoma. We owe its existence to the vision of Dr. Ellie Kaufman, and I'd like to just spend a moment, huge round of applause for Ellie for really leading our work in this. And I'm, of course, lucky to be able to work with Kristen, who deserves another huge round of applause for serving as midwife to our work, and you'll have to forgive my metaphors here. I'm also really grateful for our medical director, Dr. Angela Chen, our research director, Dr. Viv Suter, and our advisor, Dr. Barb Levy, and the chair of our management committee, Dr. Amy Van Blaerkom. I also want to thank Amelina Casa for working behind the scenes to make this day happen, and to our whole team at the foundation for really picking up all those loose odds and ends that need picking up for a large event. Change can be difficult and is sometimes slower than we would like it to be. Progress in birth equity can be so slow it can seem non-existent. Before I turn the stage over, I wanted to spend a moment on one of my favorite quotes. In December 2016, activist, lawyer, and sick faith leader Valerie Carr asked this question in her prayer for America. What if this darkness is not the darkness of the tomb, but the darkness of a womb? What if our America is not dead, but is a country still waiting to be born? What if the story of America is of one long labor? Remember the wisdom of the midwife. Breathe, she says, then push. And with that in mind, Kristen, I'm going to turn the stage over to you.
Thanks so much, Jenny. I feel better. So thanks everybody for being here. We've got a nice in-person audience. We also have a number of people online, so hopefully you can all hear well, and your questions can go into the chat box via Zoom, and we'll take those and do those out loud when they come in. So thanks everybody for being here. And I really want to thank our supporters of the meeting this year, Physicians Insurance and Hologic with the Rapid FFN product. We really appreciate your support, as well as the folks from JADA and Natera and Bloodworks Northwest and the perinatal psychiatry consultation line. So please visit them in the breakfast room, and we'll get your little cards stamped for the raffle. Just briefly, a little bit about the CME. So make sure that you have signed in on the CME papers in the registration desk, and fill out your evaluation. With the QR code is on your table. So just make sure you've done that. And once you've filled out the evaluation online, we'll send you your, the CNE certificates require that. The CME certificate, you're welcome to pick up one of those on your way out today or anytime at the registration table. And there's 7.8 nursing contact hours and 6.5 CME hours. Just a reminder that the work that we do here is confidential work as a quality improvement program, and it's all protected under the RCW of Washington State as a coordinated quality improvement program. We are recording the meeting so that we'll have this to be able to listen to afterwards if you want to go back and listen to any of the presentations. Please use the microphones if you're asking questions. Even if you have a loud voice, they can't hear you online if it's not by microphone. And again, if you're virtual, go ahead and put your questions in the chat box. No speakers have any disclosures. There's a summary document in your file, but everybody has completed those. And we won't be doing full in the interest of time. Everybody's bios are incredibly amazing, and we don't have time to go through them all, but the full bios are in your speaker materials that we sent you out online. So please take a look at those. And we also really ask that you complete the evaluation following the meeting, because we do look at those and appreciate your input to make these meetings better each year. And lastly, make sure you visit those vendor and supporter tables to get your card stamped, and then put that in the basket. There's a little wooden box at the registration table, so put those in there by 4 o'clock, and you'll have a chance to win a $500 Alaska Airlines gift certificate. And then hurry back at the end of each break. Dr. Carl Olden has generously provided some wine for a wine raffle, and so you got to be in your seat to get to be able to win. So get back here after the breaks. And with that, I'm going to turn it over to Dr. Amy Van Blaricom, who is the Chief Clinical Officer for OB Hospitalist Group, where she leads their clinical engagement and clinical operations. And she also serves as chair of our management committee. So, Amy?
The down button? Okay. Good morning, everybody. Let me now put a face to our OB COAP team. So at our base, we are a quality improvement program, a nonprofit organization made up of a very diverse set of hospitals in volume and acuity, and managed by a similarly diverse management committee. These are our participating hospitals, and we use chart abstracted data, which any of you who work in clinical research and data understand that chart abstracted data is so much better than billing data, which is what most of the clinical quality improvement studies are based on. So this is very clean data, and it is an amazing mountain of data that we collect from these very diverse participating hospitals. So we're very, very grateful to them for contributing their data, but we can always use more. So all of you hospitals out there in the Pacific Northwest who are not already participating, if you would like to have a conversation about how you could not only contribute your data to our cause, but also participate in some of the research that is happening, our data allows us to drive quality improvement across the region. It allows us to drive educational opportunities and ultimately impact and change. So our management committee is made up of representatives of all aspects of healthcare for women. We have clinicians across the maternity specialties, so including OBGYNs, including MFM, nurses, midwives. We have consumers on the management committee, which offer a very insightful aspect of feedback, and that's very important. We have representation by payers, large employers, professional organizations, and we gather regularly to give feedback on the data that we've collected and consider where additional research opportunities lie with the data that we've collected. You're going to hear about an awful lot of that today. So this is our executive leadership team. I'm not going to go through the whole list again because both Ginny and Kristen discussed and offered up these names, but this is the power group right here. This is where the magic happens. And we manage a larger management committee, which I'm not going to go through the whole list here now, but if any of you are in the audience, if I could ask any of the representatives of the management committee to please stand so that we can recognize you and thank you for your ongoing efforts. Thank you all so much. So I now have the pleasure of introducing our first speaker. Angela Chen is the medical director for OB-COAP. She is known to all of you. In addition to continuing to provide patient care at several hospitals in the area, Dr. Chen is very involved in quality improvement work at the local, state, and national level, both through working with Team Birth, and you're going to hear about that work today, the Washington State Maternal Mortality Review Panel, and as a peer review consultant. So I'm going to invite Angela up, and then she will introduce her co-speaker, Amber Weiss.
Morning, everyone. The down button moves the slides. So thank you for that, because otherwise I might have been here for a while. So I've been relegated to glasses now, because otherwise the font would have to be so big on my notes that I'd be flipping papers every minute. But I am really honored to introduce Dr. Amber Weiss. She's a research scientist at the Harvard T.H. Chan School of Public Health and the director for the Delivery Decisions Initiative at Ariadne Labs. She is a labor and delivery nurse initially, and she has really gone on to do amazing things. Most of you know her well from the work that she and her team have been done in the state, bringing Team Birth to all the rest of the maternity facilities. She has been a longtime supporter of OB-COAP, serves on our management committee, and she's going to share a little bit today some of the qualitative data that we've seen in Washington from Team Birth. So Amber, are you there? Oh, there you are. Hi.
Hi, Ange.
She's at A1. Oh, we're coinciding with the big A1 conference. We did not know that we were coinciding, so I think that's made it hard for a lot of our nursing leadership folks to be here. But hi.
Hi, can you guys hear me okay?
Yes.
Yes? Okay. Unfortunately, I can only see Angela. I don't have a view of the rest of you all, but I can imagine all those friendly faces out there in the audience, and sad to not be in person. I'm going to miss out on Carl's wine and a potential flight on Alaska Airlines, but maybe next year. Let's go and advance the slides.
Oh, that's me. Okay.
Oh yeah, that's Angela. Thanks, Ange. Okay, go ahead and go one more. So I'm going to be giving a project update on the implementation of Team Birth across the state of Washington. And similar to Amy, I want to start out by calling out my team because none of this work could be made possible without all these incredible individuals. This is a snapshot of the larger Delivery Decisions team, but I do want to call out the folks that are really supporting this project in depth in Washington. So primarily Misha Severson, Lindsay Renner, and Kaya are your main coaching, data, and implementation teams. So they're meeting with the sites each and every week. Joyce Edmonds is supporting with the research, and then Dr. Angela Chen, yours truly, is also supporting with some of the implementation efforts. So if you go to the next slide. So this project is in collaboration with WSHA's Safe Deliveries Roadmap. So we've partnered through funding from the Ballmer Foundation to implement Team Birth across the entire state. So really we're aiming to improve both outcomes, so safety, but also equity and experience for patients in their births. This project, we planned 4 cohorts across the 54 hospitals. And you can see some of the very high level research aims, although we will go into that much more in detail in just a minute here. If you go to the next slide. This is a map of the hospitals that are in the implementation process for right now. So the cohort 1 hospitals are in orange, cohort 2 you can see in blue, and then the purple is cohort 3. We are starting to enroll cohort 4 right now. I think we've got about 6 or 7 hospitals signed up. You'll notice that that's not all of the state of Washington. So we're right now doing some planning with WSHA, whether we're going to offer a 5th cohort or somehow squeeze them in, because we really do want this initiative to be available for all patients, no matter where you choose to give birth. So if we go to the next slide. Here you can see the names of the individual hospitals, and we've got a few that are launching soon. Forks, they're hoping to launch. They're so ready, but they're closed for OB services right now, so they're just waiting to see if they can get the go-ahead, but they are ready to go. If you go to the next slide, I wanted to give you a snapshot of some of the boards and all the hard work the teams have been doing. For those of you that aren't as familiar with Team Birth, it's a series of conversations that have a structure to them. So we call those huddles. And the huddles, what's discussed is then put onto what we call a shared planning board or a dry erase board. Although we have discovered that the word huddle is a little bit of a hot topic or a hot button in the state of Washington. I think people feel maybe there were too many huddles that occurred during COVID. I'm not so sure, but some of the teams are calling them check-ins and other things because the huddle word strikes fear among too many. But you can see these are some of the board designs, and you can see these represent critical access hospitals, LDRPs, as well as large academic centers. And that's part of our implementation process, is that we're working with a basically core set of design principles, and then the needs and the individual context of the hospital to make sure that it's adapted to something that can work in every L&D and postpartum space. Go to the next one. Going to do a few just little highlights of some of our launches. So this one was a launch at UW Valley that took place just a couple months ago. And it was very notable because it was the first launch event where the team did a skit. So you can see on the top right, this was a nurse and a physician and midwife all doing a skit together. And our patients even had her water break as a part of the skit. I think they had a water balloon, but it was quite a very fun event. You can see they have some party planners. So if you need to plan a party, UW Valley is who you're going to want to call. If you go to the next slide, this is going to be from St. Peter's, Providence St. Peter's, and they were one of our sites to launch in cohort 1. And what I wanted to draw attention to in this slide is if you can see on the top right, I don't know how big the screen is for you guys, but that's a board that's been adapted for triage. So they're one of our first sites to really integrate this into their triage communication and documentation plan. So you can see they're sort of an abbreviated board. But all of the teams have really been so thoughtful in planning their launch events. Definitely, we have seen so much creativity come out of Washington State. If you go to the next slide, we've also had the opportunity to partner with Smooth Transitions and Health Commons to develop some community-facing materials. So similar, I mean, you guys all understand this, but what happens in the health system is only a portion of an entire health journey or health outcome. And so we feel it's really important that once we have Team Birth established in that hospital, that we can then back away or back up into the community to get it really ingrained and integrated in all spaces that touch maternity care. So this has been an opportunity to design specific doula-facing materials. So not only are doulas aware of Team Birth, but the hope is that they're more empowered, that they understand they have a role when they go into those facilities to support a client, that they feel empowered to grab that dry erase marker and to be a full member of the care team. So that's been an incredible opportunity to really design some of these materials that we're starting to test. If we go to the next one. Okay, back to creativity in Washington. Wanted to just call out many of your hospitals have been creating their own training videos. So these are your everyday clinicians that are also taking up the role of being an actress or actor to help provide materials for their staff. So there's been incredible creativity, like I said. If you are in a cohort to come and you haven't quite implemented, don't worry, we will give you all of these resources when it comes time. But let's go to the next one. And then just a couple months ago, we were able to hold a statewide workshop. And so this was hosted at UW Montlake. We had over 100 people come from across the state. You can see in that bottom right, those little green dots represent participants. And we even had some folks from Oregon and Idaho. And we shoved everybody in a way too small room, and we just team birthed all day long. And it was an incredible opportunity to not only for teams to learn what they need to know to go back to their facility, but to share learning, to share, we have some of the same challenges, and to share ideas on how to solve them. We also were able to have a virtual panel where we had a provider from the Cleveland Clinic who joined, as well as some of our Team Birth OGers from the pilot, as well as some of our newly implemented hospitals to share advice and what worked for them. So it was a really great community event that was hosted by WISHA and by UW Montlake. We do plan to do more of these, so if you are interested in coming to one, don't worry, there will be other options. If you go to the next slide, okay, let's start talking some data. Go ahead, Ange, you can go on more. So really, I only have time to give you a small smattering of data, but again, we're early in the data collection. As I said, some of our sites are just getting ready to launch. And so maybe this time next year, we can present a more full like research and progress look at the data. But I want to start out with just a few snapshots of questions that we've been keeping our eye on. So here's one here where it says the clinical team asks for my permission before carrying out exams and treatments. What the color gradient is responding to basically the level of agreement or disagreement. So the color we want to see the most of here is the dark blue. What we don't want to see is that dark red. What we notice here in Washington State, as in other states that we ask this question to, we do see an increase in patients who respond that they feel like they were properly consented. What is interesting, and something I think we need to learn about more, is why none of the time that 7 to 8% stays the same, regardless of whether they had teen birth as a part of their care or not. So interesting to see this increase, but also more to learn about that particular population, why we're not seeing any movement there. If you go to the next slide. So similarly, this is a question around pain, and why we chose to add consent and pain questions is in a lot of the other previous research, especially on inequities in healthcare or obstetric racism, pain is a theme that comes up as being not properly addressed, especially in Black women, as well as consent. So that's why these questions are pulled out separate. But you can see, although teen birth isn't really focused on pain management, it's not part of our training, it's not part of our goal, you can see that more patients feel very strong agreement that the clinical team did everything they could to manage their pain if they experienced a teen birth huddle. So interesting trend there as well. If we go to the next one. So I think part of the richness of this data, and Angela will talk more about this in a minute, but yes, those quantitative questions are really great, but also there's so many questions behind them to really truly understand it. So we do collect a lot of qualitative data, and the patients here in Washington, they write these paragraphs more than any other state. We have patients that fill out like multiple paragraph essays basically about their experience. So I wanted to pull out just a few quotes here. I like this one in the middle, that they truly made me feel heard and valued, that my preferences were well talked through and understood. People feel seen, and which builds the trust that they feel towards the health team. So if you go to the next one. So here are a couple of questions from the survey tool MADAM. So that's Mother's Autonomy and Decision Making, which was developed at the University of British Columbia. So this particular survey tool is 7 questions. We have implemented this across the whole state of Oklahoma, and we're just working on that manuscript right now. We do see statistical significance with increase in MADAM scores. And actually with MADAM, what's interesting is the highest increase we actually see for the non-Hispanic Native American population. But here are the same questions pulled out for the Washington data. And you can see in both of these questions, we see an increase in that level of agreement when people are experiencing a teen birth huddle versus they're not. And if you go to the next slide, you'll see all of the questions. It's a little bit busy of a slide, but what you'll see is the trend is the same across all on the question level. The level of that completely agree or that strongly agree goes up. Now, what you're looking at here is the full state data. So we've aggregated everybody's data together. We've got about 300 patients that are not experiencing the intervention and about almost 500 that are. But I want to show you an individual hospital's, an example of their dashboard. Now we collect a ton of data, and then we send them monthly or bi-monthly dashboards depending on their delivery volume, so that they can understand how they're performing compared to the whole state and what their opportunities are. So I took off the numerator and denominator because I wanted it to be truly anonymous. But you can see here, this is an individual site based on those same questions we just looked at. And you can see this hospital in particular has a lot lower scores of agreement when it comes to those who do not have a teen birth huddle. We do see variation across the hospitals. And interestingly enough, Angela, will you go backwards one just for 1 second? When we look at this data across the country now that we've been asking these same questions in multiple states, we do see difference. And on average, the Washington state respondents do report higher autonomy compared to Oklahoma, which I told you we're going to be publishing on, and actually our lowest autonomy we're seeing coming out of New Jersey. So really interesting to see the geographical differences. And at first, I was kind of like, well, this is really interesting about Washington. And then I thought, well, you know what? I'm not surprised. From being a Washingtonian who now works across the country, I know that working in Washington, living in Washington, being a maternity patient in Washington is a privilege. The healthcare quality in the state and the amount of collaboration and quality improvement with groups like COAP and with WSHA is unmatched in any other state. So you are unique. Your patients are on average reporting much higher levels of autonomy, and then they're still even benefiting even more from the intervention. So you can go forward 2 slides for me, Ange. And just wanted to end on a couple more quotes here because they're so great. And they're, when our team reads them and we get to send them back to the hospital teams, it's like feeling like you get a hug because so much in healthcare can kind of, I don't know, it can feel like negative or really hard, as you guys know, that are leading quality improvement. And reading these patients' quotes makes it feel like, okay, I can keep doing this. It's all worth it. So I will just read this bottom one that's in orange. This patient said, "We loved the huddles and we felt very involved and respected in the decisions that were made." Like that's our goal. We want our patients to be safe, but we also want them to feel seen, to feel like they had autonomy in what happened to their bodies and in their birth story, and that they leave the hospital feeling respected. Because our hypothesis and what we're hoping to study in the future is that those patients have a greater trust in the health system and are more likely to come back when they're not feeling well, when their blood pressure's up, and hopefully can make a dent in some of that postpartum morbidity and mortality that really we haven't been able to sort of crack across the country. So click one more time, but I think that might have been my last slide. Yes. Okay, so back to you, Ange, to talk about going forward.
I know, moving forward. So thanks, Amber, for showing that preliminary data. I always get excited when we look at teen birth data. I think because Evergreen and Overlake, we are the super OGs. We were part of the pilot, and I think our success with teen birth allowed more interest in the state of Washington, and with WSHA's support, we're able to get that going. So in talking about data, Dr. Van Blaricom, she already set up the stage really well. OB-COAP is different. We are a data registry, right? This is chart abstracted data from each patient record at our participating sites. This is incredibly robust data. We understand there is some data burden, but there's magic in technology now to where, like, I don't know, there's some flat file where we can import things directly from an EMR into the database. So we anticipate this data burden is going to become less. You know, there's something called AI that might help. I don't know, it's kind of above my knowledge base. But the point being that getting this robust data, we think, is the key to really continuing with meaningful quality improvement, right? It's looking at what really happened to the patient, just not what the hospital got paid for. So when we look at this qualitative data, right, we talked a lot about like how important patient experience is. We all acknowledge that probably 1/3 of patients have significant birth trauma, and we don't really know, how to remedy that, I don't think, because we don't have the right data. So we talked a lot about, how do we link the data? And it seemed like, well, that might be kind of hard to do. But we actually kept pursuing it to decide how can we link patient-reported experience with the clinical outcomes that we capture in OB-COAP. So this is this is sort of the project that we proposed, right? That we were going to figure out, we've already built this into the database where we have a way to link through email addresses and phone numbers, patient experience survey information with their directed clinical outcome. It would really give us wonderful new metrics that we could potentially look at. Because what if it's more important that the patient had an amazing birth experience than it is whether that baby came out through an abdominal incision or vaginally? Because really, right, what are we measuring? What's really important? So we're really excited to report that we have received a 3-year grant from the Balmer Group. So we are now funded to pursue this work. The Balmer Group also helped to fund rolling out teen birth through the state of Washington. So they recognize the value of the intervention of teen birth. And I think the beauty of OB COAP, we are able to track team birth huddles. We have that built into the database, so we know exactly which patients had a team birth huddle, how many they had, and now we'll be able to link it with what was their patient-reported experience. So we are partnering with Twistle. I guess I think of them as a subsidiary, is that the right word, of Health Catalyst, who is the mothership of where our data is housed. So they have already done some of this patient surveying. I can show you an example of what they've done. Oh, this is so cool animated. So this is sort of an example of a Twistle built survey. It will go out to patients by text, and it will just allow them to pretty quickly answer these questions. And then that will, by some IT magic that is beyond me, but it will get hooked to the OB COAP database. I think we recognize the challenges, right, in getting patient surveys answered. We all get a lot of them. But I think this comes down to when patients come in to deliver with us, that we tell them, you'll have an opportunity to really tell us how this experience was for you. And I do think texting, I don't know what generation I am, if I'm Z or X or whatever, but texting surveys seem to work better for me than email, and for sure better than paper. So this is coming. And it really gives us an opportunity to really look at our data differently and really look at the impact of interventions like team birth and also interventions like having a doula present at labor. We are able to capture that in the OB COAP database. And I can say there's probably no administrative database that is going to be able to do that. So we will be looking forward to developing new metrics. We will be reaching out to our partners, to the sites who are participating in OB COAP to really say, how do we want these metrics to be built? What do we want to look at? So here's Isabel Griffith. She's coming to us. We're borrowing her from the DDI team. She's going to be the project manager of this upcoming project. So watch your emails, because this is exciting. I feel like this is very groundbreaking. No one else is doing this. And we got very good funding and very excited. So Isabel is online. So. Oh, hi, Isabel. Are you here?
Hello. Yes. Can you hear me?
Hi. Hooray.
Hi.
Hello. We don't see you, but we hear you. So welcome to Washington virtually. And we are very excited about this project.
Thank you so much. I'm really looking forward to it. I can't turn on my video, but I think you can see my photo there. Should I give any other introduction? Would that be helpful?
Well, Twizzle will be in Spanish. Will those texts be in Spanish?
Yes, Twizzle will be in Spanish. Yeah, Isabel, would you want to give us a little bit of background about yourself?
Sure thing. Sorry, I can't have my video on. It looks like it's not enabled or something. Let's see. But I can go ahead. Yeah, just a little introduction. I'm really excited to be here. I feel like I've been learning a little bit about this project, and it just feels so innovative and exciting and necessary. I am just wrapped up my MPH at UNC Chapel Hill, focusing on maternal, child, and family health, and going to be joining the team birth team and Ariadne Labs this July. And yeah, I'm just really excited. I have a background in mixed methods research. I'm also a birth doula, so I kind of come at this work from a bunch of different lenses, with methods, with sort of direct client care experiences as a doula, and also as a project manager, and helping to sort of ensure that these types of projects run smoothly and we can be as successful as possible. So I'm really excited to get to know everybody and join this very exciting project.
Thank you. Is there anything in the chat? I don't know if I can. Oh, there she is. Hi, Isabel.
Hi.
Is there anything? Do I need to look in the chat? I just see.
There was a question, will this also be available in the CBDR for clients who transfer to the hospital?
Well, if they transfer to the hospital, yes, they will. It won't be in the CBDR, but we'll be able to link that CBDR data with their hospital data. So yes, is that accurate, Lara? I mean, we'll know the link between the community birth data and the hospital data. Yes, if they've transferred to an OB-COAP participating hospital, yeah. Sorry. CBDR can still have projects that utilize the TWSL application down the road. We'll get there.
I have a question for Amber, which is, can you talk a little bit about the closing of the QI loop with Team Birth? So you give dashboard reports to the hospitals, and then if there is work to be done in terms of autonomy and consent and stuff, does Team Birth get involved in working with the hospital about improving their outcomes?
We do. I would say it's more informal in the sense that from our purview, really what we can do is we can coach, we can provide recommendations and resources, and then we can hold people accountable as we continue to look at the data over time. I think one of the most powerful things that we see in the data is that as we've all been learning about bias in healthcare, pretty much everybody in this room, those of you that are clinicians, would say that you give good care to your patients and you give the same care to everybody. And until you really see your own hospital's data, and we do look at everything by race and ethnicity with our individual data reports, until you see that data where there's a really clear disparity that's existing, it's really easy to scapegoat and think that it's not me, it's that other hospital down the street, or it's the east side of the mountains or whatever. And so I think the power in the data is that people then have the opportunity to confront the challenges in their health system and that they have data behind it. So it's not just feelings. I think with this new particular project, this might feel spicy to some people, but you will be able to look at this data by experience, by provider, which I don't know, is probably a hot topic for another day, but it will be an important level of transparency as we're trying to understand how patients experience their healthcare journey. So I know that was a little bit of a roundabout answer. Yes, we do. We continue to measure it. We continue to provide resources and coaching, but we're not on the ground in the same way as being in the facility.
I like the word spicy because it is a hot topic. You know, I think it's hard for hospitals and providers to get that level of data that will really show that the patient-reported experiences may be different for patients who look different or come with different lived experiences. So spicy, that's going to be the word I use.
Yeah, Angela, I just wanted to add to the comment about the CBDR and patient experience. That when there's a transfer that happens to a non-OB-COAP hospital, often, well, Smooth Transitions is working with more and more hospitals around the state, and so there's opportunity for that patient experience of care to be given through our surveys, which are also using the UBC, Madam Mori, and some trust scale information questions, and we have Team Birth questions and just general huddle questions as well. So a lot of our data that we're getting on transfers looks just like what Amber posted from patient experience. So we're kind of capturing it in several methods, I feel like. So even if it's not an OB-COAP hospital, we're capturing that data. And it is spicy, that feedback. We're in that space and working towards developing some protected review processes that will hopefully help to address some of that equity and bias that we're definitely seeing and is hard to deal with.
Yeah. Well, and this is a 3-year project, but this is not something where at the end of 3 years we would anticipate not continuing. I mean, this is going to be really important data, and we've dreamed big. Amber and I have talked about, wouldn't it be amazing if we could somehow get HCAP to just look at the data we could capture through TWSL, right? So, okay, let's see. Are there any more chat? Is there one more chat?
Yeah, there's a question from the chat that says, are you also going to be diving more deeply into the question of why the strongly disagree numbers seem to stay the same without and with a huddle? Have we looked for a correlation with past birth trauma or prenatal events controls?
Yeah, we definitely are interested in looking at that. We looked at that particular subpopulation across the state of Oklahoma, and we didn't see anything correlative about them. So it tends to be a fairly small sample size. I think in this Washington project, because the birth volume is so high and we have much more balanced cohorts around the no teen birth versus yes teen birth, we are going to be able to look at that more with statistical interest. One thing that we did see, and this again, I'm going to go to the Oklahoma data. One thing we did see was that patients who reported complications, so that's our subgroup, had complications in their birth or postpartum. If they had a teen birth huddle compared to those that did not, that was the largest increase in autonomy scores over all of our separate subpopulations, which I think was really interesting, that people who had complications that they did not have their sort of ideal birth, if they had huddles, they came out feeling more empowered and that they had more autonomy than some of our other groups. So there's more to learn here. It's definitely a priority because we really want to move the needle in that group who doesn't seem to be getting impacted by the intervention in the same way.
All right. Well, I think we're going to move on to the next topic. If there are other questions, you can throw them in the chat or come find me. I will wax poetic about teen birth, OB COAP, whatever you want. I will keep talking. I have the pleasure now to introduce Dr. Vivian Suter. Many of you know her. She's the Director of Research for OB COAP. She's been doing that for us for almost a decade, and she was the Medical Director from 2019 to 2021. She's now working as the Medical Director of Women Health for Natera, which is a clinical genetics company. But we're really indebted to her for all the work she has done to put your data to good use, and it has resulted in really several meaningful publications. But I'm going to let her come up here and talk about steroids.
Thank you very much, Angela, and thank you for allowing me to be involved in this session today. So the session is on antenatal corticosteroids. You may be asking, why are we talking about steroids? We've been using steroids for 40 years. We've got it covered. However, in the last few years, there have been some developments with steroids. We've seen the publication of the ALPS trial, and as a result of that, we're not only using steroids in patients who we anticipate may deliver before 34 weeks gestation, but we're also using steroids in the late preterm period between 34 and 36 weeks. And this, as we can see from our OB-COAP data, has resulted in a big increase in the use of antenatal steroids. In addition, in the last few years, there's also been a growing body of literature which has started to kind of raise the potential that using antenatal steroids, particularly in patients who go on to deliver later in pregnancy at term, may not be entirely safe. And there could be some long-term effects of steroids in these patients. As a result of that, and the other thing that we've actually kind of become aware of is that the most effective way to give steroids is if they're given in the week preceding the time of delivery. And as all of you know, predicting the time of delivery is really difficult. But giving steroids outside of, that week before delivery may be associated with a decrease in effectiveness and exposure of the babies if they go on to deliver at term. So reflecting these concerns, in 2022, the Society for Maternal Fetal Medicine published a special statement called Quality Metrics for Optimal Timing of Antenatal Corticosteroid Administration. Now, thanks to the foresight of Dr. Ellie Kaufman, OB-COAP has collected data on antenatal steroid use since the outset of the collaborative. And since 2016, we've also collected data on the timing of antenatal steroid use in relation to the time of birth. And as a result, we're probably one of the very few places in the States that can actually look at the metrics that Society for Maternal Fetal Medicine has recommended for antenatal steroids. So let's have a look at the 3 quality metrics that are included in the OB-COAP dashboard. So I'm going to just quickly orientate you to the slides. On the left-hand side of the slide, you'll see the quality metric, and in this case, it's antenatal steroid use at any time prior to the birth at 23 to 34 weeks gestation, or 36 and 6 days gestation. And it includes all live births. And then if you go to the graph at the bottom right, you'll see along the x-axis a number of the hospitals that we have data on along the x-axis. On the y-axis is the percentage of early preterm births, 23 to 33 plus 6 weeks gestation, where they received antenatal steroids at any time before birth. You can see the point estimates, which are the little dots, and then you can see the confidence intervals around these point estimates. So what you'll see is that the percentage of early preterm births that received antenatal steroids at any time actually ranged quite dramatically between the different hospitals. At the very top in the graph there, you'll see on the x-axis quarters from Q1 2021 to Q4 2023. You can see the kind of change over time. And in fact, there really hasn't been a lot of change over time in the use of antenatal steroids less than 34 weeks. Overall, for the collaborative, just under 80% of all patients who delivered in that early preterm period got some kind of antenatal steroids. The next metric equates to one of the 2 SMFM quality metrics, and that's the percent of early preterm live births that received antenatal steroids within the 7 days preceding birth. So this is optimal steroid use. Again, at the bottom, you'll see that there is really quite a wide range in the percentage of babies that actually, or patients who received antenatal steroids optimally. But overall, it's only about 50% of the early preterm births. So about 80% of preterm births, early preterm births got steroids at some time before they delivered, but only about 50% got them within a week. And again, if you look at the very top, you'll see that that really hasn't changed very much over time. Now, I mentioned that there has been some concern about patients who receive antenatal steroids and then go on and deliver at term. So one of the other SMFM metrics is the percentage of patients who received antenatal steroids and then went on to deliver at term. Again, looking at the bottom graph, you can see that that ranges anything from 10% of patients who received antenatal steroids then went on to deliver at term to over 50%. So, you know, we are probably the only group that can look at this, but it is interesting that about 20% overall of the patients received antenatal corticosteroids actually delivered at term. So we have 2 talks coming up related to antenatal steroids. Our first is from Dr. Andrew Combs, who actually was one of the co-authors on the SMFM quality metrics document. He's actually going to, we're going to play a recorded video from Dr. Combs. Dr. Combs is a maternal fetal medicine specialist at Pediatrics Medical Group, where he is the senior advisor for MFM quality. In this role, he's involved in quality and safety improvement efforts for 31 MFM practices across the US. He was a founding partner in Obstetrics of California, where he practiced maternal fetal medicine for 29 years. And so we're going to hear from Andy and his recorded video. do I have to press the button here, Kristen?
Good morning, everyone. It's a pleasure for me to be here to share with you some ideas on optimizing our use of antenatal corticosteroids. I have no conflicts of interest related to this topic, but for CME purposes, I need to disclose to you that we're going to be talking about the off-label use of medications. Betamethasone and dexamethasone are actually not indicated, according to the FDA, and they're listed as pregnancy category C for fetal lung maturity and for antenatal use. However, their use is evidence-based. We're going to be covering some quality gaps on our use of steroids, and that's first that many newborns born before 34 weeks have not received antenatal corticosteroids within the optimal time window. Furthermore, we don't know what the optimal dose is, and when used late preterm after 34 weeks of gestation, the pros and cons can be debated. So our objectives today will be to describe some challenges that we have in optimally timing corticosteroid administration and to summarize what's known about the optimal regimen for corticosteroids and to list some pros and cons of late preterm antenatal corticosteroids. I have to thank Dr. Sarah McDonald from McMaster University for this brilliant idea, which is to use the stoplight to indicate by just a simple color scheme harmful interventions where the evidence shows that doing something is harmful in red, benefits shown in green. And amber doesn't show well on white background, so I just use gray or black to show interventions where there's no significant change between the groups. So everyone knows that early preterm birth is associated with some serious newborn complications ranging from respiratory distress, which is most often self-limited and reversible, but intracranial bleeding, which can lead to cerebral damage, necrotizing enterocolitis, childhood developmental delay, and death. And the evidence shows from a most recent Cochrane review on the subject involved in 27 randomized controlled trials that antenatal corticosteroids result in significant reductions in all of these, with the evidence ranging from moderate to high certainty for each one of them, and the benefits including ranging from a 22% reduction to an over 50% reduction, depending on which particular harm is being improved by antenatal corticosteroids. So the Joint Commission was concerned that we weren't using steroids often enough in these early preterm births, less than 34 weeks of gestation. And so in 2012, they introduced a quality metric, PC03, that had to be reported by all the hospitals that had a Joint Commission accreditation if they had more than 1,100 births per year. And by the end of the reporting period, by 2017, they'd actually dropped that number to anyone with over 300 births per year. And the short version of this quality metric is you basically just count the moms that gave birth between 24 and up to just under 32 weeks of gestation, and you counted those in whom antenatal steroids were initiated and just reported the percentage. There was an exclusion if there was a documented reason for not giving steroids. And the results of this quality metric were summarized in the Joint Commission annual report. Within a few years, the use of antenatal corticosteroids in Joint Commission hospitals rose from a baseline of around 80% to almost 98% by 2016. So hooray, they accomplished something here, mission accomplished. They demonstrated that some improvement in the use of steroids was possible, that with the use of a quality metric, you could encourage providers to change their behavior. And furthermore, at 98%, there was very little room for any further increase. And so they retired that metric effective 2020. But there's some problems with that Joint Commission metric as they posed it. First was that you could exclude a case from the denominator if you stated in the medical record any reason for not giving steroids. So, for example, if you put, we didn't have it in the pharmacy, they ran out, that would exclude the case. And that's obviously a huge quality problem if you don't have an adequate supply of steroids in your pharmacy. And if you documented some reason that wasn't valid, well, we expected delivery within 24 hours. Well, ACOG actually says there is some benefit within 24 hours and you should give steroids at that time. Or you can have some just mistaken belief about, well, I don't think steroids work in female fetuses or twins or preeclampsia or whatever. So even if your reasons weren't valid, the cases were still excluded from the denominator. And this is probably the reason why that we were reporting, hospitals were reporting 98 to 100% on this metric, even though as Dr. Suter's data showed in the state of Washington, you were at 80% or so during the most recent years. It's not that the state of Washington was doing badly, it's that her data was showing you cases that didn't exclude cases from the denominator, whereas the Joint Commission excluded cases for these reasons, which may or may not have been valid. Most often they weren't valid. Furthermore, there was no balancing metric in this PCO3. So basically what they did was encourage you to just give steroids to everybody, whether they were really going to deliver preterm or not. And so even if they delivered at term, you still got credit for it. And it led to this belief that, you know, you should just give steroids early, give steroids often. Steroids are all benefit and there was no associated risks. That's the belief that many of us had. Furthermore, there was no consideration in that metric between the interval between antenatal corticosteroids and the time of birth. If you gave mom steroids at everybody 24 weeks of gestation, even if they weren't in labor and even if they weren't threatening delivery at that time, you would get credit for that metric. But steroids are obviously not likely to be effective if given several weeks or months before birth. And it seems that they're probably not effective if given just minutes or seconds prior to birth. So, well, it's really important to consider that timing. And if we're going to optimize our use of steroids, that timing is really critical. So this comes from an older Cochrane review that looks at the reduction in these various severe outcomes, RDS, intraventricular hemorrhage, and perinatal death, as a function of the time between administration of the first dose of steroids and the time the baby was born. And most of us have this idea that, you know, the optimal window is 48 hours to 7 days, 2 to 7 days is the optimal window. And that's largely driven by RDS, which is one of the most common outcomes, but not the most serious. If you look instead at intraventricular hemorrhage, the best reduction in that outcome comes with steroids given with under 48 hours, and perinatal death, the benefit is actually demonstrated statistically significant in under 24 hours and persists at under 48 hours. And although not statistically significant in these meta-analysis, based on relatively small numbers, the benefit persists for up to 7 days. But beyond 7 days, none of these really shows much benefit in these randomized trials. So when recent studies have looked at how often are steroids given with optimal timing, and what you can see is in study after study from all over the developed world, including North America and Europe, the rate of optimal use hovers somewhere under 40% and certainly under 50% in center after center, sometimes multi-center studies, sometimes single center studies, and that very often the steroids are given too early and these patients deliver much later than that 7-day window, and is in fact a substantial fraction delivering at term, and sometimes given too late where the timing is less than 1 day, but that still fits within ACOG criteria. So the question is, why are we doing so badly? And the answer is that although ACOG says that you should give steroids to anyone who's at risk of preterm delivery between that 24 weeks and 34 weeks, if they're at risk of delivery within 7 days, they should get steroids. But the problem is, how good do we have a crystal ball that where we can really predict who's going to deliver within 7 days? And the answer is, it's a really complicated question. There's many, many variables that we have to consider when trying to time the steroids adequately, including for those patients threatening preterm birth because of preterm labor or ruptured membranes, or what's the cervical length, how often are they contracting, are they changing over time, is it fibronectin positive, did they have things like bleeding or ruptured membranes that would increase the risk, singleton versus multifetal gestation, any signs of infection, any comorbidities. You know, oftentimes our premature births are driven by hypertension, et cetera. Do they have a prior history? And trying to do this calculus in our head is really complicated. And there's no simple solution that we can say, well, if they have this or that, they're going to deliver within 7 days, or they're not going to deliver within 7 days. So that's the problem with timing. This slide summarizes a couple of studies that are very similar, one from Canada and one from the US, relatively large numbers of patients who actually delivered preterm, and how many of those patients received steroids within the optimum window. So that you can see that it varies, and it's pretty consistent from study to study, the two indications. For most indications, the rate of optimal steroid use is less than 40%. The two exceptions are hypertensive disorders, where the rates are over 50% in both of the studies, and PPROM, where the rates are over 40% in both studies. But for the rest, we really do a bad job of timing the steroids. And the question is, can we do better? Well, you might think that you could do better if you allow the use of a rescue course of steroids. So you give the first dose of steroids, and if the patient doesn't deliver, then, well, you wait and give the rescue steroids when you do it later. And this was a study done out of the University of Washington almost 8 years ago that showed that before they used rescue steroids, that was the period of 2006 to 2008. Their optimal time steroids, shown in the red bars here, was just under 30%. And the availability of rescue steroids, which was 2009 to 2012 in that study, didn't really result in a substantial improvement. Still, most of the patients were getting their steroids and delivered more than 7 days later. There were a few that delivered within the first 48 hours. So even rescue steroids didn't improve our ability to time steroids. Well, because of these challenges, Society for Maternal Fetal Medicine, and I was on the work group committee that developed and hashed out this new quality metric. Well, what we said is that if we're going to actually measure our use of steroids, there should be a standardized way of measuring it. And so the denominator, what we said, should be all births that happen less than 34 weeks. And the numerator is not the number of patients who receive steroids, but the number who receive steroids with optimal timing. And you just report the percentage. And what we said was most important is there's no exclusions. In other words, if you really want to improve the quality, then don't give people an out by saying, well, I didn't give it because, because you want to know what those reasons are, what the becauses are. If the becauses are misunderstanding on the part of the provider, you'd like to know that. If the issue is systems problems and supply chain problems, you need to know that. And you don't know those things unless you actually measure how often those things are happening. And we also devised a balancing metric, which is the percent of cases in which antenatal corticosteroids are given, but the moms actually deliver at term. And our next speaker is actually going to talk about some of the harms that may be associated with that happening, that it's not the idea that steroids are all benefit and no potential harm, that there may be actually some harm when we give preterm antenatal corticosteroids and the patients deliver later. So here's some ideas about possible ways that might improve timing. And I think the most important aspect of this is that I don't have data to say that these things are proven, but they are testable. And if you have a standardized metric that you can do this, then people can do the studies to see. So the first idea is that for preterm labor, you don't have to give the steroids the first time the patient comes in and says they had 2 contractions in the last hour. That you should wait until you've given them a trial of tocolysis. If the tocolysis is unsuccessful and their cervix is really dilated, and there are some studies that say when the cervix is less than 2 centimeters and there's not some cervical change measured by either transvaginal cervical length or positive fibronectin, that patient is at very low risk of early preterm birth and really at very low risk of delivery within 7 days. For PPROM, unless they're less than 30 weeks of gestation or having contractions or bleeding or some sign that other than that they're just going to sit quietly for a while, you can hold steroids until they show you some change. And remember that steroids are beneficial in terms of reducing mortality within the first 24 hours. So you've got some time to get steroids on board. Preeclampsia, you don't have to give it just when the patient first presents with preeclampsia at 32 weeks of gestation. Oftentimes with severe preeclampsia, you're going to admit them for expectant management until 34 weeks or so. And unless you've got some triggers that say this patient's really likely to deliver within the next day or two, you can probably hold steroids. The same thing for fetal growth restriction. You don't have to give it just as soon as you make the diagnosis. You can wait until they actually show you some times. So in my hospital, it was very commonplace. The patient came in with a previa and even 1 drop of blood, they got a course of steroids. And when they came back 3 weeks later with another drop of blood, they got another round of steroids. And for those of us that are afraid to withhold steroids, this slide is actually very useful, that under 30 weeks of gestation, the number needed to treat with steroids is less than 100 to prevent one neonatal mortality, one perinatal death. But beyond 30 weeks, it goes up to over 100, and it's over 500 by 32, 33, 34 weeks. So certainly in those later gestational ages that are most common, we don't need to be that afraid about withholding steroids until there's actually some indication that they're very likely to deliver. Here's the analogy that I like to give. There's that bear in the woods, and you can barely see it, and it's way off, and it's really scary. It's called preterm birth. This baby might deliver, and it's really scary. But we have a shotgun that we can shoot at it, and the shotgun is antenatal steroids. It's got 2 rounds in the chamber. That is, we can use the first round as the first course of corticosteroids, and the second shot is the second round of corticosteroids. So we want to withhold shooting until that bear is within range. We don't want to shoot the first time we see it. We want to wait till it's close enough to be threatening because we've only got 2 rounds in the chamber there. You want to wait till it's threatening. It's, that first bear I showed you was a black bear, which isn't even really all that scary, but this brown bear up close, maybe that's the one you want to shoot at. That's the idea I want to get across. Next concept has to do with the optimal regimen. The doses that we use, everyone acknowledges, are whopping huge doses, and we don't know which is better, dexamethasone or betamethasone. This slide's a little bit complicated, and it's not color-coded. The green or red's not my color coding. It came from the actual slide. It was from a meta-analysis, network meta-analysis that compared betamethasone versus dexamethasone, and you can see that all of the bars here in these forest plots cross the line of no difference. In other words, there's no consistent evidence that either one is better in terms of reducing choreo, IVF, neonatal death, neonatal developmental disability, or RDS. So we don't really know whether betamethasone is better than dexamethasone. For a while, there was some interest in trying oral dexamethasone. It's a very bioavailable drug. And the idea was it would be nice if you could save the mom 4 doses. The dexamethasone is a regimen of 4 shots. Instead of the betamethasone, which is only 2. But in this randomized trial, what they found was that giving it orally actually resulted in a higher rate of neonatal sepsis and IVH, and they stopped the trial early because of that. And no one's been willing to test it again because of that safety concern. There's also a concern because we know the doses are large. Could we possibly decrease the dose? So this one trial that was published early this year, the first trial on here, compared, instead of giving 6 milligrams 4 doses, what happens if we give 5 milligrams 4 doses? And the primary outcome of the trial was RDS. And they basically said there was no significant difference between the 2 groups, but the rate of RDS was so low in both groups that it's really going to be impossible to show any difference. And they did say less neonatal hypoglycemia with the lower dose. The other trial was called the beta dose trial, which is actually compared 1 dose of betamethasone, 12 milligrams, versus 2 doses at 24-hour intervals with double-blind trial. And it was designed as a non-inferiority trial. And what they showed was that the single dose was what they said, not non-inferior. And for statistical reasons, that doesn't mean the same as it's inferior. It just means that they couldn't prove that it was non-inferior. But the rate of RDS was, or surfactant use was the primary outcome. The rate of surfactant use was slightly higher in the single dose group than the second, which would suggest that maybe the second dose was better. In the subgroup where it was less than 7 days before delivery, which was only 17% of the patients. Remember that means that 83% of the patients delivered more than 7 days after they entered the trial, which means they did a really terrible job of timing steroids. There was actually a larger difference between the rate of surfactant use, but surfactant use is not really an outcome. In a secondary analysis, they looked at things like RDS and CPAP and so on, but the survival without severe morbidity was the same in the 2 groups. So it appears that maybe we could get away with slightly smaller doses. You may or may not know that Celestone, the form of betamethasone that we use, is actually a combination drug of betamethasone acetate and betamethasone phosphate. And there have been a handful of trials that in sheep that have looked at which one is better, the acetate has a longer half-life in the body, and you might think it would work better. But the phosphate alone seems to have a better effect on respiratory in one study. Another study said that the acetate alone resulted in better things, and one study compared the beta-methazone phosphate to the dexamethasone and found no difference between the two. There's more basic work that needs to be done here. We don't know the optimum regimen. And I'd like to close with some thoughts on the late preterm antenatal corticosteroids, which is something that has become a topic of some interest in the past decade or so. So really, when this broke into the waterfront was when the NICHD Maternal Fetal Medicine Units Network published what they called the ALPS trial, which was the antenatal late preterm steroids trial. So this was moms randomized to beta-methazone for placebo at 34 weeks to 36 weeks and 5 days. And what they showed was that their primary outcome, which was a composite of perinatal death or ECMO, which didn't happen in any group, in any of them, or mechanical ventilation or CPAP or high flow nasal cannula or some mild respiratory morbidities, showed that there was a reduction in those things in the group that received beta-methazone compared to placebo at that late gestational age. The severe respiratory morbidity, which they defined as needing more than 12 hours of CPAP or high flow nasal cannula or more than 24 hours of extra oxygen, more than 30%, was also reduced significantly. But a potential harm was that hypoglycemia was increased by 1.5-fold, and is statistically significant. Well, this trial burst onto the stage. It was presented at SMFM in February of 2016, and within months, it had the use of antenatal steroids, according to birth certificate data, had risen in this gestational age group from under 5% to almost 12%. And it continued to rise in this study up until the end of the study period. And corresponding to that, there was a reduction in the trend for immediate assisted ventilation. So this is a ventilation of less than 6 hours duration. And there was a slight dip in this thing, and it didn't actually decrease, but it just didn't rise as quickly as the trend had been going. Now, why it was trending up during the baseline period, your guess is as good as mine. But it's so, well, maybe there was some benefit to introducing this ALPS trial and doing this stuff. What's not widely appreciated is buried in the supplement to this paper that appeared in the New England Journal. It's not in the print version, but it's way in the back and you have to download it separately, is the fact that all of the benefit here of the beta-methazone late preterm is in patients delivered by planned C-section. That is, patients that didn't have labor. If there was any attempted vaginal birth, if the patients labored at all, first of all, the rate of the primary morbidity, the severe morbidity outcome, was very low to begin with, and no difference between the group. And the only benefit was in the planned C-section group. And we kind of know this. And so if you look at the indications, if they had labor, preterm labor or ruptured membranes, the relative risk actually trends in the wrong direction. It actually says you're better off not giving beta-methazone. And it's only those that didn't present with those labor types of outcomes where the trend is towards some benefit. Furthermore, it looks like the trend towards benefit only occurs in the earlier gestational age block, that is, those less than 36 weeks of gestation. In 36 and to 36 and 5, there was actually a trend in the wrong direction. Again, that stuff is buried in the back. Other people have looked at this hypoglycemia outcome. So in a case control study, this was not a randomized trial, but a case control study done later, said that the rate of hypoglycemia was indeed associated with the use of antenatal steroids in this late gestational age range. And if you looked at severe hypoglycemia, meaning less than 20 milligrams per deciliter, neonatal hypoglycemia was threefold increased in that severe range, and no difference in respiratory morbidity. This is another study that looked at the timing of steroid use in the late preterm period and when hypoglycemia occurred. So the hypoglycemia outcome peaked in the 24 to 48 hour range, and by the 2 to 7 day range, it was on the rise, whereas the respiratory outcomes, TTN and RDS, don't really start to drop much until after that 48-hour period. So it looks like the best benefit of this drug is given if you're going to get more than 2 days, and that's when the risk of hypoglycemia is really the lowest. So since then, there have been 2 other trials more recently published. This was the WHO double-blind trial performed in India, multi-center study, showed no difference in respiratory outcomes, no difference in perinatal neodata. The only difference was a slight reduction in the use of positive pressure ventilation for more than 1 minute. In other words, babies that got steroids, you only needed to give them mask ventilation for 2 minutes instead of less than 1 minute or something like that. And maybe a slight reduction in maternal bacterial infection, which doesn't really make any sense. So really not a good confirmation here of a benefit of late preterm steroids. And another randomized trial that appeared just this year in the Green Journal showed same thing, no difference in respiratory outcomes, and also surprisingly no difference in the rate of hypoglycemia. So the ALPS trial basically hasn't yet really been confirmed. Although we jumped on the bandwagon and started doing it, there's not really convincing data that steroids at this late gestational age are beneficial. So where do we stand right now in terms of what organizations are recommending? ACOG and SMFM say, yeah, if they haven't received a prior course of steroids, we should be offering repeat steroids. The Canadian Society for Obstetrics and Gynecology in Canada is more circumspect, and they say really talk about gestational age specific stuff. And if you look at their table of counseling data, it really favors giving it at 34 weeks, but not at 35 and 36 weeks. And the other European organizations basically do not endorse giving late preterm antenatal corticosteroids. And if I'm going to stand on my soapbox and give you my opinion, I would say that probably we should be pretty circumspect about using late antenatal steroids. We really should stop using it at all in patients who are laboring. So those that present with preterm labor ruptured membranes, or where you're planning to induce labor. And that we should be circumspect if we don't plan to prolong pregnancy for at least 2 to 3 days, because that optimal window for reducing the respiratory outcome is at least 2 days. And that's the peak window. Under 2 days is the peak window for the hypoglycemia in the newborn. And if we have, therefore, if we're going to give steroids only for scheduled preterm C-sections, that we should try to give them at least 3 to 6 days before surgery rather than a shorter interval. And that's a lot of material. Thank you very much for your time. And I'll be back for the question and answer session. Thank you.
Okay, well, thank you. That was an excellent talk by Dr. Combs. We're going to hold our question and answer session till
Good morning, everyone. It's a pleasure for me to be here to share with you some.
It was a really good talk. I don't know, we have to listen to it all again. So our next speaker is going to talk about antenatal corticosteroids and long-term outcomes. The presentation is by Dr. Jessica Liao. Dr. Liao is maternal fetal medicine clinician scientist at BC Women's Hospital and clinical assistant professor at the University of British Columbia in Vancouver, Canada. Her clinical research interests include improving risk communication and shared decision-making, and also placental insufficiency. Welcome, Dr. Liao.
Hey, thank you so much. I don't know if I feel like I'm kind of short for this podium. That's right. All right, so I'm very happy to be here today. Thank you for the invitation and to chat about long-term impacts of antenatal corticosteroids. I do have some research funding in the area of antenatal corticosteroids specifically to look at clinical practice guidelines and the impact of them, but they don't this funding does not impact the material I'll talk about today. And so it's long been posited, as we've already heard earlier today, that there may be programming effects of antenatal corticosteroids on other organs other than the fetal lungs, because there are these glucocorticoid receptors and many other organs in the fetus. And so it's plausible that exposure to antenatal corticosteroids could result in other programming effects that lead to longer-term health outcomes. And so today we'll talk about these health outcomes, but namely the impact on neurodevelopment, because that's the one that most people are concerned about, and really drilling down to look at the importance of study design when we're wading through this literature, and also a brief overview of the non-neurodevelopmental outcomes, namely metabolic or kind of the HPA axis outcomes. And then finally, how do we put this all together? So the take-home points, and I'll sort of, I think, what Andy just said sort of resonated with a lot of the points that I'll end with. So first, impact on neurodevelopment. So I think it's useful here to just take a second and think about, what type of literature is out there, because there's an ever-growing body of literature on this issue about steroids and the impact on neurodevelopment. And when we take a step back, we can sort of reflect that, there's these two types of literature. There's observational studies and there's experimental studies. And so experimental studies include randomized control trials and quasi-experimental studies, and then observational studies are generally considered to be lower quality. But if we start there, because this is where the most recent literature is on this topic, this is a systematic review that was done in 2015 in the Green Journal. It actually included both randomized and observational studies trying to answer this question about what are the neurodevelopmental outcomes associated with a single course of anti-corticosteroids. And they found that there was a decrease in neurodevelopmental morbidity in those born at less than 34 weeks gestation. And there was about a 20 to 30% decrease in cerebral palsy, severe disability, and other Bailey indices, but no difference for studies with a mean gestational age of 28 to 34 weeks. So they basically said that, we have really limited information for the later early preterm, so the later gestational age fetuses, and certainly not very much for the late preterm fetuses. This is a more recent systematic review that was led by a Canadian group, which included all births occurring in 2000 and onwards. So what this meant effectively was, because this was before the ALPS follow-up was just recently published, that they included all observational studies and one quasi-experimental study. And so they found that in early preterm births, there was a decrease in neurodevelopmental impairment, so similar to the previous review, but that in late preterm births, there was a signal for increased investigation for neurocognitive disorders. And here they included one study here that was basically a population database study that demonstrated this increased harm. In this review, they also discussed this study, which many people are very familiar with. This is done by Räikkönen et al., done by using a Finland population database. And this study is very widely cited in most clinical practice guidelines on anti-corticosteroids. And so what they did is that they used their population databases to identify those that were exposed to steroids in routine practice. Then they followed these children along. And at 6 to 8 years age, they saw, who had any kind of codes that they may have increased any mental or behavioral disorder. So this would be administrative codes, like you go and you have your diagnostic code for a visit with a consultant, et cetera. And so they found that in those exposed to steroids, they had a 12% risk of having this outcome versus not exposed 7%. And so this was an increase in risk of about 33%. And in term-born infants, so those exposed to steroids in routine care, but then eventually born at term, there was sort of an enhancement in this increase in risk that you can see there, almost 50% increase. And so this is really the sole reference that's highlighted in, for example, the Green Top guideline, which suggests that we shouldn't be giving late preterm anti-corticosteroids. But the major issue with these studies, so these observational studies done by large population data sets, is that in many ways they're creating exposure groups that are not comparable. So what does that mean? We're talking about steroid use in routine clinical care. And we know, because we do clinical care, that when we give steroids, they are very different patients than patients that do not get steroids. So if you take a group of term-born infants and you compare all the ones that presented for some reason to your triage because of bleeding, because of preterm labor, because of hypertension, and you compare them all to term-born infants that never came to triage antenatally, there might be a difference in neurodevelopmental outcome, but that might not be driven by the steroids they got. It might be because of the reason of the complication that they got. And so when you think about it that way, it makes sense that, of course, at term-born infants in that subgroup, you're going to see an enhanced signal in this way because the risks are lowest for that group, and maybe there is this difference, and it's hard to know if it's really the indication that brought them to triage to get the steroids or the steroids themselves. And so this is called confounding by indication, and this is really the main issue with these more recent studies. So what about using regression? Because in lots of these studies, they'll say, in the analysis, if you read the fine print, they'll say, okay, well, we use regression analysis to control for, pregnancy complications, hypertension, preeclampsia, et cetera. So what does regression do? It looks at the association between steroids and neurodevelopment, exposure and the outcome among individuals that are similar for that potential confounding factor. But the problem is in these population databases, it's very difficult to account for the severity of these risk factors. So to take an example again, if we compare someone who is delivered at 37 weeks, had preeclampsia, and got steroids in that pregnancy, they're probably very different than someone who delivered at 37 weeks, got preeclampsia, same ICD code in the database, and did not get steroids during their pregnancy. We can imagine that clinically, those that got steroids are likely systematically higher risk. There was something more worrisome in that clinical picture that got us to give them steroids versus that other patient. And so this is a good, maybe theoretical experiment, but we actually want to test this empirically. So we use this technique called benchmarking. And benchmarking, I think, means lots of things in many different fields, including quality improvement, something different. But in perinatal epidemiology, we use this concept of benchmarking to say that observational cohorts should actually be able to replicate an RCT's findings using their analyses. So although I'm saying that observational studies can give, lower quality evidence, the reality is they're very powerful because they can leverage these multiple data sources to answer questions that a randomized control trial, maybe cannot even answer just logistically. So, but in these observational cohorts and with these analyses, we should expect that these analyses should be able to replicate what we know from the gold standard from randomized control trials. And if it can do that, then maybe we can trust that cohort, that analyses, to go beyond what the trial told us and answer questions we don't know. So we tried to do this for the Raikkonen study. And so we actually applied these principles to try to assess quantitatively this potential for confounding. So we created a population-based British Columbia cohort that was very similar to the Finnish cohort and repeated the same analyses, the exact same regression analyses they did in Finnish cohort with our cohort, using the same variables, same outcomes. It's great because everybody publishes the ICD codes they use, et cetera, so it's able to, they're able to replicate these analyses easily. And so when we looked at any childhood mental or behavioral disorder, their primary outcome, we found the same thing as well. We replicated their findings. We found that those that got steroids had a higher risk of these neurodevelopmental outcomes. But when we looked at the outcome of neonatal respiratory morbidity, we found that there was a higher risk in those that got steroids, which we know does not make sense. We have over 20 to 40 years of literature of randomized controlled trial data, not just ALPS, which is depicted there in the last plot, but many other RCTs, which show that steroids reduce respiratory morbidity. That is one thing that is not in question. So the fact that this plot shows that in our cohort, those that got steroids had a higher risk of respiratory morbidity means that there is a high chance that, this result that shows that there's a higher risk of neurodevelopmental disability can be confounded, or that there's residual confounding despite controlling for all those covariates. So what does this mean? This means that I think that when we wade through the literature, we should really try to focus on, what is the highest quality evidence? And here I'm going to discuss briefly about randomized and quasi-experimental studies. And quasi-experimental studies are sort of a vague term that are sort of not well understood and variably defined in the literature. But for this question, this particular one, which is looking at antenatal corticosteroids and long-term neurodevelopment, what we're really looking for are studies that in which assignment to antenatal corticosteroids is based on a factor that is unrelated to the individual's risk profile. So if I'm a participant in this study, the reason I get steroids or does not get steroids has nothing to do with how high risk my pregnancy is, and everything to do with an external factor like randomization or like a policy or another reason why I would get steroids or not get steroids. And these designs are really going to reduce the confounding by indication or that fatal flaw. And so randomized control trials, so we just have the recent data that was alluded to earlier from the ALPS trial, which showed no difference in neurodevelopment at 6 years of age between those that got late preterm steroids and those who got placebo. But the main issue here is, unfortunately, there's a 66% loss to follow-up rate, which is quite high and obviously compromises the integrity of the randomization, the whole reason we wanted the randomization. So that is quite unfortunate. And the RCTs that are older, there's about 5 of them from the systematic reviews, which have reported long-term outcomes. They show a decrease in developmental delay. But then again, a lot of these are from an earlier gestational age, as we talked about earlier, and no difference or uncertain effects on cerebral palsy, intellectual impairment, neurosensory effects, or learning difficulties. But again, high loss follow-up rates up to 40% even in those studies. What about natural experiments? So there are 4 of these in the literature right now as of our systematic review that we just did mid last year. And so there's 2 from Sweden that took advantage of different hospital policies. So some hospitals in Sweden started using antenatal corticosteroids at different times than others. And so they compared those that delivered at the ones that gave steroids versus the ones that didn't. And then there's also 2 Canadian studies that our group has been a part of, led by Dr. Hutchin in Vancouver. And we used a technique called regression discontinuity. And so I'll just briefly summarize it here because it's kind of a cool way to use observational data and different, it kind of demonstrates something that we can do when we're faced with all these problems with cohort data. And so we had a policy in Canada where we were administering anticorticosteroids up to 34 weeks gestation, 34 and 0 or 33 plus 6. That was our national clinical practice guideline. And so you can see how, if you presented for your delivery before 34 weeks, you got steroids in the gray there. If you presented after, you did not get steroids. So we were really good at following our policy. So if you take a huge population database of these pregnancies, of the whole, all births in British Columbia over a number of years, you can see how those that are presenting just before that cut point, for example, 33 plus 6, and those that are presenting just after are very similar in many clinical characteristics, except that the one group would have gotten steroids and the one group wouldn't. So it's almost as good as random, whether you present at 33 plus 6 or 34 plus 1. Like we can imagine how those would be very similar patients. So using this technique, and kind of putting everything together for these quasi-experimental studies, they essentially found that there was no association between steroids and cerebral palsy or epilepsy in the Swedish studies, and in the Canadian studies, we found that there was no association between steroids and ADHD or overall child development that was assessed at 5 to 6 years, in which we do routine testing in British Columbia for that. So one last little nugget that we have to put in there to put everything together is the indirect RCT evidence. Because as many know, there's evidence from repeat versus single courses of anti-corticosteroids that have really informed kind of our understanding of potential risk. And so there was a large RCT that was done in Canada, published in 2013, called the MAX trial, which showed that in those exposed to repeat steroids every 2 weeks versus one course, there was an increase in neurosensory disability or adverse effects in those that were eventually born at term in this sub-cohort of that study. It wasn't found in the whole cohort, and it wasn't replicated in other RCTs that were looking at this question, which have been done in New Zealand and Australia primarily. And in those, in the other kind of body of literature is before term elective cesarean section. This is the information from the Aztecs trial from the UK. There's ongoing trials still on this question about, should we be giving steroids to term cold sections? And so the Aztecs trial found that there was an increase in the teachers' ratings in the lower quartile of academic ability in those exposed to steroids. But again, there was only a 35% follow-up, and there was no difference in the need for additional help or these other parameters that they looked at. So in summary, if we look at our pyramid, the higher quality evidence says there's no difference. It's not that convincing anyways for a link with adverse neuro events on neurodevelopment, and the observational studies suggest that there may be worse neurodevelopment. And this is just one slide, which I'll probably just briefly mention for time's sake, but essentially when we did our systematic review to look at other impacts, it was very similar in that there was no difference in most metabolic outcomes based on the high quality evidence, except there was one that suggested an increased response to an oral glucose tolerance test in adulthood. It's hard to know really what the clinical sort of significance of that is. And then in repeat versus single course anticorticosteroids, they did find that there was decreased early childhood weight and systolic blood pressure in those who were exposed to steroids, but that in some of those studies, about half of them, that seemed to resolve by mid-childhood, 6 to 8 years old. So where do we go from here? So this is a very similar chart to the one that Andy showed. This is using Canadian data and using weeks at admission for delivery and cases of RDS. So we can see in the orange circle that unsurprisingly, with increasing gestational age, your risk of morbidity from RDS or respiratory distress decreases. And what that means is that the number needed to treat, which is in the blue circles with anticorticosteroids to prevent one case of RDS, increases gestational age. You can see from our data that there is somewhat of an inflection point at about 33 to 34 weeks gestation. This is where it really seems like you see that exponential increase in number needed to treat, or which means an exponential decrease in benefit for steroids. So kind of echoing what Andy had said, In the earlier gestational ages, it's not really, it's more a question about timing and trying to get the timing right. But because there's these significant benefits of steroids, these sort of circumspect or like unclear suggestions of harm are kind of less important to be talking about with patients, in my opinion. But in these later gestational ages, the late preterm ages and beyond, the timing might be easier, and studies suggest that usually we're a bit better at guessing who's going to deliver if they present at late preterm ages. But the balance of benefits and harms of steroids is a lot more difficult or unclear. So here's the chart which Andy alluded to in our clinical practice guideline, where we looked at gestational week-specific benefits of late preterm steroids, trying to really, address that issue of a 34-weeker is different than a 36-weeker presenting for potential late preterm labor. And here we actually use individual participant data from the ALPS trial and mapped it to a BC population, and we're able to get more precise estimates for these gestational week cohorts. And so you can see that, for example, at 34 weeks, I can tell a patient that, with no steroids, you have a 20% risk of breast morbidity. That goes down to 14% with steroids. But at 36 weeks, the difference is only from 6% to 4%. And that is counterbalanced with the risk of hypoglycemia, which increases by about 9% across this gestational age range. And then I say something like, we're still trying to study the long-term impacts of anticorticosteroids, and the impact remains uncertain, but the highest quality evidence suggests no adverse effects, especially with one course, and especially if your baby ends up being born preterm. So the more certain I am, the more hopefully reassuring I can be in terms of long-term effects. And that's all. Okay, we'll go up there.
The floor up for some questions. Do we also have Dr. Combs online as well?
I'm here.
Good morning. Thank you for joining us. So any questions from the audience first for Jessica or for Andy? So I'm going to ask a question then, Jessica, if that's okay. So I think that was an incredibly thoughtful talk, and I'm really impressed about how thoughtful the Canadians are in terms of their guidelines. And I just wondered, what are the actual Canadian guidelines for antenatal steroid use right now?
Yes, we just updated the late preterm one. So we have sort of two sets of guidelines, one for overall steroids, and then a kind of a sub-guideline for late preterm steroids. And that's the one that came out in June 2023. And we did change, so we were previously, from 2018 until now, we were administering them up to 34 plus 6, and we changed that. We went back to 33 plus 6 as our upper boundary. And the reason is because, when looking at that graph and the inflection point and just thinking about the body of literature, it just didn't make sense to us to just arbitrarily say that, in this 34th week, to make a decision for patients if it's so unclear, but it's been challenging because it's not that easy to talk about this unclear balance of benefits and harms. And so, I'm still unsure about what the best way is to guide practice, is if it's better to just give a hard cutoff and just everybody do that, or if it's better to give people, a little bit more leeway. It's not straightforward.
Thanks. And I think that's what's happened in Europe, that they've actually pulled back a little bit in terms of antenatal steroids. Andy, can you just update us on what SMFM are saying specifically about late preterm steroids?
For late preterm steroids, they still say it should be considered, and you can counsel the patient about benefits and risks. And they also specifically state that you should stick to the inclusion criteria from the ALPS trial, which means that, in the ALPS trial, they excluded multifetal gestation. They excluded patients with type 1 or type 2 diabetes, and they excluded patients with several other risk factors. And specifically, they excluded patients who had received a prior course of steroids. So this is not rescue or repeat steroids. It's only the initial course, because anything outside those inclusion criteria, we just don't have data. There is one recent paper that showed that there's a substantial amount of indication creep, and when over a third of the cases in one center where they were given late preterm antenatal steroids, over one third of the cases actually would have been excluded from the ALPS trial. So that's one of the problems with these sort of guidelines, is that there is indication creep. The studies are done in a highly selected group, but that group may not reflect the whole population where the drug was being used.
Thanks. And then the other thing that we saw from the OB-COAP data is that we might actually not be doing too badly as a collaborative as a whole compared to some of the other studies, in that about half of the time we're actually giving antenatal steroids within 1 week of an early preterm delivery. But I'd like to first ask Jessica and then Andy, do you think we can do better, and how can we do better?
I was actually thinking the same thing looking at your data, that actually you guys are doing pretty good. And one of the metrics that I think is important, which you did present on too, that not to lose sight of, is this metric of, the early preterm babies, how many of them are getting steroids, right? And your data is actually quite good on that, because I think it was only about 20% or something were missing them, or 30%, which is really not bad, because I think that one of the impacts that we see a little bit anecdotally is that with more conversation about steroids, which is good, you want to inform patients more. At the same time, you have the indication creep the opposite way. Like, people aren't getting steroids, when they're 26, 27 weeks, and PPROM, for example. And I've seen this, in my own institution at Handover, and, they're like, oh, well, there's harms. And just to kind of really still ensure that we're getting steroids to the fetuses that would benefit from them. So I actually think, it's looking pretty good in terms of your data. There's always room for improvement, I guess. But I think, as Andy mentioned, really the timing of steroids and trying to figure out ways that we can, pull apart this group of people arriving at risk of preterm delivery. It's such a heterogeneous group, and how can we further understand which groups, may deliver and may not? I think that's really the way forward.
Thanks, Jessica. And Andy, any thoughts from you? You did outline some potential kind of guidance about how to try and optimize steroid use.
Right. One of the biggest barriers to trying to improve the timing is that people are reluctant to withhold steroids. And the Joint Commission metric, I think one of the downsides of using that metric is that we were all incentivized to give steroids just at the drop of a hat. We got credit for giving steroids regardless of timing. And so everybody, got rates of 98 to 100% on that metric. Some of it was from the exclusions, but a lot of it was just that we were very aggressive about giving steroids as soon as the patient showed us anything. If she looked cross-eyed, we'd give them steroids. As I mentioned, in my hospital, we were giving steroids with a patient with a previa who came in with 1 drop of bleeding. That had, not ongoing bleeding, and just, they'd had a bleeding episode and it was old dark blood and blah, blah, blah. So I think that in order to improve the timing, you have to be willing to withhold steroids. And so when you devise a protocol to do that, it should be done prospectively and as a quality improvement project. And you need to track data, and having the metric to track the data is going to be very useful. But the target gestational ages, probably, beyond 30 weeks, we should have more comfort about withholding steroids. I don't know that we're going to persuade anyone to not give steroids to a 24-week or a 25-weeker, unless they're really low probability. I think that having tests like cervical length and fetal fibronectin to guide us, those have very high negative predictive values with a long cervix and or a negative fibronectin. Very high probability the patient's not going to deliver within a week, and we shouldn't be giving steroids at the drop of the hat. But that's the big barrier, is that we all have been trained to give steroids early, and withholding steroids is potentially fraught. What we don't realize is that, withholding steroids would be considered an error of omission, but giving steroids too early when we've wasted them, we've, shot that 1 shot out of our shotgun, and then we give a second round and we've shot that shot. When they come back again at 29 weeks now for their 3rd round of steroids, our shotgun's empty. And so that's an error of commission. And no matter what, there's going to be some errors, but we've all been incentivized to avoid the errors of omission, and we have to be willing to accept, we've all been incentivized to accept the errors of commission, and we have to be willing to accept there may be a few errors of omission by withholding steroids. And it's a tough question.
I think one thing that I don't know if this is applicable in your context, but that I think has helped for us in BC is that, many times when somebody, our service manages all the transfers in the province, so, higher level of care for people at risk of preterm delivery. And so in the past, providers were often instructed to sort of give steroids right away before the patient is transferred. Because obviously if you're transferring a patient via air ambulance, it's like you're quite worried about them needing to deliver. But we sort of changed our practice to say now, we often tell them not to give steroids because, we can get people out usually to our tertiary centers and, within the 24, sometimes 48 hours, depending on the weather. But so we have, we sort of just use that almost like transport time as a time for reflection. And then when they come to the tertiary center, we do see more early preterm births and things like that, so we can make that decision. So kind of take that, off the shoulders of the referring provider and sort of make that decision at the tertiary center, where I think that has made a bit of a difference in helping us tailor the timing. Like I say all the time that I don't deliver term babies anymore because I only know how to take care of these preterm ones. And so just kind of using our expertise, where we have the experience, I think would help maybe.
Thank you. Any online questions? Nope. Any other questions from the audience?
I was really interested in the regression discontinuity research method, and I'm assuming that it takes a very large data set in order to be useful.
Yes. Yeah, it has to be population data, but it's just an example of, we need to, as readers, demand more from these population data sets. Just because they have big numbers doesn't mean their methods are good. So you need big numbers, and then you need kind of innovative methods to deal with the inherent confounding that you're going to get with observational studies. But it is surmountable. It's not just that, all these observational stuff, you just shouldn't look at it at all. So it's just about being a bit more discriminatory, I think.
Hi, Pete Napolitano from the University of Washington. This isn't a question, but this is work that we're working on in terms of basic science. I think it's simplistic to think about babies at 24 weeks versus 34 weeks in terms of that they're the same. So our work has looked at the percentage of neural stem cells versus microglial cells. And when you look at beta-methasone and magnesium on the effects of inflammation from these cells in their brains, the response is quite different. At 34 weeks, the brain is mostly microglial cells and not neural stem cells. So I think we black box everything. Okay, everybody needs magnesium, everybody needs steroids if they're preterm. But you have completely a different patient when they're 34 and beyond. And in addition, we just say everything is good, right? Well, I think we have to quantify the risk of respiratory injury versus neurodevelopmental injury. And it may be that at some point there's a tilting point that says no, that you're not. So a lot more is going on right now in the basic science world. But I can tell you, we've already, at the Society for Maternal Fetal Medicine meeting back in February in Baltimore, we presented our initial work at looking at human neural stem cells versus microglial cells in the fetus. And we definitely see a very different response in those two cell types, which suggests that a baby at 34 to 36 weeks is going to have a much different response in terms of inflammation in the brain. So just a comment.
Thanks, Pete. Anybody else?
Okay, I have to ask about repeating the course of steroids. And just for example, I want to say I'm making this up in my head, but I'm really not. If you admit someone at 24 weeks with a short cervix and you give them steroids at 24 weeks, then they go home, their cervix becomes shorter, they're readmitted at 27 weeks. Not really laboring. But when do you decide? When do you give, or when do you shoot the second bullet? Are there guidelines for when and if we should give repeat steroids, because when you get a sign out that says give rescue steroids if patient seems to be in labor, it's quite vague. I don't enjoy those sign outs because I'm like, what does this mean? Because you already shot my first shot, because I've seen that, I had the privilege of seeing that talk earlier. I'm like, you already shot the first shot 3 weeks ago. So I got one more shot to go. How do I know when to do it? And then is there an optimal timing for rescue steroids? I don't know. It's very vague, I think.
Yeah, we've looked at this question when we updated our full guideline in 2018, and I think there's like a handful of randomized controlled trials looking at just like this question of rescue alone. And in general, you know, as shown, it's more steroids usually lead to better respiratory outcomes, but all those studies pretty much went up to like not past 32 weeks. So for me, in my practice, I don't really even consider them past 31 weeks. That's number one. And the second part of that is, you know, the time interval from the last steroids. I usually, although as Andy mentioned, the interval is best like within 7 days, I think there's some evidence, like even that evidence is a little bit, I think there's a bit of gray zone up to 14 days. So I usually wait till at least 14 days from their first course, and it's usually longer than that, and then not past 31 weeks. And for that patient, I don't give them until they're 2 centimeters dilated at least, you know, because that 1 centimeter dilated is like, who knows what that means. Multiple thoughts. And then, so yeah, so we usually wait. But it's hard, right? Because I really feel like, because we talk so much about to our other centers, it's really different when you have easy access to a tertiary center and you know this baby, if you happen to be wrong and they're going to be born in a tertiary unit with surfactant, et cetera, et cetera. It's different when you're talking about, you know, delivering or managing cases at a level 2 center, for example. Like, I think it's not easy.
Andy, do you want to weigh in on this? Because my reading of the SMFM and ACOG guidelines is they're a little different.
Yeah. So the first randomized trial that showed benefit of a single course of rescue steroids was done by the obstetrics medical group. Garidi was the first author, and our inclusion criteria was intact membranes, and we waited at least 14 days after the initial course. So ACOG initially endorsed that idea of you could wait 14 days and then repeat the steroids if the patients seemed to be at high risk of preterm delivery. And it's the same problem with that imperfect calculus of when are they really likely to deliver within 7 days, and all the things you have to consider, not only what's the cervical length, but what's the contraction frequency and what's the dilation and what are the other factors going on. Now ACOG says, well, you could actually consider it as early as 7 days. They say that without any data. I don't think there's any really randomized trial data that shows a benefit. We recently published our randomized trial of rescue steroids for patients with ruptured membranes. And in that trial, because we felt that they were at really high risk to deliver within that, the first, at the 1 week time point, they're still at high risk to deliver between 1 week and 2 weeks. So we gave the second course of steroids at 1 week interval after the first course of steroids for those patients. And we showed absolutely no difference in respiratory morbidity or any other morbidity. So I think we can't really endorse rescue steroids for patients with ruptured membranes. And the benefit on the rescue steroids trials is really all respiratory. The numbers are not large enough to show benefit in terms of any of the other outcomes like mortality and NEC and IVH and all the really serious outcomes. It's all respiratory morbidity, which is relatively a minor morbidity. So I think you should have a relatively high threshold to repeat steroids, and I agree, not after 32 weeks.
Can I ask a follow-up there about the PPROM? If the repeat course was given 1 week after, was there still, Andy, a long latency between that second course and delivery?
No, most of the patients actually delivered within that first week. And we looked specifically at the subgroup that did deliver within a week and didn't show any benefit in that subgroup either.
Thank you.
So I think we're just about at time, Kristen. Is there time for another question, or are we?
There's time for another question. If
any other questions?
Good morning. Mine is a life applicable question. So we're a level 1 birthing hospital in Washington State. I think of the 54 or 55 birthing hospitals that many of us are level 1. We, by guidelines, can deliver babies at 35 and 0. By policy, we're at 36 and 0. So I wonder when I look and see how many of those, the 40 to 60% that fall out where they had the steroids at greater than 7 days prior to delivery. I know that when we transfer somebody who's preterm, we're very quick about making sure that everything we need to get on board is there. How would you what recommendations would there that you think could be actionable for our really great OBs that are not generally MFN and they don't always consult as quickly? And some of our transfers seem lower acuity to the patients that you get at larger tertiary centers at the University of Washington down at Swedish, but they're not safe to stay with us. So I'd love to hear how you think we can affect that. And I really wonder in the COAP data, when there's only 1 or 2 birthing centers in level 1, how many of those might actually be originating from a level 1 facility and how we could hit that market.
Okay, so I'm going to throw that to Andy, Jessica, and maybe Pete Napolitano, because Pete, you got a lot of transfers from Eastern Washington. Do you want to kick that off? Pete is refusing to answer this question.
Let the record reflect.
So Jessica, do you want to say something about this? Because you've got a very rural state, you're not really a state. Province or whatever.
Same thing. Yes. Well, as I mentioned, I think that change has helped where we've basically taken that off the shoulders. Like, so when I take the transfer call now, I say, often the provider will say, like in the level 1, do you want me to give steroids? And I'll say no, just wait, just transfer the patient. And so that's, I think, what most of our group does now. So it does, I think that small thing has kind of helped. I don't really have any other suggestions.
Andy, any thoughts?
Oh, I'd love to see the data about whether it has helped the timing to hold off on that. And I think this is where the COAP data is a very rich and powerful source of data. So if you, as a tertiary center, decide to make some policy changes and recommendation changes and change the standards for what you expect in terms of steroid administration, then you have a method that you can track. Does it improve the timing when you do that? And I think that's the main thing, is that having the data and having a standardized metric to evaluate the data is going to be really helpful. And it's, quality improvement always sort of proceeds incrementally. And that's one thing to consider that you can improve. And Viv, I'm not sure how fine-tooth your data is, if you can tease out those that received the initial course of steroids or the initial dose of steroids at an outlying hospital before transfer versus how many, because I assume that your basis for analysis is the hospital where the delivery actually occurred, as opposed to where the patient was attributed to or initiated from or something like that. But that is, you may be able to tease out some data that you can drive some policy decisions based on it.
Yeah, and I think that, yes, we can look at the actual timing for transfers into the hospital. I think there is some confounding in the level 1 hospitals, in that the patients who don't get the steroids, I suspect, are the patients who come in so quickly that they don't even get time for steroids or transfer. And the patients, who you do have time to get steroids in are the ones who are being transferred out to another hospital. And so I think there may be some bias in there.
Yeah.
Ellie? Oh, sorry. We've got one other question, Andy. Do you want to finish that thought, though, as we take the microphone over?
I need a mic. Because the database has level 1s in it, and where they transfer to may also be in OB-COAP, those it's easy for us to track. And my question has to do with some level 1s may be in places where they send someplace, so we know they don't get entered into our database because they didn't deliver at the level 1. They went someplace. So we lose those. And a level 3, like Pete's Hospital, will get from all over, some of which might be OB-COAP level 1 participants. So given that we only have one of the hospitals and the level ones, we don't know where they're transferring to at all because they're not entered. So it's a great idea. And I'm just wondering if we as OB COAP could contact a hospital to say, you're not an OB COAP, but you sent this patient to a level 3. Did they recommend steroids? Did you do it? As again, she didn't get it because there wasn't time or that, in other words, it's more complicated because not all of our hospitals are in OB COAP.
Yeah. Well, thank you everyone for just a great session. A big thank you to our speakers, Dr. Liao and Dr. Combs. Look at your own data, compare it to the other sites, be thoughtful about steroids. And I think we're now going to have a break. Kristen, is that correct?
That is correct. We'll have a break. Please be back here before 10:30, and we'll do our first raffle. And restrooms are to the right down at the end of the hall. There's also a nursing pod down there. If there's any nursing folks in the room, there's a private space there. And then beverages and some snacks are in the room, and please visit the vendor tables in there. So great, enjoy.
What next speakers have to say. So I have a selection of wines, some sparkling wine from Taveri Cellars, some reds from Owen Rowe, and then some estate wines from Antolin Cellars. So many of you who know Yakima knew Linda Harrelson, who was the former director of our labor and delivery floor for many years, and her husband Tony, and they developed Antolin Cellars. And so there's some Antolin Cellars wines for you. So if your name is drawn, you just go get to pick what you want. One. All right, give them a couple minutes, and then so just come up quietly and pick your bottle, and then no, you can't open it.
Do you want to draw that name? What? Some of them are right side up. You only have one. Okay, you do have to be in the room, and we're announcing the name right now. Chris Laddish.
All right.
Wow, what is that in the bathroom? You guys are hardcore.
Hey,
Right.
it's actually
Rules are rules.
we got
Oh, Mandy Lee,
Mandy Lee.
you are the winner.
Woohoo! You get to pick your bottle. Thank you, Dr. Olden. Yes, I think so. Okay, I'm going to leave the podium to Dr. Chen. She's going to introduce our next speaker.
Okay. Here we are. This might be my favorite part. I love the data, right? Again, you guys all know I will talk on and on about our data because I think it's so amazing. So Kristen and I were able to attend the Health Catalyst annual meeting this year in Salt Lake City. It was like, I didn't even know it was a thing. I've never been in a room with so many data geeks in my life. It was kind of amazing. But it was not surprising to hear that hospitals really don't use their data. I mean, statistically, something like 92% of hospital data never gets looked at. So we don't want that to be you. You've all put a lot of effort into getting data into the database. So we wanted to show you kind of some of the things that are available to you 24/7 in the database. And I say we, but I'm really going to have Lara Blair. She's the clinical coordinator for OB and thoracic databases at ARMIS, which is now part of the mothership Health Catalyst. Health Catalyst is officially our data vendor. She has a background as a labor and delivery nurse. She works very closely with us at the Foundation on data acquisition and reporting. And she's been working really hard on the Community Birth Data Registry, CBDR. She's done amazing work with that. She also is an abstractor for one of our sites, so she really is very familiar with all the, the issues with the database, and she's really been invaluable to doing updates. So I'm going to have what we decided to do after sort of years of trying to do, here's the live demo, and then having like the circle of death. We've decided that that was not as ideal. So we've done screenshots. I know it will seem like we're moving really fast, but the purpose of today is not really to do a tutorial on how to get from A to B, but to really just quickly show you that there is an A and you can get to B and what some of the data outputs look like. Our goal at the foundation is really to help you as sites to use your data. We don't want you to be a site that never looks at it. So I'm going to have Lara come up and do her thing. Do you want the slide thingy?
Yeah. Okay, yep, I heard that. Hi, everybody. Thank you for being here. It's great to be here in person with you and have a chance to show you some of these reporting tools. I came to from clinical practice to data under duress. It wasn't something I was interested in or wanted to do, and I initially struggled to find meaning working with data, but I've really come to see that every metric and every plot and every bar graph represents a human experience. And it also represents something that we can learn from. So, and that learning impacts positively, hopefully, human experiences in the future. So that's kind of helped me with inspiration as we're getting ready to look at a bunch of spreadsheets and things like that. So OB COAP and ARMIS's goal is to provide you with tools to help you in that learning process by measuring and evaluating your processes and patient outcomes. At the local level, this is really where the magic happens. If you're a member of OB COAP, you or someone at your site already has access to everything I'm going to show you. And all of these reports are live or real time. So as soon as your data manager enters the data, it's there and it will appear in the reporting. So we're going to talk about 3 different kinds of reports today. First, the metric library we have 321 metrics and 247 filters that allow you to customize reports. These are essentially going to look like an Excel spreadsheet. The STAR metrics dashboard for assessing quality outcomes, and these give instant visualization of areas of clinical strength, as well as highlighting opportunities for improvement. And then the data tables allow us to drill down to individual records. Every field in the database is present in the menu and can be used either as a filter or as a column header for your table content, where you can do sorting and filtering there. So first we're gonna focus on the metric library. We're gonna use this to build customized spreadsheet. You'll be able to create a base population, choose the metrics you want, and determine how you want to evaluate them. So this is the main menu page. I've highlighted the box where you're going to choose your metrics. And today we're going to build a really simple report to evaluate the rates of choreo among induced patients that delivered vaginally. So I've highlighted in this metrics box. If I don't choose any metrics, the report will run all of them. I can type ahead so I don't have to scroll through all 300 plus metrics to get here. And so I've just selected chorioamnionitis. Now I'm going to add in spontaneous vaginal delivery. And then in my other population filter, I'm going to add induced labor. Next, we're going to set a date range. And then we're going to look at our practitioners, hospitals, and time intervals. The practitioner filter, if you don't choose any practitioners, it'll automatically give you all of them. You can sub-select for 1 or 3 or 5 or however many you want to include. If your reporting group contains multiple hospitals, you'll have all the hospitals listed that you can select from. And then the evaluate by, this is what goes in your column headers. So right now we've got it set to run the report at time intervals. So I'm going to generate the report, and this is what we get. So your population filter is specified, and you move a pointer, specified across the top. First, it tells you the date and time the report was generated. Then it tells you this is all practitioners, all hospitals, spontaneous vaginal delivery, induced labor, your date range by time intervals. Then you get your time intervals going across your column headers, and you get your chorioamnionitis metric showing up in the row. And for each metric, that's a percent metric, you're always going to get your numerator and your denominator. So now I'm going to go back into this menu. I'm going to make one small change. Now I'm going to run this report by race. So that's what's going to be in my column headers. And there they are. And we were kind of looking at this. We just sort of put these together kind of randomly about what we're going to run. And we just kind of noticed that the rates of choreo among the Asian population are kind of interesting. So I don't know, if you're a curious person, you might create more reports with more filters to look for more information. So we're back to our menu again. I've put the evaluate by back to time intervals. Sometimes you want to look at different populations and the outcomes by those different populations. So right now we're looking at reporting group 1, which has everything we've done already. And now I've sort of blown it up and moved it to the top of the page just so you can see it. I'm going to click on this little button over there that says exclude group 2. Now I have a group 2. Oh, sorry. And then I'm going to click on the button that says default to group 1, which is just going to bring everything down. Everything that's up top is going to come down to the bottom. I'm going to make one small change. Underneath my induced, where I have my induced labor in population filter A, I'm going to grab one of the modifiers and I'm going to click not. I'm going to leave my date range the same. We're evaluating by time intervals, and I put a green box around it. So now I get a report where I have the same population of patients who were induced alongside patients who were not induced. All right. Yeah.
And really, in real time, running these reports, it doesn't take a ton of time. We just didn't want to show it because the potential for technical glitches. But this is all, as Lara was saying, like you can in your mind think of a question and say, I wonder about X, Y, Z. And if you're not sure how you would create that in hybrid, like we can do that. Like we were just talking about this as kind of a way to show how you can look for something as simple as chorioamnionitis, how we could look at spontaneous versus induced labor, how you could break it down by race. That literally in real time would be like minutes. So you can do that. And that's the power of your data. So if you're sitting there thinking though, I really wonder about this, this, and this, but you're not sure how to build it, I say we, but really Lara and Kristen and a lot of our data managers, really who are very facile with this can help you build that.
Right. So, and just adding to what Angela said, there's a feature in here called recent reports. So anytime I click the generate report button or the export button, it creates a copy that stays in the back. And I can name it, I can favorite it, and other users can go log in and say, show me everyone's report. And they'll be able to see a report that I created. So if you wanted something, your data manager was brand new and didn't have time for a training session and practice sessions, we can build them for your data manager and show them how they can do them, but also produce something that you might need very fast. So the next slide, we're back to the menu, and I've just added a number of other metrics. So I've added some of the ones that are in our dashboards. So the birth without intervention, cesarean rate, early elective delivery, indicated cord gases, severe maternal morbidity, and unexpected complications in the newborns. And we're going to evaluate these by time intervals. And again, you can see your time intervals going across the top. Now I'm going to evaluate by practitioner at delivery. And these are fake names. So now that's what's running across your column headers. So now you can look and you can see the status for these outcomes for all of your practitioners. And then I can go back to that same filter and I can evaluate by practitioner at delivery practice type. So here you can see your family practice docs with cesarean privileges, those without, your hospitalist, MFM, midwife, obstetrician, or other. And you can look at outcomes based on those parameters. Now, sometimes you might want to run a report where you've got, you want to evaluate things by time intervals, but you also want to evaluate things by each one of the practitioners or another type of filter. So in this report type up at the top, it's a widget that allows you to run different report types. For this, I chose the practitioner report, but I could run this report by race, ethnicity, or payer as well. Evaluating by time intervals. I'm going to export this time. So this is, here's an Excel spreadsheet that has a number of tabs. Here's my first page. This is just the standard report. It's all of your metrics over time. The next tab is your hospital. So this gives you all of your metrics by individual delivery practitioner. And then the next tabs have the individual practitioner's data. So if you wanted to run a report card with the metrics that are in your dashboards, say once a quarter, this would be something that you could use. It's relatively easy to build. Once you've built it, it's easy. And you can have this for distribution once a quarter, and you'll have all of your roadmap metrics. You'll know what to expect and have that handy. So the next thing, any questions? Yeah.
So quick question about the metrics. We use that a lot at multi-care, but I think the one challenge that we run into is our provider colleagues. The minute you send performance, immediately the question is going to be, can I see my patient? And that's the one thing maybe for future, for the metric library to be able to say, okay, either I want my numerator, denominator, and performance, or just give me the chart and the numerator so that we're not having to pull the measure from metric library and then go to the numerator. I think that's a challenge that we're trying to work through so that we can get the list of patients to our providers who are always really interested to see, gosh, was my C-section rate really that high? Let me go back and review those charts and understand. Just maybe a question, maybe we've missed something, and then that's the next question we're going to get.
Great question. Thank you. Some of that is going to be solved in some of the STAR metrics reporting, but if there's things that your practitioners are wanting to measure and they're not in STAR metrics, we can get it added. So.
Yeah, there's a question from the audience who are attending virtually. How are you operationalizing severe maternal morbidity? Are you using the CDC codes? Some of these metrics could have alternative code sets.
When we built the SMM metric, we looked at the diagnosis codes that are included in the CDC definition, and we've matched them pretty well in our database. I think we have everything on there, if I remember properly when I look back. And again, I think the difference is with our methodology, someone's actually looking in the chart. It's not based on hoping that a coder picked the right ICD-10 code. We actually have people looking in the chart. I think our SMM is quite comparable.
I'm going back on purpose because I want to just point out something that was in one of the other slides. There it is. So if you're looking at the main metric library menu, on the bottom left, there's a generate reports button, an export button, and a download definitions button. That download definitions button will give you a PDF that has the descriptions for everything that we have. So if you want to know what's in that denominator, they're in the download definitions file that you'll get. So if you're ever curious about what's getting measured here, you can pull that.
And if you don't have access to hybrid, because only certain folks at each site have access directly, we can always send that to you. It's a PDF document and we can send it out. And next time actually that I send, when I send your all metric reports in your dashboard, I'll include that so that everybody has a copy that they can have on file.
Well, and Alice, I think it's amazing that your providers want to see their patient lists. You know, I think that has happened to us at Evergreen. So poor Kristen, she'll make the list, but people usually get like halfway through their list. And of course, everything attributed to them was properly attributed to them. And then they get tired of looking and they're like, okay, you're probably right. My hemorrhage rate really is 10%. So I think, you know, it's validating for the providers who want to be sure their data is accurate. But I think, again, our methodology, the attribution is good. You know, there just shouldn't be huge mistakes, but we get providers who are like, I did not do that many episiotomies. And I'm like, ma'am, you did. It's right here. So before we talk about STAR metrics, I love STAR metrics. So just FYI, if you don't like it, you're going to kind of hurt my feelings, which is okay. This is not about my feelings, but last year we showed Power BI, which I think was also a very powerful data visualization tool. I think we were really talking about data visualization, like what are we doing to make it easier for you to look at your data? But I have to say I'm loving STAR metrics. It's just, I think that the downside of Power BI is the data has to get kind of pushed into Power BI. There's a little more of a lag. STAR metrics is kind of real time. Like once your data is in there, it's in there. So I really love it. This stuff has all been developed, you know, by us, but we certainly want input from all our sites as to how we could make it better or if there are things that are confusing. But anyway, I'm going to let Lara show this. And it's okay if you hurt my feelings, but I do really love this.
So this report really came from our CEO at Armis, Jula, now retired, and a nurse that worked worked in a hospital in Michigan, but became really sort of just phenomenally known and respected in the world of STS. And she wanted to have something that she could give to her surgeons and then immediately see what she wanted them to see with no thinking, no explanations, because they didn't have time to look at her spreadsheet. So that's sort of where the ideas and the context for these reports came. So this is what it looks like. The goal was, again, to develop something that's very visual, that lets practitioners and see immediately where they can do better. First, I'm going to talk about what's on the menu on the left-hand side. You can set some parameters for your outputs, whether you want counts or percents or month and quarter or just month or just quarter. In your population drop-down, you can choose to run this on all your patients or multiparous, nulliparous, and TSV or the induced labor population. You can choose to have records that are anything that anybody's entered or just records that are complete. Sometimes if, we've run the whole year, but your data managers are still finishing up December, you might want to omit the records that aren't marked complete yet. And then there's some filters at the bottom. If you wanted to filter by admission provider or delivery provider, you could do that. Looking over to the right-hand side, there's a column that says OB. These are the benchmarks, and they are the mean from the previous full year of data for whatever we have. So for this, I think what we have in here is the overall mean for 2022. And then the coloring that you see on the page is there's a color key at the bottom. And you can see that if your metric is in a very dark green color, it means you're at least 50% better than the mean. And if you're red, then you're more than 50% worse than the mean. And then there is a way to export this into a PDF from this page. So now I want to talk about these tabs at the top of the page. Here are your episode metrics, the metrics that pertain to the person giving birth. So we've got the early elective delivery, low-dose aspirin recommendations, teen birth cutoff, the VBAC rates, and a few other things. This is a list that we can add to. If people are interested, this is where we started. Here's our newborn metrics. This is where you'll find your OBD success rate and unexpected complications for term newborns. The induction of labor and cesarean tabs are still under construction. This is our hemorrhage tab. This is of all of a certain population, the percent with hemorrhage. So of all vaginal births, what percent had hemorrhage? Of all patients with choreo, this is the percent that had hemorrhage. Your mean and median blood loss is here. The hemorrhage details, these are of all patients with hemorrhage, this percent had choreo, this percent delivered by any vaginal birth, etc. So it's just sort of big picture and then lets you drill down. Here's our indicated court gases metric. So the dashboards have the indicated court gases metric, but the rest of these allow you to see maybe where you missed out, like where you maybe did great collecting them on your OVDs, but not so much on your patients with a cord prolapse. And then the antenatal steroids is new. The metrics have been around for a while, but they're new to the STAR metrics report. Okay, now we're going to go back and look at this as if we're a clinician. So I'm looking at this report. Probably the first thing I want to know is what's in the red box. Like I know right away what I need to look at. So this corresponds to induced vaginal birth induced patient or percent with hemorrhage. So I'm going to click on the cell. And then I'm going to look down to the bottom left, and I've got some more tabs. So here's our metric description tab, and this tells you of all birthing people who have induced labor and deliver vaginally, this is the percent who experience the postpartum hemorrhage. It tells you what your numerator is and also what your denominator is. So this is another way to get to those definitions that the caller was talking about. And then you get a calculation. So it tells you right here that 11.2% was derived from a numerator of 10 and a denominator of 89. And then in the records tab, this is where you get your records. So I've redacted some information to remove PHI and the names of the innocent. So there's record IDs here. You do have to do some cross-referencing with what is in your EMR. And then there's an export records button, and you can get an export. So these are the patients who fell into the denominator for this metric. Some are in the denominator and some are not, but I should say it's all the patients who met the initial criteria. So you can sort by the denominator. If you sort and find all those included in the denominator, and then sort and find those who are also in the numerator, those are your patients. And lastly, there's a metric graph tab. This just lets you have a visual display of how you're doing over a longer period of time. And this is for more than just a year. So this will cross years. Any questions about that? All right. One last STAR metrics tool. This is my favorite. So this is the menu for the most extensive report we have. All you have to do is choose your date range, a few choices about your output. And when I run this report, this is what comes out. I get all of the metric sections. So you can see I get the episode metrics, the newborn metrics, the hemorrhage metrics, the hemorrhage details. My first tab is for everybody. My second tab is for any individual hospital or hospitals, and then an individual tab for each practitioner. So this is, I think, something that's easy for distribution. This is where your practitioners will look and then say, I want the list. I want the list of who the patients were. And then we have some data tables. We call these ad hoc reports. I'm not going to spend a lot of time on them, but basically it allows you to, you're going to drill down into patient characteristics. So you can build a custom population and a custom spreadsheet, and every field that's in the database in any version is available in the menu for building that filter. And same for fields that are in the field selector so that you can put them in your column headers. And that's really all I have. Yeah, Ellie.
Hi, sweetie. My question has to do with, you said several slides back, over on the right is the benchmark and the comparison is the previous year. Did I get that right?
Mm-hmm.
Because I know that sites will join OB-COAP or fall behind in their data or for whatever reason choose to withdraw foolishly. A year's worth of data, if you move it by a quarter, may have totally different sites. That's an exaggeration. But my question is there any way to look up who does that reflect? that year's worth of data is these levels 1, 2, 3 for 3 months, for 9 months, for otherwise last year can vary a lot depending on who's in OB-GYN.
Yeah, so the reason we do the previous year is just because we want to make sure that everybody who's entering data is done. So at least we know we don't have a lot of missing data. But as far as making decisions about using other means to set benchmarks, we haven't really talked about it yet. We've talked about it, we need to talk about it, but we haven't.
You can't tell who that year is.
No.
Okay. That was the...
You don't know, you can't tell who's driving that benchmark.
Okay.
Yeah, not within the reports. It's certainly something that we can pull out and say.
And I know,
Yeah, yeah, yeah. We can provide that information.
There's also, I mean, we've had also some questions about, instead of adding the mean, adding an actual benchmark that's either derived from research or maybe at some point ACOG will say this is what the recommendation should be, and then we can use benchmarks like that. But those are a lot harder to get people to make decisions on, that this is what we're going to make our benchmark.
Well, I was just thinking that it sounds like you could like kind of create a cohort or groups of cohorts. So you could do your hospital level and just kind of create a group to benchmark against, and then you could do your hospital organization. If you were multi-care, you could look at all multi-care groups together and compare that against the wider group and then some state level data. I mean, I think that's what you were trying to say, Ellie, maybe, but that was making sense. So is that the kind of thing that you all would be able to help customize? Or
we do that on a quarterly basis. Those of you who have seen what we call the all metric report, which is an enormous list of every metric that's in the library. And I know it's overwhelming, but the point of it is that we want you to see what's in there. And hopefully, over time, you'll figure out, rows, 12 through 25 are the ones that I really care about. And, you can parse it down to the things you're most interested in. But what we do in that report is give you a monthly breakdown of, for your site over the rolling 12 months, and then the total for that 12 months, and then compare that with the total for all your like levels of care. So if you're a level 1 site, it's all the other level 1 sites in OB-COAP, and then there's an average for all the sites in OB-COAP. So you've got those comparisons, and that's just something that we call it one of our push out reports. So one of the things we send out to you, and we can run those at any point in time. That's certainly an easy report for us to do. So anytime that you think, I'd like to see an updated one of those, and it's not at the quarterly interval that I typically do them, feel free to just, ping me and ask for that. So that's something that's always there. And then on that same vein, with all of the metrics that are in there, like I said, it's a huge list of things. But if there's a metric that you don't see and you're like, I would really like to have this on a regular basis, let us know. I mean, that's what Lara and her team at ARMIS, that's what they do, is build those metrics into the library. And, the ones that are there are the ones that, they're either just standard metrics or they're ones that people have asked for. So, and same goes for the STAR metrics. Those are things that, as we've developed over time, the cord gas one is a perfect example. The Evergreen team was really doing a drill down and some real quality improvement initiative around that. And so that was how that came to be, is we've made this really detailed report to show for every indication that cord gases should be drawn, what's the percentage that are being done, so that you could really see, oh, we need to focus on this group. We're doing really fine in everybody else. So anytime. And, that's what we're here for. And so we really want to drive, that was the whole purpose of, doing this talk today, is to drive home the idea that this is your collaborative and this is all about your quality improvement efforts. And we're here to be the conduit to make that easy for you. So just keep us posted what you need.
Just one other suggestion about the metric library is if you're not sure what's in there, if you just go to the metric library and you don't choose any metrics, just leave it blank and put in any random date range. So you're not really looking for data and you just run the report, and as an export, you'll get a list. What comes out will be a list. It might be zeros depending on what population you put in, but at least it will give you something for reference. And then you can look through it and go, this looks important, highlight it. And then next time you make a report that's got what's relevant to you or to your practitioners. So kind of like a menu.
The next two tabs we're working on in STAR metrics is going to be C-section, because I think a lot of us are still, it's, kind of the dead horse we got to keep beating. But we're going to try to break down your C-sections to just see where are they coming from. It'll be a little bit like the Robson classification where we'll see, scheduled, induced labor, spontaneous labor, indication for C-section, arrest of dilation, arrest of descent. It just sometimes makes it easier when you break it apart to say, well, where am I red? Like, where's our most likely opportunity for improvement? The other tab that is sitting there waiting to be filled in is inductions. I think inductions, another hot topic, right? We just want to see where are your inductions coming from? What patients are being induced? It'll look different from site to site. But, spoiler alert, we hope in the early fall to be having a webinar that's really going to focus on best practices for induction. So that's coming. I think that's still like a pain point for every site out there, is how do you get your inductions in? How do you decrease their C-section rate? Arrive has not arrived for many of us. It has just really doesn't seem practical or that we're going to get those nice results of where if we induce everyone at 39 weeks, we'll see a lower section rate. I don't think that's what we see in our own data. But yes, the data is yours. We want to help you. We have data manager meetings regularly. We have office hours. I say we again, Lara and Kristen.
Every Thursday at 12 noon Pacific time.
Yep. So if you want to learn more, it is okay to show up and say, I have no idea how to do this in hybrid, and we'll teach you. Because once you learn, and the data managers out there who are very adept at manipulating this data, there's so much you can get out of your own data that you could not get from other sources. So, all right.
Thanks, Lara.
And one thing I will add is for those of you in the room that are in the CBDR, that many of these tools will look very similar for the CBDR as well. It's just going to pull from a different registry. And so a lot of the same kinds of tools and a lot of the same options in terms of, getting us to help you pull that information is going to be available. So stay tuned. All right, I'm going to turn it over to Amy and we'll get ready for our panel. In case you don't know, the CBDR is the Community Birth Data Registry, which is works in tandem with many shared fields across the CBDR and OB-COAP so that we can really look at the outcomes across delivery setting. So, and that's just getting rolling. We have a number of folks that are enrolled and starting to put data in. So it's very exciting.
May I invite the remaining panel members in the room to join us? There should be, in addition to myself, there should be 4 in person and 2 joining us virtually. So as we were, can you check for me, Kristen? Thank you. As we were brainstorming as a management committee on topics and talks for this meeting, it became clear that access to care and obstacles toward it was a significant concern across our committee.
and that we could and probably should have this conversation from a variety of perspectives. So that's really how this panel was born. There we are. Great. I would like to start by sincerely thanking our panel members for giving their valuable time and expertise today to this discussion. Each is an advocate for access in their own way, and I'm very appreciative of taking time out of their very busy lives and schedules to join us today. So in addition to me, as I said, there are 4 present with us in the room, and there will be 2 online. I see Dr. Levy. Thank you. I'm going to start by introducing each of our panel members, and then I'm going to present the perspective on access to care from my perspective, and then invite each of my panel members to share their perspective as well. So we have Sam Piskowski, who is Governor Inslee's policy advisor for public health and will provide the legislative perspective. Thank you, Sam. We have Marianne Keene, who is the Chief Executive Officer of Newport Hospital and Health Services in Newport, which is just north of Spokane and right across the Idaho border. She is going to be providing a rural health perspective from her critical access hospital perspective. Virtually, there's Carol. We have Carol Sakala, who is a nationally recognized thought leader in maternal health and maternity care with expertise in the maternity care system transformation and high-performing maternity care models. She is the Senior Director for Maternal Health at the National Partnership for Women and Families and has led the organization's maternal health portfolio for more than a decade. She is going to speak on the alternative payment model and midwifery perspectives and joins us from the East Coast. Additionally, we have Jessica Beach, who is the Director for Health Equity and Cultural Competency for Molina Healthcare in Washington, and she will address the payer perspective. Joining us virtually is Dr. Barbara Levy, who is an OBGYN and a lifelong advocate for advancing quality in women's health. In addition to her many roles as Chief Medical Officer at Visana Health, as Chief Clinical Officer at Dorsata Inc., and as the Senior VP for Global Clinical Strategy at Invo Bioscience, she serves on the OB-COAP executive team as a strategic advisor. She will be providing our telehealth perspective. And last but not least, we have Sydney Gamble, who is a citizen of the Central Council of the Tlingit and Haida Indians of Alaska and of the Man's Foot Clan. She works with the American Indian Health Commission for Washington State and represents the AIHC on the State of Washington Maternal Mortality Review Panel. She is going to be speaking on behalf of the Native Health perspective. So let's start by setting the stage from my perspective. In order to do that, we need to talk a little bit about maternity deserts. We all know the farther a woman needs to travel for obstetrical care, the higher her risk of maternal and neonatal morbidity. Traveling a great distance for care is also stressful, both emotionally and financially. And maternity deserts are growing in size and number across the United States as facilities close their labor units due to financial concerns and inability to staff. Our panel today is going to discuss this growing issue and offer varied perspectives on how to combat the crisis of access to care. To establish the scope of this problem, I'm going to briefly share a series of maps regarding maternity deserts and staffing crisis, which really gets to my perspective as a hospitalist. We know that a maternity desert is defined by the absence of birthing facilities or OBGYNs and midwives. That low access is one or less birthing hospital and less than 60 OB providers per 10,000 births. There are 2.2 million women of childbearing age in the United States that live in a maternity desert. There are multiple contributors to maternity deserts. One piece is geography, or where one lives in relation to the nearest birthing facility or qualified provider. Excuse me. Closure or absence of birthing facilities is one. Access to prenatal care or birthing providers is another. And you can see this is a series of maps from the March of Dimes Maternity Desert Report. You can see that the farther you get away from the coastal regions of the United States, the fewer birthing facilities there are and the wider the maternity deserts become. Labor shortages disproportionately impact rural communities. This impacts birthing provider access and ability to staff units at birthing facilities, as well as emergency care services by trained providers. Ultimately, if there are no qualified providers staffing birthing units, the access to outpatient prenatal care is diminished as well. We know there's an estimated shortage of 22,000 OBGYNs in the coming years. Less than 7% of OBGYN providers live in rural counties, and this is getting worse as the national shortage of providers grows. And 2.5 million women of childbearing age live in counties without an obstetrical provider in the U.S. So most states have a county that's affected by this. Let's take a little more focused look at our state. Under normal traffic conditions, 2.6% of women in Washington state live over 60 minutes from their nearest birthing facility. 16% of women in Washington have no birthing hospital within 30 minutes of where they live. Women living in maternity care deserts travel 2.3 times further than women living in areas with full access to maternity care in the state. 20% of our counties in Washington are defined as maternity deserts. And in rural areas across the state, 61% of women live over 30 minutes from a birthing hospital, compared to 15% of women living in more urban areas. In my role, I sit atop an organization of OB hospitalists. So I'm the Chief Clinical Officer for OB Hospitalist Group. We represent hospitalist programs in 270 hospitals across 39 states in the United States. We have a mission of providing standardized, equitable, high quality expert care in emergencies for obstetrics and providing care for those that are underserved in the communities. We do this agnostic to their demographics or their other circumstances. As an OBGYN hospitalist, my perspective is that hospitalists offer an important piece of the solution to staffing labor units, emergency care facilities, and even some prenatal care access opportunities, allowing hospitals to staff, keep their units open, and provide that equitable, safe, quality care to their communities. Hospitalists do not need to live where they practice. They can travel in to the more rural areas, provide stints of coverage where they practice standardized, equitable care. They engage in community outreach. They provide that quality championship on the unit, and they allow those communities to keep their birthing facilities and their expertise available to their communities. We've discussed access to care as a multifaceted problem. So geography and ability to staff is just one of those. Here I've listed, in no particular order, other significant contributors to access to care issues. We think about geography, what we talked about, where you live, distance from a facility or providers of care, workforce shortages with both qualified delivering providers and nurses, social determinants of health. There are economic factors, ability to pay, access to transportation or a phone or the internet. There are cultural barriers. There's a mistrust of healthcare providers in certain communities. There are language barriers, racial disparities. There are legislative barriers, immigration status, the ability to extend coverage, education, low reimbursement for obstetrical services, and an absence of social support services. This panel was selected as each has a unique perspective on access to care issues and would therefore have a unique approach to a solution or solutions to this crisis. I'd like to pose these questions now to each of the panel members and offer them a few minutes to discuss their perspective on the solution to the significant problem. So I'm going to ask each of our panel members, and I'll announce him in order. How would you prioritize the contributors to access to care issues in our region? What would you put at the top of the list? And based on this prioritization, how would you approach a solution? I'd like to start with asking Sam Piskowski from the Governor's Office to share her thoughts.
Great, thank you. And thank you so much for having me back again this year. It's a pleasure to be back. Please pardon me, I've just come back from 2 weeks on vacation and then immediately went to a conference in Spokane and just got back to Seattle this morning. So if I am kind of off on a trail, it is because I might still be on vacation and or at a different conference in Spokane. Thank you for setting out that context, Amy. I think it's really helpful to kind of look at how Washington compares to other places in the country. And I spent a lot of time thinking about what are we doing well here in the state and how can we continue to improve on that. I had a really hard time trying to answer the question of how would I prioritize those 4 kind of factors that you identified. I think of all of them as legislative issues, so I might just eliminate that as a contributing factor and just say they all have potential policy solutions. I think for me, the 2 that rise to the top would be workforce shortages and social determinants of health. And thank you to my colleague to the left who has the sheet here. I'm obviously unprepared. We've spent a lot of time in the governor's office over the last couple of years. And I guess I'm going to back up for just 1 second. Say, for context, my role on Governor Inslee's policy team is as his advisor for public health. So I spend my time thinking about population health level initiatives to solve these problems. So I know talking about reimbursement and Medicaid is a real hot topic. Those are outside of my wheelhouse. I am thinking about how can we change systems from the big picture, the community health level, to improve services and access to care. And part of that is thinking about our workforce. Our workforce is super diverse. And I say that from racial and ethnic demographics of our workforce, but also the types of providers we have. I think Amy's slides talked a little bit about numbers of OBGYNs and certified nurse midwives in particular, but we also have perinatal nurse practitioners. We have physician assistants who specialize in obstetrics. We have midwives. We have doulas who are providing a specific service within the OB space. And we have family physicians who are providing OB services. So we're always thinking about how can we capitalize on that super diverse workforce. And when you think about all those different people, the workforce is a lot larger. So we've spent a lot of time, and I think there's more opportunity to continue to bolster our workforce, and particularly those folks who are maybe not as highly trained to provide specialized services in the way that an OB specialist would be, but have a provider type license where there's a lower barrier to entry, lower education requirements. We can recruit folks from the communities they're looking to serve. We talk a lot about needs in rural communities, and sometimes it's not feasible for folks from rural communities to leave their families for 4, 8, 12 years. I'm sorry, I do not know how long all you physicians go to school, but it seems like a very long time. But there are other options. You can become a nurse practitioner with a master's degree. There's midwifery school. There's lots of different options, and we want to ensure folks have opportunity to explore different entryways into the healthcare system. I think a lot about our successes too in breaking down some of those social determinants of health barriers to maternity care access. I was really excited this past legislative session, the legislature passed in the budget funds to allow our healthcare authority to reimburse for doula services. And while they're not providing that clinical care, they're helping folks get into that clinical care. They're helping them navigate a very complex and confusing system. They're being their advocate in the room, maybe when they don't have a family member or partner who can come with them to appointments. So I'm really excited. Or one of my solutions maybe is ensuring that the implementation of that policy works for providers and works for patients. I think, Amy, your slide also talked a little bit about legislative barriers being access to coverage. And one of the things I think I'm most proud of as being a Washingtonian is our super low uninsured rate. It was about 4.7 in 2022, and we've had a couple of new initiatives since then that should have brought that down even more. in just about a month, our healthcare authority will open up a new Apple Health expansion program for folks with undocumented status who are income eligible for Medicaid. Currently, that coverage is available for anyone who is pregnant or in 12 months postpartum. So we cover our pregnant folks, and now the rest of their family can also get coverage. And last year, during open enrollment, so for coverage starting this January, folks without documentation status were able to purchase insurance on the Washington Health Benefit Exchange, our state's individual marketplace. While I understand that there are significant cost barriers to buying health insurance, that became an option that wasn't available to folks in the past. And there is some ability to get state subsidies for that as well. So thinking about what's next, I think part of the solution is understanding what we've done over the last couple of years, how it's impacting access, how it's changing the system and changing folks' ability to get into care, and building off of that. So I think it's really easy to sometimes pass policies and expect to see what you wanted to see immediately, and sometimes that takes a little bit of time. I think I'm going to stop rambling now and
Appreciate that very much. Thank you so much. And I certainly did not mean to imply that these categories were very discrete and separate. There is a ton of overlap. And I appreciate that that is going to come up, I think, over and over throughout these individual talking points. Mary Ann, could we hear your thoughts?
Thank you. Thank you for having me today. So as was already mentioned, I am a Chief Executive Officer at a small rural hospital. I'm here to represent the rural hospitals across our state. The Washington State Hospital Association has a rural hospital committee, of which I'm a member, and then we have formed a rural obstetrical subcommittee, of which I'm the chair. And so I'm bringing some of the information from that perspective, but I personally have a very unique perspective. My background is perinatal and neonatal. I've been doing this for more than 30 years, and so I see it from many different sides. I've worked from level 1 to level 3 and everything in between. So when we look at these contributors, really for the rural hospitals, our biggest issue is workforce shortage. I will tell you that social determinants of health, as you look across the state, for all of your rural sites, these are your most socioeconomically disadvantaged patients that you can imagine. Some don't have a running water. We certainly don't have transportation, and education and mistrust, especially where I'm located, is incredibly high. So that's just a given. You just have to expect that. But in terms of workforce shortages, I like to say once you've seen one critical access hospital, you've seen one critical access hospital. Everyone is different, but we all can agree we do have workforce shortage. The problem is, so for all of you who are in this specialty, you recognize that you went to do this because this is what you want to do. You don't want to go look after the 85-year-old that has, dementia. That is not what you went into this to do. But if you work in a rural hospital, anybody want to guess how many deliveries my hospital does a year? More. Okay, so we actually had to close for a full year. We were only able to reopen last June because we didn't have enough staff. We have done 68 deliveries in the last 12 months. Okay, so many of you do that in a couple of days. I personally have done 10 deliveries in a 12-hour shift, so I get it. At the same time, this is vitally important from being a maternity desert, right? So how do you get nurses who are willing to work in OB, and you can't just grow your own in this because they'll never become competent. So how do you get a nurse who knows labor and delivery already, is competent at labor and delivery, and is willing to go look after that 85-year-old? Because you cannot staff a department with somebody who's only willing to sit in OB. Can't do it. With our 68 deliveries a year, anybody want to guess how much money we lose a year by doing those deliveries? This is where legislation comes in. We are losing $1.3 million a year by providing this delivery service. And that is without counting my OB OR coverage It is also not accounting for the fact that now I don't have enough staff, so I have had to hire 2 travelers. That's how I'm covering my night shift. Those travelers will not go work med-surg, I'm telling you that. But at the same time, is this important to the community or is it not? And how does this become sustainable? How do we create those education programs where we say there is a specialized rural nurse, not an OB nurse, a specialized rural nurse who's going to work OB, is going to be trained, is going to be competent, and how do we maintain that competency, right? We partnered with some of our local larger hospitals to be able to do that, as have other systems across the state. We have legislative issues. Our hospital is in Washington, but half of my town is Idaho and half of my town is Washington. You want to talk about chalk and cheese with two different governors? Yeah, that's it. And I keep saying I don't look good in orange, but you can imagine the political climate and some of the things that we're trying to navigate right now. So with that, I think we talk about workforce shortages. We don't have access to an OB. Our OBs are in Kootenai or in Spokane, over an hour away. We have family practice with OB. How do we keep our family practice with OB competent? ACOG doesn't give us a number of deliveries, but I have 5 of them. Let's divide that between our 68 deliveries, right? What happens when we have that PPH? Thank you, Jada. What happens when we have that PPH and I only have 4 units of blood? So these are the things that as you look at rural healthcare and you say, how do we prevent these maternity deserts from happening? We have to provide a standing fee. We have to provide cash to the hospital to just say, we need you to continue this service. We need to provide and support education for those nursing programs, for those family practice docs. We're not going to get OB when you're doing 60 deliveries a year. We're just not. That's not going to keep anybody happy. Even in retirement, they want more than 60 deliveries a year. And so I think that these are the things that are problems. There are solutions, but it will take a collective voice. And this room is going to help make it happen. Or we will lose healthcare in our rural space.
Thank you so much for all of that optimism.
It is optimism.
We're going to transition now to one of our virtual presenters, Carol.
Yes, thank you, Amy. So I'm going to elevate the significance of payment issues and workforce, especially, but not exclusively midwifery issues as well, and address the crisis of rural health access to maternity services. So first, if we don't change how we pay for maternity care, we will continue to see rural hospital and maternity unit closures. Our volume-based payment system will continue to be unsustainable due to low volume, and the overall problem is worsened but not exclusively caused by the disproportionate number of Medicaid beneficiaries in rural areas and lower rates of Medicaid versus commercial payments. So this comports with what you've just heard. In the last 2 years, 2/3 of small rural hospitals still offering maternity services lost money on patient services. So I'd like to highlight a maternity care alternative payment model that the Center for Healthcare Quality and Payment Reform has designed to enable rural facilities to attract and retain an adequate maternity workforce. So our fee-for-service system has fees for thousands of individual healthcare services, but there are none for what rural residents might view as most important of all: having health professionals, equipment, etc., available to provide essential care whenever it is needed. The center's rural maternity model has 2 payment components. First, standard insurance payments to cover the variable costs of providing care to people having babies, and then a standby capacity payment that covers the fixed costs of having the facility, staff, and equipment available. Standby payments from both private insurers and Medicaid reflect the value to the broader community of having the services available in the community. And one way to set them in this context is a monthly planned payment for each insured woman of childbearing age who lives in the community. Collectively, standby payments would be set at a level to keep the doors open and pay the staff. Now, in some instances, rural facilities are being paid less than other areas, but it's important to clarify that their costs are actually greater. The center's report also notes that payment of the same blended rate for cesarean and vaginal birth would reduce facility incentives for the extra revenue of cesarean birth and give greater support to vaginal birth. And in the center's fuller report, more general report, A Better Way to Pay Rural Hospitals, in addition to standby payments for maternity and other specific services, there's a standby payment to support the availability of the basics, such as emergency, lab, and radiology departments. And these are spread across a per member per month payment for each insured person living in the community, who in turn benefits from the availability of these services. So turning to a few workforce-specific solutions, first, maternity services can be sustained by augmenting skills of general surgeons and certified nurse midwives. General surgeons could receive training in cesarean birth and repair of 3rd and 4th degree tears, and CNMs have access to programs for skills and knowledge in surgical first assist, as well as in ultrasonography, assisted vaginal birth, and perinatal mental health. The loss of maternity skills among family physicians is particularly troubling with respect to the many family physicians who practice in rural areas. And more programs to reverse this trend during either residency or subsequent professional practice would be of great value. Moreover, a midwifery-led birth center is less costly to stand up than a hospital maternity unit and can meet many maternity needs in rural areas. The CMS Innovation Center's Strong Start program found, along with much other research, that birth centers achieve exceptional outcomes for the childbearing families in their care, and we have growing reports of birth center outcomes in rural areas that find results similar to those centers in suburban and urban settings. Another recommendation is cooperative agreements between rural hospitals for on-demand virtual consultation with facilities with 24/7 availability of maternal fetal medicine physicians and perinatologists. This would strengthen the capability of rural emergency departments, whether the facility has a maternity unit or not, and would strengthen the capability of rural maternity units as well. And lastly, with respect to building the cadre of providers for rural maternity care, I'm lifting up the highly successful Frontier Nursing University model for educating certified nurse midwives. This is a remote program where rural-based and oriented and other students largely stay in their chosen communities and collaborate with local preceptors during the clinical training segment of their education. They do go to the university in Lexington, Kentucky for an orientation week, a week of clinical skills development, and if they desire, for their graduation. So Frontier Nursing University is educating more CNMs than any other program in the country, and they have been exceptionally successful at diversifying the composition of their graduates. And of course, CNMs can be educated quicker and at lower cost than physicians. I want to end with a shout out. I hope in Washington State and elsewhere, the Medicaid agencies are planning to apply to the Innovation Center's Transforming Maternal Health, or TMA model, which will feature payment reform, midwifery care, and much more. Thank you for the opportunity to join this panel.
Thank you so much, Carol. I actually am hearing a theme of an opportunity for creativity. Creativity both in how we integrate the model of care and how we think about reimbursement for care. So I made a little joke about the optimism earlier, but there really are opportunities here that can be managed. So thank you so much, Carol. We're going to come back down to our group in the room, Jessica.
All right, thank you. Hi, everyone. My name is Jessica Beach. I'm the Director for Health Equity and Cultural Competency at Molina of Washington. I'm really happy to be here today with a group of just a wide breadth of knowledge in the space. My role at Molina, I kind of see it as it's my responsibility in our health plan to really work at developing internal and external programs, partnerships, collaborations that really focus on increasing access for our members to equitable, high quality care and health outcomes. So I bring that kind of like to my payer perspective. And then also I'm a mom who's had a baby on Medicaid before. I've had a baby in a very rural area where I did live over 30 minutes from my delivery hospital. And I was always terrified I was going to be the lady having her baby on the side of the road. So I think that I also, I can't ever divest my personal experience from the work that I do in the payer space now. And I think, all of the panelists have shared really great and innovative approaches to addressing access. And one of the things we're trying to think about at Molina is how we design a pregnancy experience with our members at the center that is responsive to the unique, diverse perspectives that our members bring, right? We serve the entire state of Washington. We serve pregnant people who live in extremely remote and rural areas, as Marianne discussed, and then people who live in more resourced areas, but may not have the ability or familiarity to access some of those resources or may not feel comfortable in the spaces that we have. We have a large population of members who are new to the United States where English isn't their first language. How do we support them in accessing care? And so we really, in addition to from a provider, being able to access a service, that is one component of it, but it's also that experience piece and how do we support members in the navigation tools. I know, Sam, you talked a little bit about navigation earlier. How do we support our members in having support around navigation? And one of the strategies that we've really focused on when thinking about the priorities that you shared earlier is probably more in the space of geography, social determinants of health, but really going and meeting with our members, meeting with the people that they trust. So we've been talking directly with Medicaid beneficiaries to really get an understanding of what has your pregnancy experience been like? What would you have wished it looked like? Because I can guarantee you, people who have had babies on Medicaid are not saying, I had the best experience with my providers. They were so sweet to me. I felt like I could trust them. And I think that that's what we're trying to think through is how do we support our members in knowing how to be more comfortable in the system, advocate for themselves, or have, the support of someone who can advocate for them. We've also been having these discussions with community-based organizations with providers and saying hey, what are you seeing? What are the barriers in your community? I think that's another thing that's really important too is, I think you said it about the rural access hospital. You've seen one rural access hospital, you've seen one. Well, if you've talked with one community in Washington, you've talked with one community. And I think thinking about how the community someone is from really informs their experience in pregnancy and in the healthcare space. And that's not just about geographically, I live in Spokane and here's my Spokane experience. It's how we support our American Indian members who are trying to navigate resources, maybe in an urban area or in a tribal community. Those are very different perspectives. How we support our Black members who are trying to find providers who are respectful of their culture and their perspective. That's something we've heard a lot of. It's hard to find a provider who meets your unique needs. And there are providers that are out there, but it goes back to that navigation piece. So I think it's really coming together and looking at the systems within communities, and whatever community looks like, and how we as a health plan, like, where are our lanes, right? What can we do? What do we have influence in our space as a managed care organization? How do we support these trusted voices in communities to better understand the Medicaid space? Because something I say often is, no one's ever said, the person I trust the most in my pregnancy is my health insurance company. I just really want to get them on the phone and talk to them all day. No, that's not who people trust. And so how do we support those trusted messengers in better understanding? This is what is covered by Medicaid. Here's how I can help you get to a provider that does respect your needs, or is, someone from the same cultural background, has shared experiences, practices with cultural humility, and that's been validated. How do we support those people in helping our pregnant members? And then also, how do we open up the conversations with providers? We've had some really cool conversations across the state about very innovative things that providers are doing to open up access, introducing new programs, working together. And how do we support that as a managed care organization? I know Carol talked earlier about agreements and things like that. And I think, in the pregnancy space, that's something that's not been seen a ton in managed care, making those intentional agreements in prenatal and postpartum care. So how do we innovate around that together? And that's really collaborative work. I don't think that comes from us saying hey, this is what we see in our data, and we're just going to go design this and bring it to you. Because I know as providers, y'all love it when that happens, right? So really working collaboratively to say, if we did want to do an agreement that really supported this work that you're doing, what does that look like? How do we work together on that and really just push this work forward? And then I think our other lane around advocacy, there are a lot of things like workforce equity issues, workforce just access issues in certain parts of the state. And I think that's where we really work hard to advocate for the legislation that supports growing the workforce and whatever that looks like in particular parts of the state. So I think that's another really critical area where we try to move as a health plan to support the work that is happening in the workforce space, whether it's, from an OBGYN perspective, a midwife perspective, or the work around doulas and other pregnancy workforce professionals. So I think I took all the time.
Thank you very much, Jessica. We are going to have some opportunities for questions at the end, and I see that possibly there are some popping up in the chat. I'd like to move now to our other virtual presenter, Dr. Levy.
Well, thank you, and I'm sorry I can't be there with all of you. This is so exciting for me because it really does require innovation and creativity to solve some of these issues, like the maternal health crisis in the US in general and in the state of Washington. It hasn't budged. I started working at ACOG, Carol, you'll remember this, in 2012, and we were talking about all these same things 12 years ago, and we haven't really moved the needle. So in my role as a chief medical officer for a virtual first women's health company, I'm trying to create ways to leverage resources. And I think we've heard, from Mary, and we've heard from Jessica, and we've heard from Sam. We have limited resources, particularly in the rural areas, but it's also true in the urban areas. The people practicing obstetrics who are willing to accept Medicaid patients are limited. And so how can we expand that workforce? How can we provide services that are convenient, that don't require a person who has 2 or 3 part-time, jobs to leave work where she now doesn't have money to put food on the table so that she can drive for an hour to wait in a doctor's office for a prenatal appointment? What are the things that we can do to provide more convenience, to provide more access, earlier care. And I think telemedicine is one of the things that can add value. But, and there's a big but here, and I'm really, really passionate about this, it can't further fragment the care. So one of the issues with a lot of what's available digitally and asynchronously and by telemedicine right now is that there's no collaboration with the in-person providers. And I honestly think that to provide the best service for our patients and our communities, it absolutely requires that collaboration. And it's got to be person-to-person collaboration, whether that's sharing a medical record. But it can't be that there's a telemedicine company out here and the patient can access it and ask me any question she wants, but I don't write a note that gets into her bricks and mortar prenatal care provider's record. And so that poor prenatal care provider doesn't have a clue what we talked about. And it puts the patient in the middle. Patient hears one thing from someone via telemedicine and hears something else from her provider in person, and that doesn't generate trust. So in order for telemedicine to work well, I think in the maternity, really truly in any space, we need a system whereby there's true collaboration. And the challenges are all the challenges we've been talking about all morning, one of which is payment. So when the prenatal care services are a bundled payment, how do I unbundle that to pay a telemedicine provider while still not shortchanging the bricks and mortar provider? So I think, you know, in the third world, some of the work that ACOG did while I was there in global health, it's very clear that we don't need 13 in-person prenatal visits. What we do need is an early risk assessment and then collaboration with the health plan. So working with Melina to understand that there are case managers and there are resources there that the patients don't know about and often the providers don't know about either. So what kind of a system can we set up that's inclusive of all the types of resources that will be needed to solve this problem? And how do we hold ourselves accountable to the results? Because when you're creative and you're innovative, we're going to make mistakes. And I think we have to fail fast. We have to learn what things work and what things don't work and move forward. And unfortunately, certainly our payment system is so cumbersome and so difficult, it doesn't change very fast. But we're going to have to be lighter on our feet. We're going to have to hold people accountable to communication, to holding the patient at the center of everything that we do, and then providing those resources around her so that we build that trust, but that we leverage what's out there. You know, in my telehealth company, one of the things that's mission critical for us is to hire midwives and women's health nurse practitioners and PAs and physicians who look like the patients we're treating. And so we have a very diverse provider workforce, and we're getting them licensed in many states so that they can provide care and fill those gaps. And Jessica, you brought up, you know, a really good point that our patients want people who look like them, who have a shared cultural experience to feel like they can trust. And doulas absolutely help, but it's not as good as, and we have good data to show that when the healthcare provider looks like the patient, the outcomes are better. So I do think that there's opportunity for telemedicine to be of value if it's done right. And if doing it right means close collaboration with the bricks and mortar providers, it means close collaboration with the health systems and the payers to make sure that it's a seamless experience for the patient.
Thank you so much, Barbara. Once again, we're seeing how much overlap there is in these different contributors to the problem. And once again, what I'm hearing is the opportunity for creativity, the clinical care model, who are the components of the care team, and creativity in terms of how the workforce is created, what they look like, even more importantly than where they're located. So last but definitely not least, we have Cindy, and I'm very much looking forward to hearing your perspective. It's a good thing it wasn't on. Oh, there's a red light.
Oh, there we go, Cindy. Oh, thank you. Okay, now there, I hear it. Okay. Oh, well, hello everyone, and I'm really excited to have this opportunity to talk with you. And what an amazing panel. And as I listen to all of these wonderful ideas, I'm just really hoping that we have reached that moment of critical mass where these ideas can finally burst into action, because this is really heartening to me to hear all these ideas and understandings. But for me, when I'm talking about American Indian and Alaska Native people, and I'm Tlingit, my homelands are in Southeast Alaska, as was said already. But when I talk about American Indian Alaska Native people, I have to do my standard disclaimer that I am only one Native woman from one tribe. And if you talk to any of the Native people in this room or elsewhere, you might get a different perspective, but I am going to do my best to give you a perspective today. And the other thing is that it's really hard for me to answer the question about contributors and prioritizations and solutions without giving some context into American Indian Alaska Native people. So I'd really like to start there. And one of the reasons that I can't say that I represent everybody is that as of January 2024, there are 574 federally recognized tribes in the United States. This number changes. There are still many tribes that are trying to gain federal recognition. And one of those is the Duwamish tribe, on whose traditional homelands we are on today, right now. In Washington state, we have 29 federally recognized tribes, and we have 2 urban Indian health organizations or clinics, one in Spokane and one in Seattle. And nationally, there are 41 of these urban Indian health organizations that are working to serve the thousands of American Indian Alaska Natives who live in urban areas and off reservation. And many of these urban people are there in those urban areas because of federal policies that again arose in the 1950s when the U.S. Congress tried to implement new termination policies to terminate the rights of Native Americans, their status and the treaty rights, and force assimilation into the overall American society. But these policies of genocide and assimilation are really nothing new to American Indian Alaska Natives. Really, they are the theme of our 500 plus year relationship. But the good news is that we are still here. We are still here. We are living on the lands that we call home. Our culture, our beliefs and values, our traditional ways of life have endured and have sustained us, and really they have saved us, because at times it was really touch and go. And we do bear a lot of scars from our battles, which are now seen, they're measured by these modern ideas of health disparities and social determinants of health disparities, and really the ongoing racism that we still know in our communities to exist. And some people may not see it, but we certainly are aware of it. And it's important to understand that Native American people are an oral tradition people. And so that means that we are wired to carry our history, our stories, our lineage within us, that we have long memories, and that the experiences of our ancestors and our relatives are important to us. And so that means that those 500 plus years of experiences and traumas that our ancestors and relatives went through are still meaningful to us today. And that's a really important point, because in those 500 plus years, there were a lot of horrific events that happened. And I don't want to go through all of them, but just a couple to help understanding was that researchers tell us that probably within a short amount of time of colonists coming, there was an 80 to 90% depopulation of Native people. And just think how horrific and scary and terrifying that would be. And then, of course, there was war, actual physical war, and then war on our culture and way of life. Then there was the forced removal from our homelands, from tribes' homelands, and then the forced relocation to lands that they didn't know or understand. And then probably most diabolical of all was the forced removal of our children from our homes and sent away to schools where they had to stay, and, went through a lot there. But to me, that was just such a horrible type of psychological warfare that really influenced generations of children, their parents, their tribes and communities. So these were really hard. And what people may not know is that even when the boarding school era ended, they were still taking Native children out of Native homes and placing them in non-Native homes. And this actually continued until the 1970s. Now, even as a child, and I'm an elder, so that was a while ago, but, not that long ago, that I still wondered, I remember this, why don't people like us? I recognize that even as a child. And the federal government, the colonists, the church, they really went all out in their efforts to eliminate and really destroy the traditional ways of life. And my point that I want to make is that this even continued into modern times with that, the example I just had, the urban relocation movement in the 50s. And then in the 60s, believe it or not, the Indian Health Service, who is entrusted with the healthcare for Native people, did sterilizations on Native women of childbearing age without their knowledge or consent in the 60s, and they estimate that probably 25% of the Native women at that time were sterilized. And then the failure to resolve jurisdictional issues that would protect Native women from murder and violence in their own homelands. And this continued and finally culminated into what is now known as the Missing, Murdered, and Indigenous Women and People movement, which was actually started by Native women to protect other Native women. And finally in the 70s, that was only 50 years ago, laws were finally passed that gave some protection to us. So there was a law to protect Native children so that they couldn't be removed from their families or their tribes. There was the American Indian Religious Freedom Act that we had to wait hundreds of years to get so that we could legally do our own spiritual practices and ceremonies. And another law in 1978 that actually gave tribes the authority to finally manage their own healthcare systems and their own educational systems. And so that is when the healing finally began for us. And so when we talk about the contributors and the solutions, I would really like to propose another contributor, and that is really the trauma from the 500 years of intentional genocide and trauma and racism that really caused so many mental, physical, emotional, and spiritual scars on our people, and that really need healing. And so healing is one of the first steps that needs to happen for us. And it's really hard for people to accept this, because for many people it happened hundreds of years ago. But again, for us, it's still in our memories, it's still in our hearts, it's still in our spirits. And so these things, they need to be healing. And part of our healing that, again, is hard for people to recognize is that a lot of our healing needs to be led by Native people themselves. And we call this tribally led and tribally driven work. And over time, you can see by just even the short synopsis I've given you that it's no wonder that Native people have a lot of trust issues, right? And we've come to recognize that if things are going to change, we have to advocate for ourselves. And that no one understands us and accepts our way of life, our ceremonies, our beliefs, our culture like we do. And so what we really need our allies to do is to recognize sovereignty, the sovereignty of tribes, and to uphold that and to work with the tribal leaders then in the way that they see fit on all of these issues, because all of these issues are issues in our community. Access to care, lack of access to care, lack of funding. People who have heard me speak before, anybody, a Native speaker, would know that now that the actual funding for Indian Health Services, that even the U.S. Government Accountability Office says that tribes are only funded at about 38% of need. And so in many tribes, there is no maternal infant health, much less OBGYN services that are available to us. So we really need the acceptance and support for tribally led solutions, because then the tribes who, my public health education and what has been expressed today is that people in the communities, they are the experts about what is happening in their communities and experts in their solutions, many beautiful solutions that have been discussed today. And so once we go through this healing process and we can get support for tribally driven solutions, then the tribes and the tribal leaders and the urban Indian leaders can then work with our allies, such as everyone in this room today, to come up with the solutions and the pathway forward, because as has been expressed many times, this is very complicated stuff. It's very complex. It's very interwoven. And so we all need help. We do know we need to work together. And again, so many beautiful, creative solutions and understandings expressed today. And I know that the tribal and urban Indian leaders would love to work with them and count on them, but it needs to be tribally led and tribally driven. So thank you very much.
Thank you so much, Cindy. That was a very elegant description of the overarching theme of really not just a lack of trust, but a complete absence of trust in some situations. And so while you can have access to care, having providers, having a creative integrated model, but if you don't have trust from the community, they aren't going to access that system. So that is such an important component to this conversation. Thank you all to my panel members for your thoughts and your expertise. I think we can open it up now if there are questions in the audience. And I saw some things come through on the chat, but I couldn't tell if they were questions or not.
I'm a licensed midwife and birth center owner in Olympia, Washington, and I have the honor of sitting on the maternal mortality review panel with Cindy. And one of the directives that has come out of our panel work has been to increase access to midwifery care and doulas. And while we made big strides on doula access in this legislative period, I'm wanting to know what is being done to promote midwifery care in Washington state, and specifically, what is being done to decrease the barriers for licensed midwives to be able to provide care in a hospital-based system. We have the ability to do that. We're licensed to be able to do that. The Smooth Start study that Carol mentioned showed that birth center care, the maternal mortality rate is 0.7 per 100,000, compared to 22 to 32, depending on whose numbers you look at, with decreased prematurity and increased satisfaction. So how are we going to get the midwives into the hospital to do the care? What's being done?
So I'm happy to talk a little bit about what we're thinking at the executive branch around how to kind of increase awareness and support for midwifery care. I can't really speak to how we get folks into hospitals as much, but maybe Mary Ann can speak a little bit to that. So last year, the governor had funds in his budget, his proposed budget, to send out grant dollars to folks like yourself who are interested or had recently opened a birth center in a community with need who was going to serve those with limited access. The legislature decided they wanted to do something a little bit different. I don't know why, but they did. There is and I apologize, I don't remember the dollar amount, but there is some funds in the state budget for that folks who own birth centers can access to help support them at this time. And we're continuing to look in our office about what we can do in the future. The governor is a big advocate for birth centers. We acknowledge the value and benefit of having options for folks. Not everyone wants to give birth in a hospital, and not everyone needs to give birth in a hospital. I think I was recently looking, in the UK, like 60% of births are tended to by midwives, and it's maybe 11% here in Washington. Maybe someone can correct me if I got the wrong number, but it's quite low. So we'd love to figure out how to increase that number. I'll just mention too, I know that there have been barriers for folks who are looking to open new facilities around getting licensure from the Department of Health, and that's something that we've been working really closely with DOH on to kind of reduce those barriers and make sure folks have access to the right, whether it's an architect who can help review plans. Sorry, I'm not a building person either, but make sure folks know how to navigate that complex licensure process. Someone at a hospital has a whole host of staff and legal resources to help them get through that. But, single proprietor businesses or just a number of folks who are not facility experts don't have that. So we're getting creative. We're trying to think about, are there opportunities to provide funds to get folks kind of like incubator grants, things like that. And I'm hoping that we'll be able to get some of those concepts into the governor's last budget this year.
And certainly from the hospitalist perspective, I can address that in that there is an opportunity in the collaborative care model and even a hybrid model from the hospitalist approach. And we have had a number of programs be very successful with that, where we've had midwives actually as part of the hospitalist team, or the physician hospitalist team supports and backs up an employed hospital group of midwives or a community practice where there is collaboration and potential medical oversight if they need a physician to have as their consultant or advisor or whatever it may be. But I think having that collaborative care model where the physicians and the midwives are working together, which is really what happens in the European model, is a significant opportunity. And we have been able to demonstrate that, at least from the hospitalist perspective, that can be successful. And I think patients want that too.
I'm wondering about the health of, over here, Sam, sorry. I'm wondering about the health of the scholarship and loan repayment program, because it feels like that is such a rich resource potentially for the state to really invest in providers. You could have a pipeline of people who, spend a few years working in rural areas, all different provider types. And I know there are people in this room who have benefited from the scholarship and loan repayment program. I'm just wondering, is there, what's the current state of that program, and is there potential for really bolstering it?
Great question, and I wish I had our higher education policy person here to answer it for me. I actually don't know. I know that program exists, and I know that there are lots of folks who are able to take advantage of it, but I also know that it maybe doesn't have as much funding as it could have. I love that idea. I'm going to write it down here in a second.
And not just scholarship and loan repayment, but potential stipend for people who are going to work in rural areas that so desperately need providers.
Yeah, I know we have some of our nurse practitioner programs have started using stipend programs, and it's certainly, I think folks will want to see the outcomes of that and, you know, figure out how we can extend that to other provider types as well.
And now we've got a question over here. Go ahead.
Hi. I'm going to read to prevent you from having to tolerate my rambling. My name is Laura McPherson. I am a nurse practitioner and one of the few very experienced midwives of color in Washington State, certainly in the Seattle area. My first doula client was over 20 years ago. So I've been in the field for a while. I maintain a small clinical practice at an FQHC in a really large healthcare organization in Seattle, but most of my work has changed to strategic consulting. And really my attention has turned to, it's really been captured by the experience of midwives of color and doulas of color who already exist and learners who are entering their practice. We want to serve our communities, and the current systems, steeped in white supremacy, steeped in patriarchy, just doesn't allow us to have longevity in our fields. If we want to increase cultural congruency, which I think that we do, I think that's pretty clear, we need to figure out how to support BIPOC folks who are doing the work right now and doing it without being harmed by the system. And I wonder, each of you mentioned workforce development, except maybe Cindy. And I wonder what's in your purview or what is in your area of some control that could make the field more sustainable for us and for upcoming BIPOC birth workers.
I can just speak briefly from a payer perspective, and this definitely will not answer the breadth of like what you shared. I think from a workforce perspective, something that we're focusing on is really the administrative burden that often impacts BIPOC workforce professionals and birth workers, because I know, and we've had a lot of conversations with the doulas and BIPOC midwives and providers, and often mirror your experience in the sense small clinic, maybe not part of a larger health system, even though it sounds like you're part of a larger FQHC. And what we're really hearing is, and I'm sure a lot of you in the room share this as well, people don't get into the work to contract and to file claims, and that's not their mission. And I think especially with smaller community practices, individualized practices, the administrative burden becomes a challenge. And I think that's something we're trying to collectively work with within our organization, with our provider partners, with our doula workforce, and also with the state, and really understand, like, we hold a piece of the puzzle, right? We can do better. We can support our providers better, our partners better. But it's also, like you said, it's a systemic issue. It's a long history of institutional racism and discrimination that have created these systems that are harmful to not only members, but the workforce. And so I think we all hold a piece of the puzzle, and that's what Melina is trying to work on, our piece, but also recognizing that it's collective work. So we have to work with our providers. We have to work with our members. We have to work with the state and really understand what's happening and what the opportunities are. So I know that's not an answer, but just that's how we're approaching it right now. We recognize it's a problem. We recognize that we can do better, and we're trying to start making strides in the right direction collaboratively with communities. So.
Great. Let's go online. There's a couple questions I know.
Yeah, there was just a comment and then a question. So the first, I just wanted to provide the comment was Within Reach has an employment trainee program for certified MA training. The individual felt that that model would work well for the midwifery training as well. Is there a comment? And then the question is the standby Medicaid facility fee proposed for rural birth centers in addition to rural hospitals? I would argue that for low risk, minimal intervention births, the costs are the same to staff, run, and keep the doors open.
Yes, so I can speak to that. I think there's a lot of places in maternity and elsewhere where the concept of a standby fee works very well. Another example is we're seeing in NICU care healthier and healthier babies being put into NICUs because of too many, maybe, perinatologists and NICUs. And we should be able to pay to have these critical resources available and then to give them to the people who need them. So that's a better allocation of payment. There's so getting back to the Strong Start program, it was focused on Medicaid beneficiaries. And there was this earlier question about birth centers, and unfortunately, Strong Start showed that with Medicaid beneficiaries in birth centers compared to typical Medicaid beneficiaries, the birth centers achieved lower rates of low birth weight, cesarean section, preterm birth, more vaginal birth after cesarean, higher rates of breastfeeding, sky-high satisfaction, and a lot of birth centers have to put limits on the number of Medicaid clients. So it's a beautiful model for them, but they have to put limits because of the insufficient reimbursement. So there's a federal act, BABIES is the acronym, and I can't tell you exactly what it stands for, but the purpose is to test what is needed for payment in birth centers. It's way less than hospitals, but it's way more than what birth centers are getting now. And one example is hospitals get large amounts of money for caring for the newborn, and many birth centers aren't getting anything for the services they provide to newborns. So we need to rethink our payment rates for birth centers and what those components look like in order to get the right rate and be able to bring that model to the people who could benefit from
it. Hi, this question is for Sam. So my name is Pete. I'm one of the high-risk providers at the University of Washington. And one of my primary I do a lot of outreach, telemedicine with Central Washington and Tri-Cities. So I manage actually a lot of patients in these rural deserts, so to speak. One of the inequities I see amongst the small and the barriers that we have is a lack of a baseline EMR for the small rural facilities. Your big facilities, your big care systems like for Yakima Valley Farm Workers, for instance, they have EMR, so their patients we can work with them and manage them very effectively. But then when you get into the small level 1 facilities, they don't, and they don't have the financial resources to have an EMR. They don't need the deluxe model, but they could have a baseline model. But I don't see them ever being able to have that because they don't have the financial capabilities. One of the things I would push from the state and from the governor's office is to think about that. If we can't, even as medical providers, communicate with the very people that need it the most, the patients that are the sickest, then how am I supposed to provide care? So I would think that communication is a big priority, and even just having a baseline EMR access would dramatically improve care in this state.
Yeah, and I know there are a lot of conversations happening between our office, the Healthcare Authority, and others who have facilities, so like the Department of Social and Health Services, which has healthcare facilities, and the Department of Corrections, which also serves a large number of folks in the state around increasing access to EHR. Our Department of Corrections uses paper records, so when they have to transfer a patient, some of them have literally boxes of paper records that have to go along with them. It is not great. So we certainly acknowledge that as the state. And Cindy, I hate to put you on the spot, but I also know that this is a challenge that many of our tribal health providers experience as well, the cost and the challenge of implementing an EMR. So, you know, that we
This question is for Carol. I noticed, I think I heard correctly, part of your model is to have 24/7 availability by telemedicine of consultants. And you mentioned the maternal fetal medicine, you mentioned some others. You did not mention OBs, but you had also said, I think, that there are lots of places where there are no OBs in the community. So my question is, why were obstetricians kept off the telemedicine 24/7 consultation part of your model?
So thank you for letting me clarify that, because obviously hearing from OBs would be fabulous, where their level of care and experience exceed whatever the arrangements are in the rural facility. So I didn't mean to exclude them, but I meant to say that when people are calling for urgent, emergent situations that they need help from, probably a lot of that could be handled by maternal fetal medicines and medicine specialists and perinatologists. So definitely OBs belong in there too.
We probably have time for one more question. Anything else online there, Emily?
Amy, I'd like to make a comment, a response. Okay. I would be really remiss if I didn't bring this up, that in tribal communities, we have a different look on provider types just due to need. And so some of the provider types that we have are, they're wanting to, I think they're calling them now mid-level provider types. So like people have heard about the community health aide and community health practitioners, dental health aide therapists, behavioral health aide therapists. And I know this is really hard for some people, because really in our country, we've really gone to over-medicalization of certification and education and licensure, which really does not serve our communities, and there may be other communities that it does not serve either. We're still working to up our high school graduation and work and this and that, and overcome some of these issues around racism that have been brought up already. And so these provider types we have, so like the dental health aide therapists, they do about 300 procedure codes, and then the higher level of care goes to the dentist. And so that works really well for us. The community health aides through telemedicine in rural Alaska, where I'm from, they're the first line of response, and then they're connected to their doctor by a phone line and a community health aid manual, and that's how they serve the people. And so we've had to do other creative ways of looking and meeting the need, because believe it or not, a lot of people don't want to come to the rural areas and live after they've gone through all their education, and they want to earn the salary they need to earn and have the lifestyle they want to, which isn't the lifestyle in our communities. And so I hope that people can really be open to those ideas, and especially with the midwives too. The American Indian Health Commission is doing a lot of community work right now. We're meeting in community and listening to community members and tribal and urban Indian leaders about what the needs are. And one of my favorite responses from one of the people about who is your dream team for giving birth, and they said a midwife, a doula, an elder, and WIC. So that is what works in our rural communities. And there are other people who say, well, we have so many health risks, we still need hospitals, and that's true too. Some people are not going to be comfortable, and they are going to need that higher level of care. But I think that that level of care is where you have the midwives as the first level, and then the higher level of care as needed, because there's a lot of people who need that, is really critical. But for us, it can't be just nurse midwives. We have to have support for licensed midwives and community midwives also, because it's so hard for us to even, I mean, that's another huge barrier to have to go to nursing school and then become a midwife, and that just looks like too much for our people. And I did want to respond to your question about the racism and bias, and I think we're all wondering that, right? And I think we just have to keep working it. We have to keep advocating for ourselves and for the people of color. And if we really want to make a difference in those health disparity numbers, we have to do it. We have to, if we're not working with people of color, we have to call ourselves and our organizations. Why aren't we? How can we? And how can we do it in a good and respectful way? And so we just have to keep working it. It's important. So thank you.
We knew this was going to be a lively conversation, and I'm glad to see we were correct. Thank you so much, everyone, all of my panel members, and for your audience participation. We're going to break now for lunch, but I'd like to also just add that if you have additional thoughts, comments, suggestions on this panel and its discussion, please feel free to write them on the flip charts on the side of the room over your lunch break. I'll come back with a brief summary after lunch. The community midwives should get their lunch and attend the CBDR training session that's going to be happening in Seoul, which I think is out into the right.
To the left.
Oh, yeah. Okay.
On the other side from the
other side of
where the food
Amsterdam, which is directly to the left. So you can get your lunch right next door in Amsterdam. CBDR training is just past that. We will start our afternoon session right at 1:20. So be in your seats at 1:19 for the next drawing for some of Dr. Olden's delicious wine. And I'll just add, for those of you that are virtual and you want to make any comments for the wrap-up discussion about the panel, please put those in the chat box, and we'll include those on the poster board up here for discussion. So thanks. Enjoy your lunch.
Oh, that's okay. Yeah. Okay. There you go. Okay. All right. Hi, everybody. I hope you guys are enjoying your lunch. My name is Carrie Nicholas. I'm the Measurement and Evaluation Manager with the BRE Collaborative. The BRE is a sister program of the COAPs. You'll see on your tables, we're conducting an evaluation of one of our guidelines that has just come out for perinatal behavioral health, and we're hoping to collect baseline data for 2024. And we're hoping to use the OB COAP as kind of way to measure outcomes. So we are looking for people to participate, and all the information is on there on your table. And Amelina, can you go to the next slide? Yeah. And we also just wanted to recognize, I think a lot of you guys are here from these organizations. The BRE and the foundation started an awards program this year, and we had many organizations who won awards for concordance of care with many of our BRE topic guidelines, and we had 2 organizations who won for excellence in equity, and that was Kaiser and United Healthcare. And then we had 2 finalists, but Multicare and UW Medicine. So we just wanted to recognize them. And if you guys participate in the perinatal behavioral health evaluation, you can also be eligible for the BRE Collaborative Awards. So thank you very much.
Try to keep all the local wineries busy.
Lost some conversation over there. Although I do not have to comment if you shut me down. I know, right? Me too. Like that.
I'll send mine. I'll actually have my number, send them in for you guys.
Great, I'm sure that, yep. Welcome back from lunch, everyone. So we're a couple minutes after when we promised we would do this, but we are now going to have a drawing, and Dr. Olden tells us that we can draw for 2 bottles in the post-lunch. So, you want to draw?
Make sure I don't pull my own name.
I don't think our names are in there.
Leslie Getz?
Leslie Getz, are you in the room? Oh,
yeah.
Well, Leslie Getz, if you're on virtual, you just lost a bottle of wine.
There's your wine.
She was only able to attend in the morning.
Oh, she's not even there.
Malachi Starling?
Malachi Starling, are you in the room? All right. Maybe 3rd time's a charm.
3rd or 4th time. If you're in the room, just write your name down and throw it in there really fast. All right. Jennifer Moore.
Jennifer Moore. Come and select your bottle of wine.
If you don't drink wine, you probably find a friend who will help you.
Okay, one more.
Yeah.
Great to have friends in the audience, right? Yeah. Teresa Mullen.
Teresa Mullen.
Teresa. Well, we'll put her back in then since they're still meeting. Yeah. Molly Firth.
Molly Firth. Come select your wine. All right. We have one more right by the end. Yes, we do. Those are the used ones. Right. Okay, so I'm just going to go ahead and get started with our afternoon since we're already a few minutes in. Just wanted to summarize. I see people didn't really add new comments to the flip charts in the room, but you know, the panel this morning right before lunch was a labor of love that really came from, like I said, when we were brainstorming what would be important components to the conversation in this meeting. it seemed like every single talk that was suggested had something to do with an access to care issue. And so it became this panel, and boy, I just so impressed with the passion, the expertise of the comments of our panel members, and the participation from the audience. So thank you so very much for that. Really what I pulled away from that session was, as I think I mentioned before, the opportunity for creativity. And that means creativity in the modeling. What does the healthcare group look like? What does the team, what does the healthcare team look like? And that means not only the color of their skin, their gender, their ethnic background, do they look like the community that they are serving in, but what type of provider, what's the category of provider we're looking at? Is this an OBGYN? Is this a midwife? Is this a nurse practitioner? Where can we integrate navigators into the healthcare team, right, that help with bridge some of those concerns about trust in the system and how to communicate and those sorts of things. So how can we get creative in building the healthcare teams in these communities that invite that bridge of trust from those that don't have it, but also access to care where there are a paucity of providers. So one of the powerful things about this organization is the collaborative voice and the collective voice that we have when we all are looking at what is going to be the really best thing for the patients in our communities. And so I look forward to chipping away at the resolve of the healthcare system as it stands today and inviting that creativity. And I really thank all of you for participating in that. I think our next speaker is going to be introduced by Angela. So I will invite you to come forth and take away
the podium. Welcome back from lunch. Thank you all for making it through the morning with us. I hope you've enjoyed the conference so far. We're pretty excited about what we've talked about. So we're going to talk a little bit about low-dose aspirin. And I think some of you may have joined us when we did a webinar, I can't remember when, but we did a webinar focusing on use of low-dose aspirin for patients identified as high risk for developing preeclampsia. I'm actually going to skip to the next slide before I introduce Melissa. This is a data slide. We added this low-dose, I call it the low-dose aspirin metric. This slide should look similar to what you saw when we looked at our steroid slides. Basically, the definition of the metric is in the left-hand column. We took the lowest hanging fruit. We said, let's pick go by ACOG and SMFM guidelines that say the pregnant people who are definitely at high risk of preeclampsia have one of those entities. And then in the numerator is really, do we see when we go into the chart that low-dose aspirin was recommended appropriately for this high-risk patient? So we started tracking the metric in 2022. You can kind of see performance across the board. It hasn't really budged over the last year. And then you'll see down below by the different levels of care and the different sites what the performance has been. It's a tough metric. I'm not going to lie. This is one of those metrics where we think it's important because it has clinical impact for our patients. But it's challenging to get. I think we've had, sites have had to figure out where is this going to be documented. You can't really just use the medications on admission because sometimes the low-dose aspirin doesn't get added on someone's medication list. And sometimes patients are now stopping their low-dose aspirin at 36 weeks. So when they come in to deliver, you might not see that they actually were recommended to take it from early on in pregnancy and just had stopped it before they came in to deliver. So we're still working on it, right? It's a work in progress. We feel confident that we will get this
rate up, whether it's by more rigorous documentation, whether it's by kind of with chart abstracting, making absolutely sure we're capturing it. But in OB-COAP now, we have some sites from Tulsa, Oklahoma. Oklahoma has been a really amazing state to work with. They have really embraced sort of pregnancy care, maternity care, expanding doula services over the course of the work they've done. And so I am really excited to have Melissa Ward come join us from the Oklahoma Perinatal QIC, Quality Improvement Collaborative. She serves as the project manager and really has led strategy development and implementation of their low-dose aspirin campaign. This is a statewide campaign, and I feel like I first heard about it maybe like not even a year ago. I feel like I first heard about one of my trips to Tulsa not that long ago, and she is here to share with us the work that they have done in Oklahoma. So this is the beauty of now having sites in other states so we can see what's being done elsewhere. So Melissa, I'm going to turn it over to you.
All right, perfect. And are you going to be advancing slides for me as well?
I am.
All right, excellent. It makes it easier on my end, I think, instead of having to navigate Zoom and talk at the same time. So anyways, thank you all for having me today. I'm really excited to be here and share some of the work that we're doing in Oklahoma. Again, my name is Melissa Ward. I work with the Oklahoma Perinatal Quality Improvement Collaborative, and I'll be discussing our low-dose aspirin initiative to reduce rates of preeclampsia and preterm birth in Oklahoma. Funding for this initiative was provided by the George Kaiser Family Foundation. So our learning objectives for today are to define the known short-term and long-term risks of preeclampsia to mom and baby, describe the benefits of low-dose aspirin therapy, and for you all to be able to name 2 steps to improve low-dose aspirin awareness that target providers, patients, and other healthcare professionals. So quickly, our agenda, I will share briefly about OPQIC, share some quick statistics about preeclampsia and preterm birth, how we diagnose preeclampsia and prevent it, our project goals. We will do an OBGYN gap analysis, and then cover our QI clinic toolkit and how to initiate change across the state, our public awareness campaign, and then finally we'll be open for a Q&A at the end. All right, so first I want to touch on what is a PQC. So most states have a PQC that is operating right now, and they were formed by the CDC to address maternal death rates and severe maternal morbidity rates that were increasing across the US, as well as to improve reproductive health. And the goal of a PQC is to advance evidence-based clinical practice through QI initiatives and collaboration with the goal of improving maternal and infant health at a population level. So if you look at this graphic on the left, I think that's a perfect example of all the different groups that we work with on a regular basis to try to improve care in Oklahoma. At OPQIC, our mission is to create a culture of excellence, safety, and equity in perinatal care. And we do this through a number of different initiatives. Not all of them are captured on here, of course, but Team Birth. We have launched Team Birth at all 44 birthing hospitals across Oklahoma. We have OMNO, which is Oklahoma Mothers and Newborns Affected by Opioids. We've successfully implemented AIM bundles into practice at multiple health systems across the state. We soon will have OB readiness in the ED, eliminating early elective delivery, and of course what we're talking about today, which is low-dose aspirin in pregnancy. So let's cover some quick stats. So preeclampsia is a leading cause of severe maternal morbidity and mortality in the US and worldwide. And preeclampsia is also responsible for 6% of all medically indicated early preterm births, so those that occur before 34 weeks of pregnancy, and 19% of preterm births or those before 37 weeks. The preterm birth rate in Oklahoma, unfortunately, is quite high. It's at 11.3%, and that's 2022 data. and it's much higher in Black individuals at 16.3%. Looking at our birth certificate data, out of the 48,000 live births that we had in 2022, 8.8% of those were complicated by a diagnosis of gestational hypertension and or preeclampsia. And for this initiative, for benchmarking, we used Sooner Care data, which is our state Medicaid agency. We looked at from 7/1/2022 to 6/30/2023, and we found that there were 2,445 Oklahoma Medicaid recipients that were diagnosed with just preeclampsia. Also of note is that over 50% of our births in Oklahoma are by individuals covered under Sooner Care. Additionally, 53% of Oklahoma counties are considered a maternity care desert, which makes it that much more difficult for individuals at high risk for preeclampsia to get to some of their regular prenatal appointments. They may have to take time off work to travel. Some of that time may not be paid. Then there's emergency care access. What happens if your blood pressure spikes and you don't have a birthing hospital near you? So that can also complicate matters. And then additionally, individuals who get preeclampsia are at a much higher risk for developing cardiovascular diseases later in life. So what is preeclampsia? Well, it does get referred to by many names, some of which I've heard that are not even on this list. Toxemia is an older term for it. Gestational hypertension is new onset hypertension that occurs after 20 weeks of pregnancy. Then there's preeclampsia with severe features, for example, a really high blood pressure reading. Superimposed preeclampsia, so the patient may have had controlled chronic hypertension before they became pregnant, but then they got preeclampsia on top of that. And it is sometimes accompanied by HELP syndrome, which can result in liver failure. And how we diagnose preeclampsia specifically, and what makes it different than gestational hypertension, is that preeclampsia is new onset hypertension after 20 weeks of pregnancy, diagnosed by a blood pressure reading of greater than 140/90, 2 readings 4 hours apart, or just 1 reading of 160/110, plus the presence of proteinuria. And so that just means that your kidneys are working very hard. And then it can also be accompanied by physical manifestations. So the warning signs are here on the left. Some of these include shortness of breath, swelling of face or hands, or even sudden weight gain. And I know if you've ever been pregnant before, a lot of these symptoms are something that we think as being common in pregnancy. I know personally I had shortness of breath, or, swelling of my feet or something like that. And that makes it easy for not only patients to justify these different symptoms, but also clinicians as well. Preeclampsia in the pregnant individual can lead to kidney, liver, or brain damage, blood clots, postpartum hemorrhage, eclampsia, stroke, or death. And then additional pregnancy complications can include preterm birth, placental abruption, fetal growth restriction, or low birth weight. And it's also important to note that although very rare, preeclampsia can occur in the postpartum period as well. We actually see higher rates of maternal mortality with postpartum preeclampsia, but it is not treated in the same way. So what causes preeclampsia? Well, it is thought to be caused by a problem with the placenta. In fact, it's known as the disease of theories because we still don't know why some people get it, why others don't. It could be multiple different disease states that fall under just the disease of preeclampsia. But ultimately, it's poor placenta formation, and this could be related to a number of causes. So you have chronic uteroplacental ischemia, which is poor blood flow to the baby, immune maladaptation, genetic imprinting, exaggerated inflammatory response to trophoblast development. But I think this image on the left best describes it. So you have poor remodeling of spiral arteries. So You always have these spiral arteries in your body, and throughout the course of your pregnancy, those spiral arteries should dilate to accommodate for the additional blood volume that will allow your baby to grow and get the nutrients it needs. However, in somebody that gets preeclampsia, those blood vessels do not remodel enough or don't remodel at all. And what happens then is, because you can't get those nutrients and blood flow to the baby, that can often result in maybe a small for gestational age baby, intrauterine growth restriction, and it can lead to increases in your blood pressure. And because we don't know why some people get preeclampsia and others don't, some people have all the risk factors and some hardly have any, maybe just one. We really need to focus on the prevention aspect of it, or at least delaying the onset of preeclampsia until we can get baby to 37 weeks gestation. Some of the long-term effects of preeclampsia I don't think get talked about enough. So your likelihood of developing chronic hypertension after a preeclampsia diagnosis is greater than 50% on average 14 years later. There's a 2 times higher risk of death from cardiovascular disease. And in women that get it before 34 weeks, that goes to a 4 to 8 times higher risk. And then 2 months ago, a paper came out that found that you have an increased early mortality risk that remains 40 years later if you experienced any of the following adverse pregnancy outcomes: preterm delivery, small for gestational age baby, preeclampsia or other hypertensive disorder, or gestational diabetes. And you may have also seen another article that recently came out that individuals who get preeclampsia are at a higher risk for developing early onset dementia. Children who are born premature are more likely to have vision, hearing, or learning disabilities, cerebral palsy, autism spectrum disorder, and a hypertensive disorder of pregnancy also increases the likelihood that that offspring will go on to develop hypertension, stroke, diabetes, and cardiovascular disease. And it's unclear if preeclampsia itself is a predictor of cardiovascular disease or if it's the causative agent. And I just want to draw attention to this image over here on the left as well. This was done by the Preeclampsia Foundation to capture patient voices. And the top one I think is so key. I didn't know this would be a lifelong problem. I work closely with March of Dimes in Oklahoma, and one of the people that I work with had preeclampsia many years ago and was shocked to find out that it could result in an increased risk for cardiovascular disease. And she's worked in this industry for over 20 years. So just think about some of the people that come across your office every single day that are unaware that they have these increased risk factors. So how does low-dose aspirin work? So aspirin itself is an NSAID, so it means it's a non-steroidal anti-inflammatory drug. And it's also an antiplatelet medication, so it reduces the stickiness of your red blood cells. And its method of action is to inhibit activity of cyclooxygenase enzymes. So you have the COX-1 enzyme, which lines the inner surface of your blood vessels and regulates 2 types of prostaglandins. You have prostacyclin, which is a vasodilator, so it allows those blood vessels to increase in size, and then thromboxane, which is a vasoconstrictor and allows those blood vessels to shrink. And then you have COX-2, which is produced related to inflammatory signals from the body. Like, let's say you bumped your knee, it would be produced in that situation. So if you were to take a regular strength dose of aspirin, which is 325 milligrams, it would inhibit both COX-1 and COX-2. However, with low dose aspirin, because it is a fraction of the dose, its only ability is to inhibit COX-1 enzymes' ability to produce thromboxane, that vasoconstrictor, but it does not affect prostacyclin. As a matter of fact, it's theorized, again, disease of theories, that in people who get preeclampsia, there is an imbalance of thromboxane and prostacyclin within their bodies. And a systematic review done by the United States Preventative Services Task Force of aspirin studies revealed there were no increased maternal or fetal risks associated with taking low-dose aspirin. As a matter of fact, I was surprised to learn that the first study on the relationship between aspirin and preeclampsia was actually done in 1978. So we have over 45 years of research that has looked at the relationship between aspirin and preeclampsia. And so based on an analysis of high quality aspirin studies involving over 20,000 women, the United States Preventative Services Task Force put out a recommendation statement for aspirin use to prevent preeclampsia and related morbidity and mortality in individuals with high risk factors. And looking at those studies, they found that low-dose aspirin significantly reduces rates of preeclampsia and other related conditions, including perinatal mortality, preterm birth, and fetal growth restriction. In August of 2023, the Society for Maternal Fetal Medicine put out a special statement regarding low-dose aspirin in pregnancy. And despite low-dose aspirin being recommended by ACOG, USPSTF, and Society for Maternal Fetal Medicine, they found that low-dose aspirin is still used in less than 50% of high risk and less than 25% of patients with more than one moderate risk factor. Patient surveys indicated only 58% of high risk and 5% of moderate risk patients recalled a provider even telling them to take it. And so low rates of use could be due to a number of factors. So one, low rates of prescribers recommending low-dose aspirin, or they're not aware of the most current guidelines for prescribing it. It does take a long time for a practice recommendation to become common practice. Patients may not remember receiving a recommendation. So when I think back to my first prenatal appointment, I was listening to baby's heartbeat for the first time. I was getting an ultrasound. I may have had to pee in a cup. I was answering a ton of questions. My husband was there. There was a lot of information coming at me very rapidly. And so for patients, they may not remember even being told to take low-dose aspirin. And then finally, patients may be hesitant to take it even though it is recommended. I mentioned earlier that it is an NSAID, and typically we're told not to take NSAIDs during pregnancy. Or you may have patients that are more naturally minded and would prefer to not really take a lot of medications outside of a prenatal pill during pregnancy. So the aim of our initiative is to reduce rates of preeclampsia and improve birth outcomes in Oklahoma by increasing the number of pregnant individuals taking low-dose aspirin. And how we do this is to ensure providers have access to the most current guidelines and are prescribing aspirin to eligible patients. We're providing education and informational materials that target nurses, pharmacists, doulas, midwives, and other community birth workers. And finally, a public awareness campaign regarding the benefits of aspirin that targets the general population. So now we'll cover some of the current recommendation guidelines. So according to these guidelines, it's estimated that about 70% of people could benefit from taking low-dose aspirin based on these risk factors. So some of the high risk factors, you have a history of preeclampsia, pregnant with multiples, pre-existing conditions such as chronic hypertension, diabetes, kidney disease, or autoimmune disease. But note, it also states combinations of multiple moderate risk factors. So it says recommend low-dose aspirin if the patient has 2 or more moderate risk factors. So the first one being nulliparity, you've never had a baby before. This is because sometimes it is difficult to predict who is going to get preeclampsia and who isn't. Obesity, so BMI over 30. We know that individuals that have a higher BMI are more prone to complications during their pregnancy, or they may have pre-existing comorbidities as well. Family history of preeclampsia. And then the next two are interesting. They're sociodemographic factors, and sociodemographic factors can certainly increase the stresses that you bear in life. For example, Black race, due to social rather than biological factors. And it sounds like you all talked about this earlier about access to care, limited access to care, or even having culturally competent care where people feel comfortable talking to their providers. A survey done by the CDC last year found that 1 in 3 Black or Hispanic Americans felt that they experienced some type of mistreatment during the course of their pregnancy, and that can certainly influence how you seek prenatal care. Low income. So the stresses that come along with low income, such as maybe it's a single parent household, higher rates of, domestic violence, housing insecurity, food insecurity, those type of factors. Age 35 years or older. So with this, we do know that there's a higher rate of maternal mortality and morbidity over 35 and especially over 40 years of age. And then personal history factors. So you were a low birth weight baby or small for gestational age. You had previous poor pregnancy outcomes, or it's been more than 10 years since you were pregnant. And then also IVF. I know we see a lot of people now that are seeking IVF to conceive. So looking at some of these moderate risk factors, you can basically see that a lot of people might qualify for taking aspirin on this based on this criteria. And I just want to draw your attention to this image on the right. So this is our 2016 U.S. gold medalist track team. What you see when you look at this picture is some really healthy, fit individuals celebrating. But what's tragic about this is that 3 out of 4 of these women had life-threatening complications related to pregnancy. So Allison Felix experienced preeclampsia at 32 weeks. Tiana Bartoletta had a preterm birth at 26 weeks. And Tori Bowie unfortunately passed away last year of respiratory distress and eclampsia. So I think this is just a stark reminder of some of the things that we face, especially amongst our Black population in the US, because the one thing that they all had in common was that they were Black race and it was also their first baby. So how do you take low-dose aspirin? So therapy is initiated at 12 weeks gestation or anytime between 12 and 16 weeks to get the max benefit. However, the new guidelines suggest that you can initiate therapy anytime between 12 and 28 weeks gestation. And I know this is beneficial for those people that don't get prompt prenatal care. So in Oklahoma specifically, about 14% of our population does not go to their first prenatal appointment until after 5 months of pregnancy. So there still is an opportunity for those individuals to have some modest benefit from starting aspirin therapy. And you take 1 tablet every day at bedtime until you give birth. There are very few contraindications. So if the patient has an aspirin allergy or hypersensitivity to NSAIDs, nasal polyps, or aspirin-induced acute bronchospasm, or a history of GI bleeding or active peptic ulcer disease, that could be a contraindication. And I just want to point out with aspirin allergy, you want to identify if they're actually allergic to aspirin itself or some of the inactive ingredients that might be present in some brands of aspirin tablets. Aspirin must also be taken greater than 90% of the time to be most effective. So when you think about your traditional medications, so for hypertension or cholesterol or diabetes, they need to be taken greater than 80% of the time for you to have a therapeutic benefit. But for aspirin, that threshold is much higher at 90%, likely because it is such a low dose. So we need to be creative in thinking of ways that we can get patients to remember to take their medication. So whether it be a pill minder or medication reminder apps, calendars, alarms, whatever works best for them, offering solutions to kind of bridge that gap, because for some, this may be the first time that they've ever had to take a daily medication. It also requires regular follow-up to identify if they are experiencing, any barriers to adopting medication or aspirin medication on a daily basis. So how do you administer it? So in Oklahoma, we are recommending you send an electronic prescription. For one, it does improve the medication reconciliation process. Typically, what has happened is when a patient is told to take aspirin, it's more of a recommendation, which doesn't really give it the same credibility to a patient, right? We add other things to MedRecs, like if they're taking, a daily vitamin, for example, but that is not always consistent across different institutions or health systems. And so that MedRec will travel with that individual as they seek prenatal care. Maybe they switch providers or go to different hospitals, whatever the case may be. We want them to have that MedRec that travels with them. Additionally, it also provides specific directions for use on the bottles. So take 1 tablet every time at bedtime until birth. And then in Oklahoma, because aspirin is a United States Preventative Services Task Force recommendation, such a mouthful every time I say that, but because it is a recommendation, they will pay for 100 tablets of low-dose aspirin for a 100-day supply for the prevention of preeclampsia in pregnant individuals. This is the only time that they will pay for aspirin OTC, as long as there is a script for it, and they do allow refills. I did check several commercial plan formularies, and it does look like most commercial plans will pay for it as well. Some alternative options are what has been done historically, which is instruct the patient to buy low-dose aspirin OTC at the drugstore. So there are a few barriers that come along with this. So timeliness of the purchase. Did that patient go that day to go buy low-dose aspirin from the drugstore or the grocery store? Maybe they thought, oh, I'll pick it up this weekend when I go. And then, like most of us, we get to the grocery store and forget half the things that were on our list to purchase. So, and at that point, you might just forget that you needed to get it in the first place. Then there's also the language that's on the aspirin bottles. And I don't know if you can see this, but I will read it for you. So this is on every brand of aspirin bottle. And I quote, "It is especially important not to use aspirin during the last 3 months of pregnancy unless definitely directed to do so by a doctor because it may cause problems in the unborn child or complications during delivery." Now, we know from the practice advisory from ACOG and from what was put out by USPSTF that is not necessarily the case. And so we don't want to dissuade a patient from continuing on with their aspirin therapy, especially in that last 3 months, because that's where you see the highest number of preeclampsia cases. So that language can certainly be confusing to those individuals. And then follow-up, is it added to the medication rec? And cost. We know a lot of things cost a lot more nowadays. And so if aspirin is too expensive, a person may choose to buy food for their family or a different medication that seems more important instead of purchasing low-dose aspirin. And then finally, providing aspirin on site is also an option. You could request it from a pharmaceutical rep, but there may be some barriers involved in that, including, tracking lot numbers and who you dispense it to, and drug sampling laws that may be going into effect in 2024. So that could be an additional problem. So now we're going to do a low-dose aspirin gap analysis. So looking at specifically an OBGYN practice, what are some things to consider? So one, what is the current protocol for prescribing aspirin? Are we all doing the same thing? What type of screening is done to identify who is eligible and who is not? What types of patient education is being offered? Is it consistent amongst providers? And what does patient follow-up look like? And in what ways are we ensuring that patients have access to aspirin? I mentioned Medicaid patients earlier, sending a prescription, but what about uninsured patients that may come in, or others that may have transportation barriers? They rely on other people to get them to their appointments. And then we have additional patient care gaps. So differences in recommendations amongst providers. So I talked to one doctor who said that he gives aspirin to every patient he has, except if they have one of those previous contraindications. And then I talked to another that told me only 5% of her patients are eligible for it. So there's definitely a disparity there in who is getting it and who isn't. I was actually on a webinar earlier today where they said that 41.9% of reproductive age individuals are considered obese right now. So obesity being a risk factor for preeclampsia, there's definitely an opportunity there to get aspirin in the hands of more people. Then there's the need for improved access to healthcare and prescriptions. It sounds like you guys talked a lot about access earlier. You know, do you have something in your community to go to, or do they live in a rural area where it makes it a real challenge? And siloed health professionals. So one doctor told me that he's constantly having to do aspirin re-education because, for example, his patient will go to urgent care, and when the urgent care professional finds out that they're taking low-dose aspirin, they're told, well, you can't take that in pregnancy. You even have different specialties where there was a nurse we talked to who specializes in neurology, and she had never heard of patients taking low-dose aspirin before. Or even pharmacists, you know, they know to tell patients not to take NSAIDs during pregnancy. Do they feel comfortable with low-dose aspirin? The patient not being considered as part of the care team in decision making. And so what this basically means is, like, are patients able to make informed decisions? You know, some individuals prefer written communication, some prefer verbal, and some prefer a combination of the two, perhaps to reinforce a certain behavior. And if they are not given the appropriate information about why they're told to take aspirin and what some of their risk factors could be, they may not be compliant with it. Next is lack of informational materials that span different education attainment levels or languages. So the average reading level in the US is an 8th grade reading level. And in addition, patient medical literacy can be a challenge as well. The CDC estimates that 9 out of 10 Americans struggle to make sense or make healthcare decisions based on medical jargon or complex medical terminology. And then finally, information as a social determinant of health. How we deliver it and where we deliver it and who delivers it can yield improved patient outcomes. If the individuals that are seeking prenatal care are not getting the appropriate information in the doctor's office and having a really constructive conversation about it, where are they going to turn to? Well, they're going to go home and they're going to, you know, ask friends and family. They're going to look it up on Google. They're going to ask people on Facebook. And so that really can impact how adherent they are going to be to taking aspirin as a medication. And I know this one will be difficult to read again, sorry, but I'll summarize it for you. So I worked with a researcher over in the UK who's doing really interesting work on analyzing patient behaviors when it comes to being prescribed aspirin in pregnancy. And she has put together a behavioral model that impacts whether or not individuals will take low-dose aspirin. So insufficient knowledge or being overwhelmed by the sheer amount of information that's provided. They're not buying into prevention. So they don't identify with risk factors, or they're kind of optimistic about pregnancy in general. And I know a lot of us think, well, it won't happen to me. Safety concerns regarding aspirin, or having a negative emotional response to just taking medications in general. And then, of course, access to medicine. So in the UK, you have to go ask a pharmacist to give you aspirin, and a lot of the pharmacists will not dispense it because they know you're not supposed to take it in pregnancy. And then finally, social influence. So the lack of social acceptability of medication use in pregnancy, or aspirin use particularly. And I love some of these. They interviewed several patients that were told to take low-dose aspirin, and I'm going to summarize a few of these. Quote, I know it's a painkiller, pain relief, it gets rid of headache, it thins your blood, and I know if you're going to have a heart attack, then stick one under your tongue. But when they prescribe these things, they don't tell you what exactly they're for. Quote, a lot of patients or people aren't fantastic readers either. There's still a lot of people who can't read very well. Next one, when I was told by the first doctor, I was still a bit skeptical, and it's only when I saw the second and third doctor it sunk in, and I thought it must be important as they're all saying the same thing. And next, women did not consider preeclampsia to be a serious disease. This led to a sense of optimism and reduced their sense of necessity in medication, as there were no visible consequences of not taking the medication. I kind of thought, if I'll get that, I'll get that. It wasn't a big deal. I mean, we don't call high blood pressure the silent killer for no reason. And it's because a lot of people don't really experience side effects related to high blood pressure. And so by the time, they address it, the damage could already be done. Slide. So how do we drive patient buy-in and compliance? So ideally, the patient would self-screen their eligibility for aspirin during their initial prenatal appointment. A nurse would guide them through the screening process, and a provider would discuss patient's eligibility for aspirin. Provider would issue easy-to-understand instructions on why aspirin is important and include teach-back. The patient would be given a prescription for aspirin, revisit aspirin compliant at each visit, and identify barriers to adoption. And the role of the doula. How can we use doulas to empower patients to be more proactive in asking questions, especially regarding their risk factors? And in Oklahoma, now doulas are covered under Medicaid, and they will be seeing a lot of high-risk patients. So it's vital that they're able to direct individuals to resources if they need it. So now I'm going to share our practice toolkit and implementation strategy. So clinical tools. So you may be familiar with some of the barriers we have with patient care, including we are all not using the same EHR system, right? Many of the large systems have moved over to Epic. Some of the more rural ones in Oklahoma are using Athena or Meditech. And so because of this, if you are wanting to get started quickly with doing low-dose aspirin in your clinic and screening patients, this might be something that you can use to jumpstart that, because oftentimes it does require a build from somebody within your institution to integrate these into EHR systems. So the first thing is a form that the patient would fill out during their first prenatal appointment. It would walk them through some of the risk factors. Now, I do want to say that all of our patient-facing materials are written at a 4th to 8th grade reading level to ensure the most amount of understanding. I know there may be some people that fall through the cracks on this, and hopefully the next tool can help bridge that gap. But this would walk the patient through some of those risk factors and then introduce the concept of aspirin. So before they've even stepped into the provider's room, they have a little bit of background knowledge about aspirin. Next is a preeclampsia risk assessment tool. So some people do integrate this type of thing into their EHR systems. Again, this is a paper form to help bridge that gap in the event that you're not able to do that at this time. And so it identifies, the nurse would go through this and identify if the patient had any of the following risk factors. And then they could do a standing order for aspirin. So when that provider comes in the room, they would know that that patient was eligible for aspirin based on some of their risk factors. And then next we have a provider decision tree. So this would walk providers through who is eligible and who is not to take low-dose aspirin, some prescribing options, etc. And then we have our patient-facing toolkit. So first thing we have is posters for office displays. So how can aspirin keep you and your baby healthy during pregnancy? So this QR code that's available on all these materials leads straight to the Preeclampsia Foundation's landing page on aspirin specifically. And for any of your patients that really struggle to understand written material, this is a great option for them. So they have a wonderful video on there that's available in English and Spanish. So if they are visually impaired, they can listen to it. But it walks them through like what preeclampsia is, how can aspirin help, what are some of the risk factors, etc. We have a trifold brochure. So this would ideally be given to any patient that was told to take low-dose aspirin on that particular day. So it introduces what is preeclampsia and eclampsia, what are some symptoms to look out for, how can aspirin help, how you take aspirin. And then next we have some waiting room brochures. Some providers in Oklahoma prefer to use this over the trifold. I say whatever works for you, use that. But again, this walks through some of the risk factors for preeclampsia and introduces the concept of aspirin. And so these could be kept in waiting rooms, in patient rooms, that sort of thing. And then adherence calendars. I mentioned earlier, aspirin needs to be taken 90% of the time to be most effective. Giving people options. If you really have somebody that struggles or says, I don't do medications, then this could be an option for them to tape on their bathroom mirror as a visual cue each day to cross off when they take low-dose aspirin. So this would be what an ideal workflow would look like. So patient would come in and complete that screening form during their first prenatal appointment. And then the nurse would go through the screening form with the patient or maybe ask their score. Provider would discuss aspirin eligibility and explain what aspirin does, and then provide an aspirin education brochure. The provider would e-scribe low-dose aspirin to the patient's preferred pharmacy. In the next phase, ideally, in the ideal world, we'll say patient attends all the following prenatal appointments. And if they maybe struggle due to access, hopefully they're sent home with a blood pressure monitor. A nurse would complete a med rec at each appointment and identify barriers to adoption for aspirin. And that would give the provider an opportunity to discuss any of those patient concerns regarding taking it. And then finally, when that patient presents to labor and delivery, they would be asked about prenatal vitamins and aspirin use in pregnancy. And with that, you know, early on when I was starting this project, I sent out a feeler to all the different nurses and health systems that we worked with. And I asked, do you all ask about aspirin use during pregnancy? And only one responded that they did. And it was only if it was on that patient's med rec. So got to do the med rec, got to add it on there. And then, of course, incorporating doulas. So how can they empower these patients to ask questions or direct patients to these different resources that are available? So how do you influence rapid change? So there's a couple different strategies. Not all of them are on this list, but this may get you started with some ideas. So one of the first things I did was actually submit a data request to our state Medicaid agency to get a list of all OBGYN clinics that have billed for prenatal care in Oklahoma, and also get a list of all the rendering providers. And I started with a letter writing campaign to different clinics across the state, just telling them the purpose of our initiative, showing them the evidence. So including a practice bulletin that talks about aspirin use in pregnancy. And then of course I included some of our toolkit samples as well. And then in the next phase, I actually called each one of those clinics and spoke to a leader within their organization to talk about our campaign and what we're trying to do. I also visited multiple OBGYN clinics across the state and asked to speak with nurse leaders. I asked for nurse leaders specifically because sometimes the person who's the clinic administrator serves a different role. And so I spoke with nurse leaders specifically, and this was great because I could ask them, like, have you heard about taking aspirin in pregnancy? What are some of the criteria you use to prescribe it? Did you know that Sooner Care will pay for low-dose aspirin prescriptions? And some of the answers I got were all across the board. And so, this is just one great way to really connect with some of those clinics, especially as a PQC. We mostly work in the hospital space with those labor and delivery teams. And so this was a great way to connect with those working out in the community. And then again, labor and delivery teams, are they seeing an increase in patients taking aspirin? I presented a lot of different things within our Oklahoma Nurse Forum or through A1. And I think it's great to get out there and ask people, what are you seeing? Newsletters. I used multiple, whatever I could think of. I probably wrote to them to see if I could get this initiative published. For example, the Oklahoma State Board of Pharmacy, I was able to get a blurb in there about our aspirin project coming. This was one of the first things I did too, because I wanted providers, clinicians out in the community to know that this was coming in the event that they started to see more patients ask about aspirin. I also reached out to the health colleges and different residency programs to see if I could connect with residents there. I used our state Medicaid authority to host a webinar. And I also reached out to multiple different professional organizations to get in their newsletters as well. I thought it was also important to involve those ancillary teams that are out there, like pharmacists and urgent care practitioners. So, I was able to connect with the Oklahoma Pharmacists Association and present to pharmacists through them about this initiative. I did a fax blast to all our urgent cares in Oklahoma. And I also connected with our new managed care organization. So that's something new for us that we're doing this year. This is the first time that we're using managed care to manage our Medicaid patients. And so we had 3 new groups that are coming in. And so I was able to meet with the chief medical officers of all of those different organizations, so we could come up with a plan to maybe add this as a quality metric. And then, of course, I think it's so vital to be visible in the community, because that's where you really know if you're making an impact or not. So hosting booths. I did one most recently with March of Dimes. They did a walk. And so I was able to not only just talk with clinicians who said, yeah, I'm seeing a lot more people taking aspirin, but also I could talk with some of the people that, are at March of Dimes because they've been affected by, preterm birth or a birth complication, and finding out what they knew about preeclampsia. And I was excited to learn some people had actually asked their doctors about taking aspirin. So I know that they're seeing our stuff. And then mass media, because OPQIC is housed under the OU Health Sciences Center, I connected with our MARCOM team and developed a press release. And so we were able to be featured on KOC. Well, you don't know these stations, but we were able to be featured for both Preeclampsia Awareness Month as well as American Heart Month. And now I'll share our public awareness campaign. So we are doing this in partnership with the Oklahoma State Department of Health. They are running one campaign. They have these social media posts on the left. They're featuring banner ads that you can click on that take them to their OSDH preeclampsia landing page. And they are also running television spots. We are all using the hashtag #AskAboutAspirin. And then this is an example of the OPQIC social media campaign. I mentioned earlier that I received funding for this from the George Kaiser Family Foundation, and part of what was earmarked was for social media, which has been great. So these are examples of some of the posts that we've done featuring the hashtag #AskAboutAspirin. They're available in both English and Spanish. All of them have a link to the Preeclampsia Foundation's aspirin page, and we found out from them that we are the leading driver of all traffic out of all the 50 states in the US to that landing page. So far, we've reached over 590,000 Oklahoma women, age range 18 to 55, and we've had over 32,000 clicks.
Love it.
And then March of Dimes has just announced last month that they are doing their low dose big benefits campaign to combat preeclampsia and preterm birth. And they are doing that with low dose aspirin. And so I mentioned Allison Felix earlier of that US Olympic track team. She is actually their spokesperson. So I'm excited to see more things come out about that campaign as they move forward. These are my sources. And my question page is missing, but that's okay. I am open for questions if you have any.
Oh, Melissa, I love it. Hashtag ask about aspirin. I love it. I feel like we should just steal it. Borrow it.
Do it.
Or get on your hashtag.
Melissa, we have a question from the virtual audience, and they were curious, how many languages did you provide your patient education on low dose aspirin, and how did you handle your illiterate clients?
So right now, we have it just available in English and Spanish. Now I have had requests to get it translated into Vietnamese and also Marshallese. So we have a large Marshallese population in the north part of our state. And so I would like to do that. The only complication I have is that I want to be able to direct people to a resource page where they can learn more information in their particular language. And because I don't have those resources yet, I have not translated it. But I'm hopeful that that will come. We do have somebody within our Oklahoma State Department of Health that is a Marshallese translator. And she reached out to a couple people to see if we could connect and see if we could get that translated. As for illiterate population, I have not really heard anything just as of yet. If anybody's struggling with that, in Oklahoma, about 20% of our population is Hispanic, and about 12% primarily speak Spanish in the household. And so, but we do see a lot of people that come in from Central America that really do struggle with literacy. And, I haven't heard just yet if they have struggled with any of those materials, but I'm always open to feedback. And if you ever try to use some of these materials, I'd love to hear if you find that the resource page that it directs to is helpful.
My question is that our maternal fetal medicine docs that we consult and refer to quite frequently, I've actually been recommending 2 low-dose aspirin. And so we've been getting a lot of feedback around doing 162 milligrams, and I'm just wondering if you could speak to that and the differences between the 81 milligrams.
Yeah, so actually what's interesting about this is that in the UK, they give out 150 milligram aspirin tablets. So anyone that is told to take low dose aspirin is taking 150 milligrams. That strength is not available in the US. And so that's likely why they're telling them to take 162 milligrams. In patients that are very high risk, that is kind of a common practice for those maternal fetal medicine doctors to do that. And you'll sometimes have patients that are aspirin non-responders, meaning even though they took low dose aspirin during their pregnancy, it didn't stop them from having severe preeclampsia. So in those specific patients, it might be better if they did have a higher dose, especially if, somebody does have a rather high BMI. that might be something that they would do. I do know that the Preeclampsia Foundation is doing some research right now on the 150 milligram dose to see if they have better health outcomes. So to answer your question, yes, that is a common practice amongst MFM providers. It has not been adopted by ACOG as of yet because I think they're waiting for just the appropriate research to come out.
But I think to your point, it's confusing to patients because they might get told by, you know, their primary OB provider to take, you know, the 81 milligrams. Then they see MFM who says 162 because there are studies that suggest 150 is most effective, which isn't available here. So then they just say 162. Then the patient gets nervous. They're like, well, I don't really know what to do. So then they don't start it because they don't know what dose to take. So that is an issue. I don't know, what do the Canadians do? It's a hot. Do you have 150 milligram aspirin?
No. We have the same. We have the same, I think, pharmaceutical provider. So no, we have the same issue. I think it's throughout North America. So we have the same issue where we have variable practice between 81 milligrams and 162 milligrams, or basically everything you just outlined, Angela. And I think that ultimately the Preeclampsia Foundation has announced an RCT where they're finally going to look at these two doses head to head, which is excellent. We've all been waiting for this for a long time, so we're really looking forward to that. There's a couple RCTs that have tried to look at the dose comparison directly, but they haven't been high quality, haven't been large enough. So I think this is really going to make a difference, like hopefully give us a definitive answer. I usually use 81, but I'm kind of, in Canada, I would say that the majority are moving towards 162. I think ultimately there are signals for more bleeding with a higher dose of low dose aspirin. So to me, I'm sort of waiting until there's really good evidence that, a higher dose is more effective before I would make that change in my practice.
Well, Melissa, thank you so much for sharing what you're doing in Oklahoma. I think it's remarkable because, again, this campaign, I think you got it launched and done in a very short amount of time. And I think you bring up really good points that I hadn't ever thought about, like actually prescribing the aspirin and making, actually having it be covered by insurance to make sure it lands in the med rec. I think patient education is really important. That is something I think having, infographics, having things visible on social media is really helpful. It's reassuring to patients when they're like, oh, I saw that on Instagram, because everything's real if it's on the gram.
Yeah.
But I do think that's, it's just really, thank you for sharing with us. I really would love Washington to do #AskAboutAspirin. I think it's a phenomenal hashtag. And it really engages patients to be proactive and to help us if we've missed that they're at risk. So thank you.
Thank you so much. I was happy to be here.
So we don't have a break, right? We're moving on. Okay. So last year, you may remember that we introduced our collaboration with Surgo Ventures regarding, sort of collaborating with them on the work that they have done with their maternal vulnerability index. I think on your tables, you all have, I think, a little bit of information about the MVI. But two members of the Surgo team are here with us, and we are grateful to them, as well as to Saba and Michael, who couldn't be here in person, and as well as to Ian Painter from our team, who we really leaned on heavily, or I did, for his epidemiology brain. But Hannah Kemp is Vice President of Impact and Growth for Surgo Health, where she oversees Surgo's portfolio of partnerships. And Nick Stewart is a Senior Research Scientist who's leading Surgo's initiatives in the realm of geospatial analytics, I'm like, that sounds really cool. And then I read the description. It's a combination of geographic information systems and AI technology with scientific methods to transform data into visual, actionable information. So that is what we are getting today. It's really fascinating work. I am super excited to have them share where we have gotten to at this point, since we started a year ago. So I'm going to have them come up and share. And I also think this is really cool, and it will also hurt my feelings if you don't find it equally as fascinating, but just saying.
All right, do we have a clicker up here? All right.
We are super excited. Okay, I'm gonna stand here. We are super excited to come here and present, and I actually think the timing of this session is perfect because this morning, you know, there was a really fantastic discussion around access to care, what those gaps are in different communities, and how different communities have different structural barriers. And one thing that I kind of took away from that discussion was a real, you know, kind of a consensus among the panelists was we need to meet patients where they are with accessible services based on who they are, where they are, and what they need. And so the MVI is one tool that we're really excited to kind of bring to today that helps to start unpack some of those factors from kind of a data perspective. So we are, let me, oops. Down. Okay, there we go. So Angela did a nice job of introducing Sergo, but as an organization, you know, our mission is really to put humans at the center of healthcare. And the way that we do that is actually by building data sets to help understand kind of why we're seeing different outcomes, what's driving human behavior, and what should health systems, payers, pharma companies, et cetera, do about it. We've been super fortunate to partner with COAP over the past, has it been 2 years? Yeah, over the past 2 years. And like, you know, on this is kind of pictures, I would be remiss talking about my team who's been working on this project as well as the fantastic COAP team. So we're going to talk about our key findings in a minute, and Nick's going to go through it in detail. But I just want to kind of say there's 3 main takeaways we want you to take from this discussion. And we're going to unpack all of these in the presentation, but I just want to start this upfront framing. 1, vulnerability matters for your patient outcomes. And we've shown this, and we're going to show this through our analysis today. The second thing is that race and other traditional SDOH factors are insufficient in actually telling you who's going to be most at risk. So there are factors that if you just look at SDOH or just look at race, that's not going to tell you the whole picture. And then the last thing is really that interventions upstream on the pregnancy journey are going to have the biggest impact. So we're going to unpack all of that in just a minute. But just kind of a quick framing. So this is a slide we like to use at the beginning of presentations where to really kind of talk about what's driving clinical outcomes. This is from a study, looks at kind of general, but I think very much applies to this context. Found that 80% of clinical outcomes are driven by factors outside of the 4 walls of a clinic. And so these include factors such as socioeconomic factors, how much money someone makes, you know, their type of family support, education, also includes physical environment. So what's their access to, say, you know, clean drinking water, pollution, et cetera, in their communities. Also includes health behaviors, you know, alcohol, drug use, tobacco use, et cetera. These are all factors that are super important in healthcare outcomes, but frankly, most healthcare data sets don't actually measure these. I do know from the last conversation, there has been some work of people in this room trying to actually get some of this data on patients and bring it into the EMR and the EHR. But, you know, when I talk to groups across the US, most of them tell me that this data, they rarely have it, right? It's kind of in some note somewhere and it's really hard to find. And so we have built the Maternal Vulnerability Index to try to unpack some of that. So this is a kind of first national scale tool that looks at maternal health risk factors at a community level. So across the US, what we found, right, is that there are different reasons, there's different areas of what we'll call maternal vulnerability or being vulnerable to adverse events, right? Where birthing people are most vulnerable. And there's different factors that affect that. So if you're looking at this map, right, the South looks really dark for reasons that many of us know, you know, less access to reproductive health care, fewer OBGYNs, you know, lack of Medicaid expansion, et cetera, et cetera. From this map, you can see Washington State compared to, say, Mississippi, overall looks much lighter. However, this gives us kind of a county by county level view. In our analysis, we actually went community by community or zip code by zip code, and it looks very different when you take that approach. So talking a little bit more, what is the MVI? It's a index that measures a lot of the upstream factors that at a community level. So it measures things like in a community, what's the access to reproductive health care, abortion services, family planning services? What's the overall access to healthcare in that community? What's the health system like, et cetera? What are access to mental health services? Or what's the overall rate of general physical health in the community? Is it an area where there's a lot of obesity, diabetes, high blood pressure, et cetera? These are all factors, actually, when you bring them together and look at an MVI, create an MVI score for a community, it actually is predictive of negative outcomes. So this is predictive of preterm birth, predictive of SMM, predictive of low birth weight, and even maternal mortality when you're looking at a national level. So just so everyone's on the same page, we thought let's break it down. What does it mean when we're going to define in this presentation what is kind of maternal vulnerability? So today, for this presentation, we're defining it based on where you live. So a patient living in, for example, zip code 98105, Seattle University District, we're going to call that a less vulnerable patient because the zip code where they live in is a less vulnerable area. So you've got better reproductive health care access, better mental health care access, et cetera. Compare that with, say, a patient living in Tacoma South End, 98418, right? That has a high vulnerability score. They've got less reproductive health care access, high socioeconomic disadvantage, et cetera. Just to say, this is one way, I just want to acknowledge, this is one way of looking at vulnerability. There's different ways you can do it, right? Including, doing individual questionnaires, asking patients, et cetera. But for the purposes today, this is kind of how we're thinking about it. A lot of the analysis that we're doing, that Nick is going to show you, compares patients who live in the most vulnerable areas, and we're defining those as the 20% most vulnerable communities in the state of Washington, to the patients living in the 20% least vulnerable communities or zip codes. And we're going to show you today how their outcomes are really quite different across every aspect of their pregnancy journey, and where we see those disparities being the biggest, and what should we be thinking about doing about it. I mentioned this earlier, this index we validated on multiple data sets from this OB-COAP data set, national data sets on maternal mortality, maternal morbidity. Essentially, patients who live in more vulnerable communities, 1.5 more times likely to have preterm birth, maternal death, low birth weight babies, et cetera, and there's actually more. We're really excited because this is, using the MVI is not something that just we've done with OB-COAP, but actually we're seeing some adoption of it across other health systems in the U.S. So here's just some examples of different kind of health systems, academic institutions, et cetera, who've actually begin to use this data set to help them look at what's going on with our patient outcomes, why are we seeing disparities, and what should we do about it. It's also been published in a number of papers in JAMA, in the Lancet, et cetera. We're happy to circulate those resources at the end of this discussion. All right, I'm going to hand it over to Nick, who has been the mastermind in doing a lot of this analysis. So over to you.
Great. All right. Thank you, Hannah, and thank you, OB-COAP, for allowing us to come here today and present our findings together. So let's get into some of the data and some of the results. So just to set up, methodologically speaking, what we did was we had access to this pretty much golden standard of obstetrics individual level clinical data. And we were able to take the zip code of where each individual patient resides and link that with our maternal vulnerability index. Obviously, our maternal vulnerability index can be available at different geographic levels, from the state all the way down to the neighborhood or census tract level. But what we were able to do here was the zip code for that level of granularity. So we were able to access over about 196,000 individual births from 2016 to 2022. And so really what we want to figure out is if this community level data that we have around barriers to maternal health care acts or shows up as another risk factor when considering individual level maternal health outcomes. And if so, what part along that pregnancy journey can we intervene to best mitigate that risk? So just as somewhat of a profiling, this is all of the hospital systems that have been anonymized across the OB COAP ecosystem. And we see that vulnerability is distributed across these hospital catchment areas. We see 3 of those top hospitals in pink are serving over 99% of their patients come from very high vulnerability communities or zip codes. And you can see only 2 of them are actually level 1, so hospitals. Then you see the majority of them actually have a pretty even case mix, where some of their patients may come from very high vulnerability communities, whereas others come from lower vulnerability communities within their catchment area. And then, of course, there are some hospitals that typically serve mostly low vulnerable populations. So as Hannah was alluding to previously, what we really wanted to do was take these clinical factors or these clinical covariates that are known at different stages of pregnancy, look at them alongside the MBI and see if they're predictive of specific maternal health outcomes. And if so, if the MBI has more of an effect on that prediction at different stages of pregnancy. So you can think during the pre-pregnancy stage, you would know the age of the mother, et cetera, initial BMI. During pregnancy, potentially gestational diabetes may crop in. At delivery, some procedural effects like if C-sections occurred, and then postpartum, maybe things like postpartum hemorrhage would be some of these clinical factors that we're looking at alongside of the MBI. And so I want to say that we were a little bit outcome agnostic when we were trying to fit some of these models. That being said, we really only wanted to see if we're not building a specifically diagnostic tool. We're not trying to say that if an individual comes into the clinic and we know their zip code level vulnerability, that we can predict with any certainty if SMM is going to occur, but we just want to see if it is an additional risk factor so that we can mitigate that risk in some sort of intervention. And so the behaviors that we looked at, we looked at 1 behavior, breastfeeding, 1 outcome, severe maternal morbidity, and then we also wanted to look at if the timing and adequacy, like other presentations have alluded to this morning, if access is an issue given your vulnerability profile. And so if we're only looking at vulnerability or the MBI score alone, we see that it univariately associates with SMM. And so you can see for the entire cohort that we were dealing with, the SMM prevalence among the 196,000 births, about 1.5% of the time SMM occurred. But you can see this linear trend that as you get higher in vulnerability, the more likely you are to experience SMM. And that held true for other behaviors and outcomes as well. Now, this is a little bit of an empty slide with just a key takeaway around being highlighted. But this is where we fit those, what we call multivariate regression models. We also looked at causal modeling as well, but that work is still in its infancy. So this is where we are controlling for those clinical risk factors. And we still see that the MVI from very low to very high vulnerability, if you come from a very high vulnerable area, you are 81% at higher risk of experiencing SMM compared to if you came from a person coming from a low vulnerability area, even when controlling for these factors. So what that means is take two birthing people of the same race, the same clinical profile, say they both have gestational diabetes, but they come from varying zip codes of varying vulnerability status. The birthing person coming from the very high vulnerable place, but it's still the same race and still has gestational diabetes, is 81% higher risk of experiencing SMM. So we do see that the MBI is an additional risk factor when considering these individual outcomes. And not only that, we were actually able to statistically pull out which covariates in this model add the most to that prediction of SMM and breastfeeding. And we see that vulnerability actually is higher in terms of the relevant importance to the prediction of SMM than some of those traditional groupings of SDOH, such as race. And so we're just pointing out here that the MBI should be it can be seen as another important risk factor to mitigate during the pregnancy journey. Now, one of the questions is where and how, importantly, do we mitigate these risks? So like I said before, we tried to fit these same models at different stages of the pregnancy with different known clinical risk factors at each one of those stages. And we see that the MBI has the largest effect on predicting severe maternal morbidity the further upstream in the pregnancy journey. We know that when it gets to the point of delivery, typically acute clinical factors subsume the effect of social behavioral vulnerability. So you're the only tools in your toolkit at the point of delivery are clinical in nature. It's going to be very hard to address transportation barriers or food insecurity at the point of delivery. So what our models are telling us is the further upstream in that pregnancy journey to mitigate these risks, the better it will be. And so the MBI is meant to be used as a tool, right? Maybe a targeting tool to help identify areas of additional need. And so how and when and can we intervene? So we know that typically at the point of delivery, at the clinical setting, it's too late to intervene on some of these metrics. So what can we do when the patient enters care, but before that point of delivery? And so we had access to certain data, mainly timing and frequency of prenatal care within the OB-COAP data set to be able to look at that and see if there's anything that can be done. So first question is timing, does timing matter? When we know that it's recommended for a birthing person to have their first prenatal antenatal care checkup within the first trimester, but does that really matter? And it seems that it does for behavior. There are lower rates of breastfeeding if a birthing person sought their first prenatal care checkup after the first trimester. And even, it seems more importantly, there are higher rates of SMM the later into pregnancy that first prenatal care checkup occurs. So then if we look at that by vulnerability profile, we see that the highest vulnerability categories, or people coming from those most vulnerable zip codes, are actually not getting the correct frequency or amount of antenatal care checkups that are recommended. And so this could be a place that we can plug in or use the MBI as a tool to better target how to intervene. So And I just want to say that even though adequate prenatal care is important, it is still not sufficient, because even when controlling for that as well, high vulnerability patients are still more likely to experience worse outcomes. So that's a lot of, it seems, negativity, but we can use this MBI not only as a way to diagnose what the issues are, but as a way to intervene as well, and a way to target these populations that need the most support. So this is actually an example of what we have done previously, actually pre-MBI, as a way to intervene and address some of these issues in our home of Washington, D.C. What we actually saw was that infant mortality rates seem to be occurring in the census tract or the neighborhoods that had the lowest transportation access to maternity care wards. And so based off this analysis, we were able to build a partnership with Uber, who Uber actually piloted did a pilot to run free transportation for specific patients of need to get them to their prenatal care appointments. And what we actually saw was an increase in attendance rates by over 8% on average for most patients. And given this initial success, they were actually able to secure more funding from local and state governments to be able to continue this effort. And so this is just one example that is related to transportation barriers specifically. That can be leveraged to try to intervene. But of course, the MBI is the usefulness of it is its modularity and the fact that it is composed of different themes, right? Not only transportation barriers, but also food insecurity, socioeconomic status, et cetera. So we can identify the largest needs of specific communities so that we can address and intervene appropriately. So just to sum up, we hope that we got these points across, but it seems vulnerability matters as we define it using the Maternal Vulnerability Index. Vulnerability seems to be a better or a larger risk when it comes to predicting outcomes than other traditional SDOH groupings. And if you can intervene upstream in the pregnancy journey, the better you will have to mitigate that risk. So really appreciate your time, and we're happy to take any questions.
First, mazel tov. Good show. I've been involved with OBCOAP since it started, so data, big deal. Two questions. One, you said SMM, that's the mother, and then you said 186,000 births. Sure. Well, those are, I mean, there's moms, there's babies. Breastfeeding is by the baby, SMM is by the mom. And people who have non-singletons are more likely to have preemies, blah, 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 blah. So can you correct for that? Okay.
Yes, yeah. So if you saw before, it said 196,000 births among 192,000 birthing people. So depending upon the outcome,
the first baby may still be a 28-weeker because they were triplets.
Yes.
But I know you can solve for it. I'm just mentioning it because SMM has nothing to do with breastfeeding.
True, true.
My second question, you use the zip code where the woman lives. She lives in wherever, and everybody knows that she's high risk, blah, 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 and she is sent to a level 3 center early or in the third trimester, or she's had 4 sections and she's got a prebian and a preterm, blah, 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 and she lives over there, and she spends her pregnancy over there. So that's a small number of people, but using where people live and where they deliver may mitigate some of the issue because they've already been sent to where they need to be.
True. No, point taken. And we try to account for that by taking we call it the hospital catchment area, right, where we take the patient zip codes where at least 5 patients delivered at that hospital, but then use their zip code of residence to do these analyses.
Thanks so much for that. Really interesting work. I have 2 questions. You can answer one or both or none. But the first one is, how did you decide what elements would go into the MPI initially? Like, what was that decision-making process like? And the second is, I was just interested by the sort of light blue centers you had that had the case mix, and if you've noticed anything with those, and if having a level of disparity within where you live, if that is better or worse, or how that kind of maps out.
Yeah, of course. So, so the initial part of building our indices is generally through an extensive literature review to find out which SDOH factors or other barriers are to maternal health care specifically. And then that needs to obviously map up with if data exists there. If data exists and it's freely available, we can get it. If not, can we purchase it? If not, can we feature engineer it ourselves, which in a lot of cases we do. So it's typically done through a literature review and an expert consultation that we develop a framework for our index and try to plug in. There's obviously a lot of statistical things where we don't want too much multicollinearity in the index. So it's a pretty rigorous process to get to the end result. In terms of for the light blue hospitals that have an even case mix, yes, we still see that even with those hospitals, if somebody comes from a higher vulnerability zip code, they're still going to have worse outcomes. So was that exactly?
Like if your zip code is somewhere where there might be more of a mix, like it's a region. I don't know if that's what that means, but like it's an area where there's people would have high and low vulnerability living in the same zip code, kind of thing. Does that end up being somewhere in the middle of the risk, or is it higher than what we expect or low?
No, that's a really good point. So zip code, that's one of the I think bottlenecks of a research like this, where we can only link at the zip code level, is that's still a very coarse geography. Like you said, there's still a lot of disparities within that zip code. So ideally, we would get as granular as possible to the zip code or to the census tract level, but within a zip code, yes, it kind of balances out to the average of the high versus low socioeconomic status within that zip code.
Can you go back a slide? We might go back and forth a couple times. Go back.
Of course.
Go back. Okay. You had a slide where you were showing the different things that were impacting outcomes.
Oh, yes. Yeah.
Right there. Okay. All of the things at the top make logical sense to me, except for the practitioner type of prenatal care. Can you give us a little more information about
Sure. So
what's going on
it seems
there?
like there are 4 different, so from the data, it seemed that there were 4 different types of practitioner that could be present at antenatal care checkups. And it seems we just added that as another variable to this model. And it seems that that could be a factor depending on how severe an outcome is.
So it might not actually influence
the
outcome. It's more on that. Based on, Can I jump in on that? So that's probably just confounding by indication. People who are at high risk see high risk.
Exactly.
Folks. Thank you.
Well, it's just that SMM, a mom who gets really, really sick and breastfeeding, the correlation for who your prenatal practitioner is and who breastfeeds, totally different. I mean, I think it's great that you use those 2 outcomes, because we know breastfeeding is incredibly important,
Mm-hmm.
and especially when the mom dies, that's a problem. But just to make the point, the prenatal practitioner has a huge effect on the outcome, on some of the outcomes. And yeah, you get it.
We've got an online question here, and then we'll go to you.
Yeah, the question online was wanting some further information. They still wanted to know whether the statistics can be evaluated for those who are in a vulnerable location with a rural hospital that provides delivery versus those delivering who have to travel to a low vulnerable area to deliver.
Mm. So in these models, we did not make that distinction. That would require, yes, but that I believe that is possible with this data set.
Hi, I'm the next speaker, and I'm going to be talking about substance use. So I'm really interested that maternal mortality and morbidity is at the bottom when it's the #1 cause of maternal mortality in this country. Both, the mental health diagnosis and alcohol and substance use are all the #1 cause of maternal mortality in many states. I don't know if it's in the entire country, but many states. So I think that's really interesting if it's just during pregnancy or during the whole postpartum period.
Yeah, for sure. I think so. That's a good distinction. So these are only these are only before delivery. Yes, but also that's why I wanted to make the disclaimer up front that we're not trying to create a diagnostic model per se. The actual this amount of covariates in the same model, there's potential that one could be subsuming the effect of another. So maybe substance use is a predictor of another acute clinical factor that may then subsume the effect of substance abuse. So that is something to be aware of in models where we have to fit many different covariates in the same model. And that could be one of the reasons that it's appearing lower on the importance.
On this, did you consider intimate partner violence as one of the factors?
Mm-hmm. We didn't have access to that type of data.
Yeah, I would love to.
Yeah.
We have that now, but because we had to go back far enough in the data set, it wasn't something we were collecting in order to have enough volume of cases to look at.
About 10 years ago in Ohio, tried to do something like this. Actually included where they had a family member that was incarcerated as an additional factor, and clearly that was related to outcomes in terms of maternal morbidity. Well, yeah, that too, but it was actually family member incarcerated was the metric they used.
Yeah, crime is one.
Less of a question, I guess, comment. I attended a really fantastic perinatal substance use and disorder conference, and it spoke a lot to that within your pregnancy, several of the outcomes for the mom are actually postpartum and within that 12-month period, which is what we do with the maternal mortality review panel. But with the substance use affecting the neonate, that kind of the most common outcome is really low birth weight or maybe preterm birth. That the reporting mechanism for people who have substance use disorder or even use prescribed medications that are misused or potentially misused, that their frequency of reporting, both the frequency and the amount, is affected by their use and by their comfort, like with the provider who's giving them care, whether they're reporting it in the hospital or to a prenatal provider and whether they receive prenatal care. So they reflected that there's actually really poor data on especially newer street available drugs and other novel drugs. It's really poor data on what the actual neonatal outcomes are that are negative outside of the classic low birth weight and preterm delivery. And so it seems less confounding to me that we don't see those in here.
because I think that they could be masked with some of those other outcomes. And we also have really poor data collection and historical integrity, not as a judgment, just historical integrity of what you're taking into your body. Also can't remember what we ate yesterday, let alone what we did for 40 weeks.
Maybe I'll just give a plug. So we've taken this data and actually profiled all the different member hospitals and kind of what your population looks like, what are some of the vulnerabilities, how does that play with outcomes, you know, and then also what are some potential interventions. If you are interested in seeing what your hospital looks like, please talk to us. We would love to share this with you. We've had some conversations with folks, but anyone who's interested, please raise your hand and we're happy to spend time with you.
Yes, let me know. Just, you know, contact Angela and I, and we will get a meeting set up so that we can look specifically at your site.
Well, and more to come. You know, we still have, I think, at least a year, right? A year to where we're still married for a year. So we still have some time. I think it's just fascinating because we as a state, right, we've continued to go round and round to say, how can we improve outcomes? But I think the hard thing is that different hospitals, different communities have different needs. So giving everyone the same solution, I don't know that it's working. So the hope when we started this project was to really try to identify, like, what are the needs in specific areas, specific communities for specific hospitals. I predominantly work at a very low vulnerability hospital. I probably don't need the same social services support as someone who's at a high vulnerability hospital. And I think we are working with a limited amount of funds. And at some point, I think we got to say, how do we fix this by getting the funding for the right things to the right communities? And that's equity. Right? When we talk about equity a lot, but are you going to get to equity with just making everything equal? I don't necessarily think so. So I think this work is super exciting. I mean, geospatial information and, you know, all of this science. And for the substance use disorder, I think part of it is, and we haven't been doing as robust of screening as you'll see. We have some data on that. Some of it, I think, is limitations of what's been built in the EHR. I think some of it is just ineptitude at doing the actual screening. Sadly, you know, I think that we have perhaps a lot more undiagnosed substance use disorder that isn't captured in the database or captured in the EHR. But yes, anyone who wants to see your hospital-specific dashboards, they're interesting. So, and many thanks to Hannah and Nick for traveling across the country to come show us their pretty flights.
And we'll take a break here. Please be back by 3:29 at the latest, maybe a couple minutes before. And if you haven't gotten a parking sticker or parking validation thing, please get one if you need that. Oh, and don't forget to put your raffle cards in the box.
All right. Trish Anderson. Not here. Okay. Rosie Romanesco? Out there? I'll put it back in there. But she's actually present, right? Danielle Henderson?
She is not here. Oh, Danny, if you're listening virtually.
Yeah, you're sad, yeah. Lindsay King? All right. I don't want to take it away from our speaker, so we'll give out the end of our speakers.
Do you have more wine? Oh, yes. Okay. Where's the, oh, here's, okay. Oh, thank you again to all our sponsors. Hopefully everyone's gotten stamped so you can enter in our final raffle. Okay, wait, I gotta get to the right slide. Sorry, we went back a minute. Your slides are very pretty though. I do have slides. Am I going the, oh, I'm not. Am I going the wrong way? Oh, weird. Okay, someone must have fixed it because previously, oh geez. So sorry, everyone. Okay, here we go. Okay, so let's talk a little bit about substance use disorder in pregnancy. So the last maternal mortality report in the state of Washington identified substance use disorder as a major contributing factor in many of our pregnancy-related deaths. You know, and spoiler alert, it hasn't necessarily been better. For those of you who sit on maternal mortality with me, you know, you're well aware that things haven't really changed that much. The Washington State Hospital Association and Department of Health partnered in 2022 to roll out a statewide initiative to improve screening, you know, recognition, care of the pregnant postpartum person. And I think that was rolled out as part of like the roadmap through WISHA. And in OB-COAP, we created fields to try to track the key elements recommended in the bundle. And we do have some data from that. But going back to the last talk with the Maternal Vulnerability Index, I think that substance use disorder during and before pregnancy is under-recognized. And I think the numbers in our database are small, which probably then makes the contribution seem smaller than it is in real life. So I'm going to show you first our slides before I introduce our speaker. Oh God, am I doing it wrong again? Okay, here we go. So, and thank you. We had a lovely graduate student, Patience Jaman, who made these slides for us. But this looks at when we look in the database and we look at all of our sites. The orange is the percent of times that SUD was identified as a complication of pregnancy. The purpley color is the pre-pregnancy substance use disorder. These numbers are lowish, but you know, definitely a contributor. When we look, however, at screening, you can see that the not screened or not documented population is still quite high. And I think, you know, I think lots of reasons for that. Some of it is if it's not, the SUD screening is not built into your EMR, it can be harder with our chart abstracted data registry to go in and find it. I think that's the case. I think a lot of times it's not being diligently done. That's my personal opinion. And I think that is problematic. But we show this data so that sites who are participating in OB-COAP, you can kind of see where you are and go back and try to figure out why are we not screening or why are we not documenting? Like that was one of the earliest tenets of that bundle that was rolled out in 2022 was to really increase rates of screening and using a vetted screening tool. So I think most of us are using the 5 Ps. So anyway, based on all of this work, you know, we really wanted to end the day with an expert in this field. Oh, and this is, again, I totally forgot we had this. This shows when we did do screening, how often patients screen positive and how often they screen negative. So we do have this data. We're continuing to collect it and just we'll probably report this out a little more frequently moving forward. But here we go. I am super excited to introduce Dr. Tricia Wright. She is an obstetrician gynecologist with the University of California, San Francisco, Betty Irene Moore Women's Hospital, and she's a professor at UCSF. She specializes in substance use disorders in pregnancy, addiction medicine, and mental health in women. I think she has a lot to share with us. She's, of course, very good friends with Vanya Rudolph. A lot of you know Vanya from a lot of the work she's done in the state. And Tricia and I trained together. So she was one of my senior residents way back in the 1990s. So we kind of laugh, we're like hashtag trauma bonded for life. So I really appreciate her flying here from San Francisco to come talk to us and just give us her perspectives as someone who's really been dedicated to this for, almost 20 years. So come on up. It's the up arrow.
Thanks, Angela. And I'm told it's up arrow. Okay, but that depends on which way you turn it. That could be it. Okay. Okay, good. All right. So I want to echo everything that Angela said about just our lack of screening and how we don't ask the questions. So of course we don't know the answers. And when I started at UCSF, I was told, oh, we don't have those patients in our clinics. And I'm like, A, as Angela just said, those patients and are us. And B, yes, you do. You're just not asking the question, because substance use disorders don't discriminate by socioeconomic class or education. I have no relevant disclosures. Just the objectives of my talk is to really realize the roles of policies and attitudes towards people who use drugs contribute to excess maternal mortality. Really incorporating reproductive justice principles into the care of people with substance use disorders, implement a validated screening methods into preconception and prenatal care, and providing obstetric care for the patients with SUD. To go back to the screening, we're working on that right now, and our hospital, I work at 2 different hospital systems, UCSF and San Francisco General. And San Francisco General is our county hospital, and they've actually had a screening process built into EPIC for a couple of years, and we're still working on it at UCSF. And I just got an email from the other day. We're also trying to work on trauma screening, and the nurse that sent me the email is like, the nurses have so many questions they need to ask. I'm like, yes. And what else is going to really impact the maternal mortality? Anything more than this. So to start off with a really sad case that just really points out the harms of stigmatization and the reasons why I talk about a lot of inclusive language and, really treating patients with dignity and respect. So before I moved to California, I was at the University of Hawaii for 17 years and started a clinic there for substance use disorders during pregnancy. And this is a patient that presented to one of my partners at a federal qualified health center. She presented at 27 weeks for her first prenatal visit. At that time, she had had a history of severe meth-associated cardiomyopathy. Her ejection fraction was 15%, so really, really sick. And my partner tried to send her to the hospital, tried to get her admitted. She refused to go. And she also asked her, why she hadn't gone to the doctor since the last time she gave birth. They're all so mean to me when I go. Unfortunately, this does not have a happy ending. She, at 32 weeks, had a cardiac arrest, was brought in arrest with the partner immediately began CPR. They got return of spontaneous circulation in the ED after doing an emergency C-section. Both she and the infant ended up on life support for a week before they both had care withdrawn. So just a horrible, reason why we need to not stigmatize these patients. We can see the U.S. trends in drug overdose mortality among pregnant and postpartum patients from 2017 to 2020, and you can see how they're continuing to increase, and they're really, it's driven by fentanyl and other synthetic opioids. Now we have xylazine adding to that, and also something isonitazine, which our patients are stating they're using, and it's making it really, really hard to get them comfortable on opioid replacement. And then if you also look, the second biggest driver is psychostimulants, so the methamphetamines and cocaine. And as we've mentioned, it's not happening so much in pregnancy, but late postpartum. But pregnancy is also increasing. This is just lessons that the four of us have all sat on maternal mortality reviews, as Angela mentioned, and found that, there's a lot of missed opportunities that are happening for pregnant and postpartum people. And the postpartum period especially is a critical time, and healthcare systems are really ignoring the signs. This is just some studies that came back from earlier on in this was published in 2016, just from Colorado, showing that suicide or accidental overdose was the #1 cause. And again, in the postpartum period. And this is just a perfect storm of all of the things that can happen to pregnant and postpartum people and contributing to excess mortality. We know that women were overrepresented in the initial opioid epidemic. The states where Medicaid, women lose Medicaid coverage at 6 weeks postpartum, association of drug use with homicide and suicide, interpersonal violence, as someone mentioned. There's a push to have patients, especially in some of the places in the rural South, a push to detox, for legitimate reasons if there's no place to provide opioid replacement therapy, which I would say is not really a legitimate reason, but at least a little bit more understanding. But also from this misguided belief that neonatal withdrawal is so harmful that we need to put moms in a vulnerable position for relapse and overdose, just to prevent a hospital stay. Stigma and discrimination of pregnant people accessing care, and also I found a anesthesia article about increased vulnerability of infectious disease and other complications during pregnancy from the drug use. We know that drug-related criminal justice is high, and it contributes to patients not obtaining prenatal care. Women are a fast-growing proportion of the U.S. population. Over 61% of women are in federal prison for non-violent drug-related crimes. Plea bargaining punishes those not willing to inform on others. They get conspiracy charges. And when anybody is incarcerated, it really impairs their ability to obtain public assistance, a job, or housing, which contributes to the problem. We know that pregnant people who use drugs are uniquely vulnerable to criminal justice and child welfare involvement, and there's racial disparities in arrests. Black birthing people are 2 times more likely to be arrested, Latinas 20% more likely, and the Native population is 6 times more likely. So we know that criminalization of drug use puts parents of the fetus at great risks and creates barriers to treatment and obtaining prenatal care. We know that prisons and jails still use restraints despite the fact that they're not supposed to. We had a patient incarcerated in our hospital last week when I was on the addiction care service, and she was chained to her bed. She was not in labor, so it wasn't technically doing anything wrong, but she couldn't move around, which is not very good for a antepartum patient. And they also deny breastfeeding. We know that pregnancy outcomes have increasingly been criminalized in this country. Lynn Paltrow of Pregnancy Justice has written a couple of papers on this. The first one she looked at from 2006, or before 2006, and saw 419 cases in the 33-year period prior to that. Since 2006, there's been almost 4 times as many, or 3 times as many. 9 out of 10 were because of substance use during pregnancy, mainly methamphetamines, cannabis, and cocaine. But 1 in 4 were for legal substances, mainly prescription opioids. 85% were medically indigent, and 1 in 3 cases were initially reported by a medical professional. So that sounds like, do no harm. We're doing a lot of harm by doing that. 2 in 5 were involved family regulation workers, so child welfare. Black and poor white people were vastly overrepresented, and 2/3 of these cases involved a normal pregnancy outcome. So we know ACOG has come out strongly against this, saying it's neither ethical nor effective. And we know it correlates very strongly with states that have poor reproductive justice and reproductive access to care, also don't provide the full range of drug treatment. So showing that the evidence base of both is being ignored. Just a reminder of some reproductive justice principles in a condition in which all people have reproductive rights regardless of economic status, race or ethnicity, immigration status, sexual preference, or gender identity. Sister Song and other groups are some of the origins of this term. And this is not just accessible abortion and family planning, but also the ability to have a child that is free from crime and all sorts of other adverse environmental problems. Reproductive justice and drugs, as Lynn Paltrow's quote reminds us, that efforts to control reproduction and drugs are rooted in forms of bigotry and prejudice that are essentially the same. We know that Black and Native women are particularly harmed by them. These efforts reflect a common political agenda and draw attention away from real underlying issues that are hard to solve, but that would actually do more good: poverty, race discrimination, and a lack of a coherent national healthcare policy. So those who fight against each of them must recognize that they have a common cause and need a comprehensive strategy to address both as a fundamental issues of social justice. So we know that harmful policies are discriminatory in application. They're not grounded in science. We know that the harms of the illicit drug use are exaggerated, but the illicit drug use harms are minimized. So we know that the two most harmful things that people use during pregnancy are alcohol and tobacco, and yet those aren't routinely screened for because it's not easy to do. I mean, it's easy to do a urine toxicology. Interpreting it is another problem. But this leads to radiating consequences of pregnant people avoiding prenatal care and avoiding drug treatment. So what are some of the recording requirements and adverse outcomes, and how are they related? So this is just a timeline of how the child welfare system came about and how these concepts came about. CAPTA was the first line, Child Abuse and Prevention Treatment Act in 1974. This is what established the current child welfare system and defines mandated reported. The various iterations since then establishes the timelines for termination of parental rights and creates additional barriers to family reunification. The plan of safe care was first mentioned in 2003, but however, it was CARA that came out in 2016 to address maternal substance use and requires a plan of safe care for all infants exposed to substances, including fetal alcohol effects. So it was supposed to be a good thing to provide services to these children and families, but ended up really doing the opposite, as I'll show. So it's federal legislation. However, states have a wide range of how their own reporting requirements are structured to comply with CAPTA. The requirements vary from state to state, and they're incredibly vague. So different states have different definitions on who is a mandated reporter, what constitutes reported child abuse or neglect, and when medical professionals have to report it. It does say all substances affected newborns must be provided with a plan of safe care, and all plans of safe care must be shared with the child welfare agency. So some welfare agencies will say, just report, you can do it anonymously, and that's what some states have done, is just, so this is that we've done, and because it's different from a Child Protective Services report. And that's where the confusion comes in, and our own risk has this wrong. So, and we can see how since 2000, the children the infants that are taken into custody from less than one. So this is probably directly responsible or directly related to removals at birth have increased with each iteration of this law. We know the harms of family separation are multitude, and one of these data people, I really, really want to look at the role of child welfare and maternal mortality, because there has been a couple articles from Canada looking at this and seeing the relationship of dyadic separation and adverse maternal outcomes. So we know that there's an increased risk of relapse, overdose, and maternal mortality. A fear of child welfare really is a big driver of avoidance of prenatal care. We know that after separation, there's an increased exposure to housing instability, intermittent partner violence, and initiation of injection drug use and sex work. And we know that the repeated substance-exposed pregnancies is 3 times higher in those who have child separation or dyadic separation. For the infant or child, so it's not just harmful for the mom, it's also harmful for the child. We know that foster care involvement in separation from the birthing parent, it heightens autonomic nervous system activity, really counts as the first adverse childhood event. And we know that ACEs lead to things like obesity, hypertension, and diabetes. Decreased growth in brain development, insecure, disorganized attachment, and subsequent mental health problems. And we know that foster care involved youth have higher rates of delinquency, teen pregnancy, economic disadvantages, homelessness, and incarceration than their peers. This is just an example of some state guidelines. I put Washington up here because yours is one of the least onerous and one of the most clear. And then I compared it with California, which you would think would be better. But it basically says a drug test on a pregnant or birthing person is not required by law. If screening indicates the need for a drug test, providers should ask for and get informed consent prior to drug testing a pregnant or birthing person. A drug test on a newborn is not required by law, and a positive drug test or indication of a newborn is substance affected does not trigger a mandatory report. California says similar things. However, it also says the results of a toxicology test alone do not require a report of child abuse or neglect. But if other factors are present that indicate risk of a child, a provider must report to the Department of Social Services. And talk about something very vague and not very clear. And we know that anytime there's vague things, that racial disparities will happen. We know that Black women with substance use disorders are 10 times more likely to be reported to child welfare. In California, one of 2 Black or Native families are subjected to child welfare investigation. So not necessary separation, but think about the stress of having child welfare come into your life and, micro analyze all of your parenting behavior. 1 of 2 versus 26% of California children. I think 26 sounds really high to me. And we know that in California, 21.5% of foster children are Black identifying, despite being only 5.4% of the childhood population. And Native children are equally overrepresented, 1.24% versus 0.3%. So how can we achieve a better outcome? Using a universal screening tool with a validated tool. Angela mentioned the 5 Ps. We're working on implementing at least the NIDA 4 or the TAP screen into ours. We know that providing prenatal care and treating substance use disorder with evidence-based treatments and really working to eliminate stigma and discrimination amongst ourselves. So the validated screens that have been used in pregnancy, the TAPS one, which is the formerly the NIDA4, and I'll show you that. The 4Ps or 5Ps, depending on if you want to pay someone or not, or the CERT-P are all validated screens. And then the most important thing is a screen is just that. It's like a pap smear. You cast a wide net, and then you follow up with an exam, with an assessment, which is your colposcopy. So you really want to, it's okay if too many people are answering positive, which is something our nurses don't understand because they use the one question screen if they've ever drunk more than 4 drinks on one occasion. And it makes everybody seem like they have an alcohol problem. I'm like, no, you're just trying to, screen out all the people that don't drink, because you don't need to do an assessment on those. This is a pyramid that stratifies people. So you do universal screening, and you can do that either verbal, computer-based, building it into your EHR, I think is probably the best way. Some centers have given iPads with the screening questions, and then they can actually do the intervention there. And that's, I think, would be ideal, because then nurses don't have to talk to patients about it. Well, ideally, we just talk to it like any other medical condition, but in the meantime. So the whole point of the screening is to identify the patients who are at moderate or high risk. So 70% of your patients will be at low risk, and you don't need to do anything more. And you just say brief advice, that's great, you're not drinking during pregnancy. It's the 5%, 4 to 5% who are at high risk at the top of the pyramid, who are continuing to use during pregnancy, who likely have a substance use disorder and need specialized treatment. Those in the moderate risk are those that may have had low-level use during pregnancy, and those benefit from some brief intervention and some motivational interviewing to, kind of get them to work on their behavioral change. Why is urine toxicology not a useful screening test? It really, it should only be done with patient consent, which is what the majority of the language says. It really has been used to incarcerate women and remove children. There's many false positives, especially in pregnancy. Things that we give all the time, like labetalol, can give you a false positive for methamphetamines. It doesn't say anything about parenting skills, just because it just shows they've had exposure to a drug in the last 72 hours. So it doesn't say anything about long-term use before. And so the best way is to really have a conversation with patients. And it doesn't pick up alcohol and tobacco, which, as I said, are the most harmful substances used during pregnancy. So getting patients on opioid agonist therapy, why are we recommending switching it gears a little bit? We know that opioid agonist therapy has maternal and fetal benefits. The maternal benefits has a 70% reduction in overdose-related deaths, and also has a 50% reduction in all-cause mortality. Nothing else we do in medicine has that much of a decrease for one intervention. So really making sure patients with opioid use disorder are on opioid agonist therapy is really important. In pregnancy, that's either buprenorphine or methadone. You get a decreased risk of HIV, hepatitis B, and hepatitis C, increased engagement in prenatal care and recovery treatment. And for the fetal benefits, we know that when a birthing parent is continuing to use short-acting, either heroin or fentanyl or something off the street, they're constantly in a state of intoxication and withdrawal. And so the levels are going back and forth. And so the fetus is seeing those same fluctuations and getting all of those catecholamine release, which increases fetal stress. We know that providing opioid agonist therapy by leveling out mom's levels decreases intrauterine fetal demise, intrauterine growth restriction, and decreases preterm delivery. So we know that methadone versus buprenorphine, which one's better for the treatment of opioid use in pregnancy? And the answer is it depends. The basics, just for those of you who don't prescribe them all the time or don't use them all the time, methadone is a full agonist on the mu receptor, so it fully activates it. Has all of the opioid side effects such as respiratory depression, sedation, constipation, and also QT prolongation if it's over 100 milligrams. The pharmacokinetics onset of action is very quick, 30 minutes to an hour. However, the initial peak is 3 to 4 hours, and so that's why we go around assessing people at peak dose to see about oversedation. And the other thing is it takes 3 to 5 days to get to a steady state before we can really do much of a dose increase, because unlike other opiates, it has a stacking effect. So each dose can increase the effects of the previous dose. So that is why the axiom is always start low, go slow. Fentanyl has changed all of that, and we're starting a little higher and going a little faster because we know that patients have very high tolerances and can tolerate a lot more. Difference with buprenorphine, it's a partial agonist on the mu receptor. It comes in combination of monoproducts, tablets, films, patches, and injections are different forms. Some of the side effects, just constipation and headache, pretty well tolerated. However, that one of the problems with it is it can cause precipitated withdrawal, and especially in the age of fentanyl. Patients on fentanyl have their levels, if they've been using it chronically, the levels have built up in their system and in the fat stores. So even 3 to 5 days later, they can still have precipitated withdrawal. So consultation with someone who knows how to do this, either start low or start high, don't start medium. The choice should really, they're both safe and effective, and the choice is complex and should be patient-centered and really individualized. Based on the available options, we know that some of the rural areas don't have methadone clinics, you know, just patient preference. It's really hard to go methadone. They have to go to a clinic every day until they've been stable enough to get take-home doses. We're working on trying to liberalize methadone, or liberate, that's the word I'm looking for, methadone. Patients' previous treatment experiences, if they've had precipitated withdrawal, they don't likely like to go back to it. But we can, you know, work with them and say if they really, you know, need to be on buprenorphine for logistic reasons, there are ways to get them on without precipitated withdrawal. Disease severity, social support, and intensity of treatment needed. Going to the methadone clinic every day can provide necessary social support for people who are very vulnerable. And then obviously which opioid is used. This table just shows some of the benefits. It's a little hard to read, but the benefits of methadone versus buprenorphine. We know that buprenorphine is associated with less preterm labor, less need for treatment of opioid use, or neonatal opioid withdrawal, and maternal medical complications. However, a lot of these things that is favored is due to the problems with the way that we have to give methadone. If we can give methadone in a split dose, and if we could give it in a more medical versus having to go to a clinic every day and less stigmatized, it may no longer favor buprenorphine. What is neonatal withdrawal? It's a generalized disorder of the dysfunction of the autonomic nervous system in the neonate, mainly involving the autonomic nervous system, GI tract, and respiratory system. It does occur in 60 to 80% of infants with intrauterine exposure to opioid maintenance therapy. However, there are really a lot of ways to mitigate this and make so that less than 20% of infants actually need treatment. And so really encouraging rooming in, breastfeeding, decreasing smoking, cigarettes, all of these things can help reduce the chance. And then other substances can worsen it, and not that they should go off their SSRIs, but just counsel that SSRIs can contribute. And it has no relation to the dose of opioid agonist therapy that they're on. So, you know, I've had patients who have been on sky high doses of like we're talking 150 milligrams 3 times a day of methadone, and baby had no neonatal withdrawal. So it really has no correlation to the dose of opioid therapy, and really has a lot of correlation with genetics and other things. So just really encouraging, as Bonnie would say, her compassionate model. We know that breastfeeding is very important, not because the breast milk has the opioids in it, but because there's very minimal quantities in either methadone or buprenorphine, but that just the skin to the skin, the decreased catecholamines, the decreased stress reaction for both mom and baby. We know that the benefits a multitude, with a 30% decrease in the development of neonatal withdrawal, 50% decrease in neonatal hospital stay, improved parent-infant bonding, and it really is a positive reinforcement for parental recovery. So I have patients that I have this one patient that took care of, it's like 17 years ago, and she is now this force to be reckoned with in the state of Hawaii. And she said, one of the things that kept her sober was the ability to breastfeed. And so really encourage that if at all possible. I'm going to skip just methamphetamines because we're running out of time, but it just know that it can cause a lot of issues in pregnancy, obviously. And then so that's how I got started. Taking care of pregnant people with substance use disorder is taking care of a woman who was using methamphetamines, who had not disclosed her use prior. And I went to the president at the time because she was very afraid of child welfare involvement. And I said, I trained at the University of New Mexico with Angela, and we had Milagro Clinic. And I'm like, so where's the clinic that I can send these patients to? And he looks at me like I have a third eye. And I'm like, oh. And so that's why I started this clinic. And it's housed on the campus of a residential treatment center. So we weren't directly affiliated, but we had a really good relationship. And so patients could go back and forth. And it was really based on harm reduction principles. We actually did very little drug toxicology. I did that very little, I asked them about sobriety, but not really, how much did you use this week? We really focused on prenatal care and using these principles. And I came across this from Shiwei program in Vancouver, Canada, because it's a great harm reduction model of prenatal care. And really what you're aiming for is improving nutrition, decreasing smoking, decreasing alcohol and drug use, encouraging breastfeeding, promoting dental health, encouraging physical activity. I'm supposed to unmute myself? Oh. Okay. Encouraging early and continuing prenatal care. I don't think I have to tell this audience that. But what we did find that if women stopped use, when we looked at our past clinic data, women stopped use at any time during pregnancy. Thank you, sorry. They had normal pregnancy outcomes. So, and we know that other studies have shown that prenatal care ameliorates the complications of substance use. We had a contingency management program for our women who use methamphetamine because it has one of the largest effect sizes of any intervention done in SUD treatment. And there's no real good medications for methamphetamine use, which is the #1 substance used in Hawaii. So we had a March of Dimes funded program, which would reward patients for coming to prenatal care, group therapy. We called our groups class. We had classes instead of groups. So they had they would learn about child care and stress reduction and breastfeeding and things like that. And then they'd have a chance to process afterwards. So we give them rewards for that. instead of, we didn't do the traditional urine toxicology for contingency management. And then just ending on the stigma and just out more hopeful things that we can do to stop stigma. We know that substance use disorders are the most stigmatized medical condition. When they studied it, it's more stigmatized than even mental health. And pregnant people with SUD are even more stigmatized. Some of the language in the media really serves to promote that. And so we really need to argue against, saying things like crack baby or opioids tiniest victims. Work towards in the dictionary, focusing on person first language and DSM-5 terminology. So it's a substance use disorder and not substance abuse. And the reason, and so these are just some terms to use versus not use. How language matters. This study was done in 2010 with doctorate level addiction care providers and mental health providers. They presented case scenarios which were identical to the different groups. And one scenario was labeled substance abusers, and the other one was labeled a person with a substance use disorder. And the scenarios with that were labeled substance abusers were much more likely to be judged as deserving punishment than the exact same scenarios of the people with a substance use disorder. So that's why language really matters, even amongst ourselves. So some of the takeaways, just attempts to limit reproductive rights and punish drug use often intersect in public policy, suggesting a similar lack of understanding of science. Prenatal care ameliorates complications from drug use, and barriers to obtaining it must be removed. Addiction in pregnancy, especially opioid use disorders, but even stimulant use disorders, can be treated effectively. And stigma and discrimination will increase the risk of pregnancy complications and worsen maternal mortality for those who use drugs. My puppies. My mental health.
One thing while people are formulating their questions, I wanted to just note that yesterday was our cardiac COAP annual meeting, and so we had a number of presentations and looking at the data for cardiac surgery and interventions, and there was some data on substance use disorder screening for cardiac surgery, almost 100%. I mean, like it was very rare to be less than 95%. And it really struck me because I had just put those slides in the deck for Angela to go through, and I was like, there's quite a difference here. And so clearly the complexity of how it relates to the pregnant people population versus those that are facing cardiac surgery is very, very different. So somewhere in between seems like the way to go.
Of course, the cardiologist didn't say that those are elective procedures and they can deny giving somebody a new valve or bypass surgery. If you're pregnant and you're going to have a baby, and we need to treat women with substance use disorders,
Can't coerce them into disclosing measures.
Thank you for your presentation. I actually had a question for you. I was seeing in your slides that there's information about how patients will use substances to lose weight. And I was just curious, in your practice or in research, if you're seeing with Ozempic coming into play here and having difficulty in accessing these weight loss medications and potentially transitioning, have we looked into that research yet, or is that kind of an up and coming area?
I think it's definitely an up and coming. We know anecdotally, and I have family members on it who have done extremely well and stopped drinking. So there's definitely, I think, some very promising avenues down the road. I think the indications for the GLP-1s are going to skyrocket with treatment of addiction. Oh, sorry.
Quick question.
question from the OB-COAP perspective. I think a lot of this is we're looking at our data internal to multi-care. Some of it, at least from the registry perspective, I don't think we collect data for long enough after the pregnancy episode to pick some of this up. Not that I want to like sign up to have to pay for more FTE to collect data, but I think that's one of the barriers that we see internally is that we look for that 30-day readmission and then that's it. And I think a lot of this can present after that. And a lot of the other registries we support, we do, 6-month, 1-year, 2-year follow-up. So just curious from the OB-COAP perspective, if that's something that you're thinking about, because we do miss things when we're looking at the data with like Sergo Health. Some of the items that you're mentioning are just, we're not going to be looking at those charts anymore to collect that data. So.
Yeah, and the studies have shown that it really peaks in 9 to 12 months, and even like after a year. So. More reasons we need to continue providing care longitudinally. Women are not just their pregnancies.
Globally, that makes it sound like we're not trying. We are trying. We are trying, but I think that we're not identifying the high-risk patients and assigning them for proper follow-up, right? Wouldn't that be a better use of resources to not, to really say, we're going to identify the patients who are at the highest risk of using, having a relapse, those who've been separated from their babies, and just really assigning a community health worker to follow those patients. I would love it if we had registry data for every hospital followed out to 12 months postpartum, but that's a pipe dream, but I hear what you're saying, but I think what we've seen is that during even the episode of pregnancy care, we're just not doing the best job in screening. And I think there's so much fear about getting reported that I don't know how much honesty we're really getting. And then there's just so little trust of us, as providers to do the best by that dyad that I always wonder, like, are we screening enough? Are we really doing the best thing? So, but yes, we would love to follow data all the way out to the year. It would be amazing.
Yeah, patients have very legitimate reasons for not telling us their use if they worry about getting arrested every single state but one has arrested a pregnant person for a pregnancy outcome, including 2 pretty high profile cases in California recently. So. Well, that was sobering. Sorry about that.
Anything online, Emily? Nope.
Okay. Yeah, thank you.
I was going to quickly add and let people know in the room, and Vanya Rudolph, that name came up a couple times during this presentation. She and some people in the state are working to develop a perinatal behavioral health summit. We're looking to host that in the middle of October, if anybody is interested in joining that. Yes, just across the street.
Okay, everyone, we are in the home stretch. Thank you so much for sticking it out with us. And I also want to thank all of our folks who are attending virtually for hanging in there. What a great, amazing day. I work for an organization that has a footprint in 39 states, including the majority of the southeastern United States. And I think it was Amber Weiss said earlier today that said, I live in Seattle, but I have visualization into most of the rest of the United States in terms of healthcare for women. And I can say that we are very lucky where we live and the access to data that we have and the collaborative spirit of the healthcare environment in Washington. That said, we are not complacent and we should never be. And what I hope that you all will take home from your experience today is the understanding of the power of that collaborative voice in healthcare, and with our legislation and with our leaders, and the power of data to drive quality improvement and change. So please have these conversations with your colleagues at home. Talk with your friends and your neighbors at other hospitals that maybe aren't a part of OB COAP, and sing the praises of all the work that is done here and the power of it, so that we can add more data, more sites, more powerful influence of this kind of quality improvement moving forward. So thank you again. Hope everybody has safe travels home. And I think we are, oh yeah, sorry. Now I don't know if it's upside down or not. There we go. Wait. Okay, I was having a phase in. So please fill out the evaluations, and I think there's a QR code on all of your tables for that too, right? You can pull that up. Please, please, please. That really helps us determine what worked well for you, what you'd like to see in future meetings, and how we can make changes that make these meetings worthwhile for you. And we will see you again next year, which will be a skosh earlier than it is this year. So it'll be on May 22nd. So mark your calendars now. And now we will have
to do the raffle.
The raffle. Yes.
Again, this is my medical director hat saying thank you to all of you for being here. Thank you to all of your sites for believing in this data registry data. It is harder work. I think that for a long time, you know, when I hear things like, oh, that's too much work, you know, or we, you know, that's too hard. Well, this is hard. The work we do is hard. And so I think to fix things that are hard, we have to work harder to get the data that we need to really start doing better. So your work is appreciated. On our side, you know, my job, I think, as medical director is try to make the data burden as little of a burden as possible and to help provide you with the data that you need to do great things at your sites and to share back with us. We have 2 sites in Oklahoma, so that's already, you know, pretty exciting. We have 7 hospitals in Texas slated to join us in the next year. So we will now have more data from other states. And part of it is there, you know, I think it's a testimony to how much hard work we've put into OB COAP. By we, I mean you. So we are able to go to other states. We're able to show them this is the kind of data that we have decided is worth it to try to take better care of our birthing people. So we're pretty excited. We hope by next year that when we come back, we will have started collecting data from these 7 sites from Dallas, Fort Worth. So thank you all.
Carl, do you want to pull? And then we'll do the allowed.
Yeah, and then we'll do the clap.
Just pull. All right. All right. The first one I pulled said Carl Olden on it, believe it or not. Esther Chung. All right. Oh, Carolyn Klein, also not here. Oh boy, help me. Zayamar Pokasangra. Am I saying that anywhere close to correct? Tell me the right way. Ziomata. Thank you. You may choose.
Yes.
Lara Blair. Did she leave? Technically, she's not in the room. Susan Rodriguez. Oh, boy. Samantha Piskowski. Did she go? Elizabeth Tinker.
Come on up, Dad.
I can. All right. Her loss is Melissa Cheney's gain. Oh my gosh.
I think she and Lara are together.
Amy Fraser. All right. Amy, you can accept the gift, yeah? Okay. Please come select your bottle, and there'll be one left for Anna Humphrey.
Oh, she left already. I mean, I can take it.
Oh, he's not here. Chelsea Price. We're going to get to Carl Olden before you know it. Emmy Yamasaki McLaughlin. She could have left. Oh, she's not here either.
Pull out your own name and take it home.
Audrey Levine.
Audrey had to go too.
Oh my gosh, I know I saw her. Okay. Kat Wright. Oh, okay. Woo. Congratulations. All right, and now, do you want to pull?
Do the last honors here.
Okay, so this is for the $500 gift card, Alaska. What do you need?
I was just gonna put it on that last little slide so you see. Oh, other way.
Wait, no, that's the. See, it's got this.
There we go.
It's got this slow phase, and it makes it feel like you haven't done the right thing.
All right.
Okay. Am I done?
Yeah, go ahead. So much pressure.
Hannah Wirtz.
Wow.
Congratulations. So you will reach out to Hannah?
Yeah, I will send an email with the info. So.
Okay. Congratulations, everyone. Safe travels home. And thank you to everyone virtually. Have a great evening.
Good job, everybody.